Good morning. I'm calling to order this public oversight roundtable on the implementation of the District of Columbia Health Benefit Exchange. I am Council Member Yvette Alexander. I represent Ward 7, and I also chair the Committee on Health. This oversight hearing is the oversight of the Health Benefit Exchange Authority. Today is Monday, May the 13th, 2013. The time is approximately 11:40 a.m. We are in room 123 of the John A. Wilson building, and I am joined by my colleague, Council Member at Large David Grosso, who is also a member of this committee. The D.C. Health Benefit Exchange Authority was established by the Health Benefit Exchange Authority Establishment Act of 2011. The mission of the D.C. Health Benefit Exchange Authority is to implement a health care exchange program in the District of Columbia in accordance with the Patient Protection and Affordable Care Act, thereby ensuring access to quality and affordable health care to all district residents. The Health Care Exchange Program will enable individuals and small employers to find affordable and easy to understand health insurance and assist small employers in purchasing qualified health benefit plans for their employees. The exchange will facilitate the purchase of qualified health plans and assist individuals and groups to access programs, premium assistance tax credits, and cost-sharing reductions. This will be the third roundtable on the implementation of the Health Benefit Exchange that I have held since my appointment as the chair of this committee, since January of this year. We have covered many topics at these roundtables, and my goal has been to maintain ongoing public dialogue with board members and the public regarding multiple policy and legislative decisions that we have to make on an accelerated basis due to the fast approaching October 1st, 2013 enrollment deadline. One of the things that we've been focused on are the legislative recommendations that the board has worked on over the past several months, which reflect the input of numerous stakeholders and advisory groups. Those recommendations were reflected in a bill entitled Better Prices, Better Quality, Better Choices for Health Coverage Amendment Act of 2013 that was submitted by the chairman on behalf of the mayor on April 11th of 2013. Given the short time frame in which the council must consider and vote on this legislation in order to meet established federal deadlines, we will postpone a formal hearing on this legislation until a later time. I plan to move on a version of this bill on an emergency basis for consideration at the next legislative meeting, and I believe that's May 22nd, correct? May 22nd, next week. I want to emphasize that while this roundtable is not a substitute hearing for the bill, I expect that many of you will comment on it today. And I look forward to hearing your testimony. Before I call up the witnesses, I will ask that my colleague on the committee, Councilmember Grosso, be recognized for opening statement. Good morning.
Good morning. Thank you very much, and good morning, everybody. I just want to say quickly before we get started here that there's been a lot of speculation about how I feel about this, and I think people should kind of understand where I am. And before you start, I'm here to listen and learn and understand your positions on it. I've had a lot of folks come in and talk to me about it, and even had a well-organized meet and greet where I got to speak to a lot of people for several hours one night. The way I feel is that we need an insurance exchange. I support this. I think it's the right way to go about doing things. I support it for a lot of good reasons. One of the most important is that we'll get the federal subsidy through the exchange. That's the way it's set up. I am still very hesitant about, well, let me start by saying I believe that we're trying to put the exchange in a position to succeed. We've been supportive at the council. We've done procurement legislation. I've met with the director several times, and I think it's important that we continue to move forward and be successful in the exchange. That in and of itself is, I think, a pretty tough task, and I've said that publicly, and that's why I think we have to be supportive. I am hesitant only in the merger of the outside and inside market, and I've stated this as well. I have not been convinced yet that that is a good idea. I can tell you that I understand the reasons, at least to this point, why people are requesting that we do that and why it was the recommendation that we do that. But I'm hesitant to support it because I just don't feel or don't have the confidence that if it doesn't succeed, if the exchange is not successful in the fall, that we're going to have a quick plan to back out of that and be able to answer to our residents and when they're trying to struggle to find insurance coverage. So, I may be a little selfish here, but I know that if I vote for the merger of the markets, the people of the District of Columbia, if they have and when they have a bad experience on the exchange, are going to come to my office, not going to go to the insurance exchange's office. They're not going to go to the mayor. They're not going to go anywhere but to me and my colleagues and say, hey, why are you making us do this? Why don't you let us choose this? So I think it's the responsibility of the council to do what we can to be as helpful as possible to make it a success, but also say, wait a minute, slow down here a little bit. Let's not be too hasty in our decision to combine the markets. Let's let it play out and then combine the markets. I understand that the chairwoman is working on this issue as well and is very concerned about it as well. And I think the testimony today can speak to these issues. And hopefully you guys can convince me one way or the other depending on your position. So with that, I look forward to the testimony.
Thank you. I'll call up my first round of witnesses. Please ensure that you push the button one time and the green light will come on. And also, if I don't have a copy of your written testimony, you may provide it to my staff over to my left. And we will begin with 3 minutes per person. We have a long list of witnesses this morning. Our first witness, Stacy Pace, from the Pace Group, PLLC. Dr. Richard Bebout, Chief Clinical Officer, Community Connections. Julie Gallion, Senior Human Resources Consultant, Nonprofit HR. Good morning, and please make sure your green light is on. I do have a copy of all of your testimony, and you may proceed, Ms. Pace.
Thank you. My name is Stacy Pace. I'm an attorney and a Ward 7 resident. I own my own practice, Pace Group, which focuses on consumer finance issues in downtown D.C. I received my J.D. from George Washington University, and I also attended Cornell. I support the HB Act's legislation to create a unified consumer-friendly insurance marketplace in D.C. As a sole proprietor of a law firm, I currently purchase health care coverage on the individual market. However, a friend of mine similarly situated was denied. She had what appeared to be an irregular exam. It turned out to be nothing important, but she was denied coverage. I could have been in her similar situation. This is something that is difficult for me in my practice. It's an expense that I really cannot account for. I can't plan for it. Under the proposal for our unified market, I will no longer be alone in the insurance market, but will be part of a larger pool, combining our purchasing power so that we will have lower, fairer premiums. I look forward to the opportunity to purchase coverage through the exchange, knowing that it will have strong protections for me as an individual consumer. I know that there will be transparency with the ability to compare all the plans in the individual market so that I can choose the plan that best meets my needs. With easy comparison of plan designs and quality, this is something that I can count on. Without a unified market, I will be in a similar situation to where I am now, left to the whims of insurers, unable to know what is the best plan for me. And when my practice grows, I want my future employees to have the same protections through the small business exchange. I also want to see the district health exchange work so that other citizens of the district, some of them my clients, will have access to affordable, comprehensive health care. My firm, as I said before, focuses on people helping to get their personal finances in order. And what I see day to day is that most of the people that come to me to file for bankruptcy or other protections, most of the time, it's not because they're lazy, it's not because they're irresponsible, it's because they are having a combination of a loss of job and they have a medical disaster within the family. There is very little that you can do if you're an average person that has a regular wage when you receive a bill for $30,000, $40,000, or $50,000. This is something that's unacceptable. This also impacts their ability to maintain their homes. It affects their stability in every aspect of their life. This new insurance exchange would otherwise be, without this exchange, they would be unable to meet these needs. They would be, because they are unable to afford coverage without the premium tax credits and might otherwise have medical debt, which many of my clients do. These benefits through this system should be something that DC families can count on.
Thank you for your testimony. Dr. Bebout, good morning.
Good morning, Chair Alexander and Council Member Grasso. I'm Richard Bebout. I'm Chief Clinical Officer at Community Connections, the district's largest nonprofit public sector mental health provider. I'm also President-elect of the DC Behavioral Health Exchange Association and a resident of Petworth in Ward 4. Community Connections provides services to more than 3,000 adults annually and roughly 500 children, historically almost exclusively those in the Medicaid and Medicaid MCO worlds. For providers like Community Connections, the Health Benefit Exchange, especially with the mental health parity and the strength of the network adequacy measures, represents a real watershed moment that can dramatically change where our services fit within the city's healthcare architecture. I'm not sure that any of you should care what it does for my agency, except that it will strengthen our ability to provide services to people who might otherwise fall into the public safety net, and it spreads that risk. If commercial plans begin offering substantive outpatient benefits, providers in the public sector will be able to provide robust services to many more among the working poor and middle class who are currently unable to afford high copays or essentially have to pay out of pocket to people in private practice on Connecticut Avenue. Those individuals will benefit, and private insurers will have skin in the game in preventing individuals from falling into the public safety net because they have to guarantee the existence of an adequate network. Again, I want to applaud the work of the Health Benefit Exchange Authority and the many work groups, the impressive body of work that they achieved in just a few months. I especially want to applaud, again, the issue of mental health or behavioral health parity that is built into this legislation, the requirements for meaningful network adequacy so that people have real-time access to needed services. And again, it's not because strictly because of the behavioral health benefits that people need, but because behavioral health issues are such a dramatic multiplier of other health care costs when people do not have adequate access to behavioral health care. The last thing I actually want to say is that if I have this right, and I'm not certain that I do, but that it's distressing to me that in front of us is the possibility that the district won't take charge of its own fate and will instead invite federal government to again control this key element of our government and our economy. Thank you.
Thank you for your testimony. Good morning. You may proceed.
Good morning. My name is Julie Gallion. I'm a senior human resources consultant and benefits practice lead for Nonprofit HR. Nonprofit HR provides human resources outsourcing and consulting services to nonprofit organizations in Washington, D.C. Our clients consist of nonprofit organizations with 200 to 200 employees throughout the D.C. metro area. We are the human resources department for 8 nonprofit organizations in D.C. for whom we manage employee benefit plans. Thank you for allowing us an opportunity to express our opinion on the issue of allowing small employers to continue purchasing insurance outside of the DC Health Benefits Exchange. We appreciate your willingness to hear the perspective of small employers and their employees who will be affected directly by this change. Nonprofit organizations throughout Washington, D.C. compete against large for-profit organizations as well as the federal government to attract and retain skilled employees. To remain competitive and consistent with their mission to serve others, nonprofit organizations generally offer rich health insurance benefits at a low cost to the employee to offset the generally low salaries provided to their employees. In fact, most of our clients provide platinum-level benefits at low cost to employees, and some adjust their health insurance offerings and cost-share arrangements to meet the unique needs of their employees. Our clients work hard to ensure the preservation of their health insurance plans and health insurance choices made available to their employees. These plans are chosen carefully based on their organization's budget and the complexity of the plan administration, as well as the needs of their employees and their internal culture. Because so much about the DC Health Benefits Exchange is unknown, we are not confident that the same level of benefits will be available at an affordable price to our client employees through the exchange. We serve as a resource for our client employees to ensure claims are paid appropriately by the insurance carriers. My work in this area often results in adjustments to claims that were either paid incorrectly by the insurance company or coded incorrectly by the doctor. I am concerned that the employers purchasing insurance through the exchange will lose the ability to fully support participants in the resolution of insurance claim issues. We do not believe that purchasing insurance through the exchange will improve the insurance plans that our clients offer to their employees or reduce the employees' cost for health insurance, as is the intent of the Affordable Care Act. In fact, we believe this change may make managing the health insurance plans more complicated. I wanted to take a moment to offer some suggestions for solutions to the closure of the small group market. Please consider reducing the size of the employer who is required to purchase insurance through the exchange. We find that nonprofit organizations with 20 or more employers are able to offer rich health insurance plans to their employees with employee choice at a reasonable premium, largely paid by the employer. However, true small groups with 2 to 19 employees have a more difficult time and would be more likely to benefit from purchasing insurance through an exchange. Consider putting in place a waiver program to allow small groups whose health insurance offerings match or exceed what is available in the exchange to continue providing that same insurance to employees. It appears that many assumptions are being made as to what small groups in D.C. are providing to their employees and at what cost or what our cost-sharing arrangement. These assumptions are leading to the board to believe that somehow employees will be better off purchasing insurance through the exchange. Our experience with the nonprofit sector suggests otherwise.
Thank you. Thank you all for your testimony. After a brief round of questions from me, I'm going to recognize Councilmember Grasso for questions, and then we've also been joined by another colleague that serves on the committee, Councilmember at Large David Catania. I'm going to recognize him after you, Councilmember Grasso, for opening statement and any questions that he may have. Thank you for your recommendations, Ms. Gallion. We are looking into all of these considerations, so it's greatly appreciated. But the size of the employer, you feel the group that's mandated right now is too large?
Definitely, yes.
Of a group. I would like to ask you, Ms. Pace, because you are in favor of the legislation as it is, what is the size of your business? How many employees?
I am the only attorney, and this is actually an issue that a lot of small firms face. And the main reason is it's healthcare. When we have more cases, when we have more work, we take on employees, but they're as independent contractors, because we're concerned with the way the economy now is in the legal market, that we cannot afford to take on the healthcare costs as they currently are if we bring someone on as a regular W-2 employee. So we do $299.
So with this legislation, you'd be able to
Yes.
grow your business?
It would be something that we can, it's something that we could have more information to plan more. For when we bring people on, we know we have a better understanding that we can provide coverage. There isn't going to be one person that would make the healthcare coverage exorbitant. Right now, it's very risky to bring people on. We even if we like the person, we like the work, there's always that risk that the healthcare coverage and the costs, it might put us out of business.
Thank you. Point well taken. And Dr. Bebout, were you a member of the working group?
I was not.
With regards to?
I was not.
Okay, but your input, someone heard you with regards to mental health parity. So I do appreciate all of your work, and thank you for your testimony.
Thank you.
And Councilmember Grasso?
Thank you. I don't really have a lot of questions. I think I would like to note, Ms. Pace, that starting January 1 of next year, there will be guaranteed issue requirements for all insurance companies. You will not be allowed to be denied. And that's true whether or not it's in the exchange or outside the exchange. So just so you know, in the
Yes.
future, your friend won't have that problem. They will be covered no matter what. I think that's important to keep in mind of. But thank you all for your testimony. You heard my opening. I agree that some kind of slowdown of this has to happen, whether it's small groups. I actually think it's for individuals as well. Should not be mandated to go into the exchange at this point. So thank you.
Thank you. Councilmember Catania?
Thank you very much, Madam Chair. I appreciate your vigilance on this subject and the frequency of the roundtables that I think are so important. This is a groundbreaking, step that we are taking here in the district. I'm particularly proud of the efforts the district has taken thus far in implementing the Affordable Care Act, and particularly proud of having authored the legislation that brought the health exchange to the district in a way that will have us manage it ourselves as opposed to going into the federal system. Madam Chair, I share the concerns that will be raised about the potential costs for our small employers and our individuals as we go towards a closed system. I do, though, believe that in the end, a closed system where all insurance companies are required to place their products on the exchange, where consumers can shop, is in the best interest long term of our residents. The issue, is the unknown, and the fear is that we will have, as we will hear today, individuals are fearful that the requirement of having all small plans go through the exchange will lead to a cross-subsidization or increase in rates for those who presently enjoy smaller individual plans. The idea that by having additional individuals who perhaps for a long time have not had insurance or health care to be added into these small plans will increase costs on those who presently have insurance and perhaps force some of them out by virtue of that increased expense. Madam Chair, I think we've been cross-subsidizing individuals in health care forever in this country. It occurs across this country where those who are insured pay higher amounts than those who have public insured policies in an effort to pay for the charitable care that happens in nearly every hospital in this country. So let's not kid ourselves. Cross-subsidization occurs. The issue is, how do we go forward in a way that is that eases some of the concerns raised that are legitimate about the unknown in terms of price increases, and yet at the same time be faithful to the Affordable Care Act. Madam Chair, if it's all right with you, I'd like to put on the record the four corners of the amendment that I hope that we will be working on together. We will introduce along with this measure for the closed system, and so that we will accomplish two things. Number one, we will make sure we have at least a 2-year period of ramping up, for lack of a better term, and to constantly reevaluate to make sure we're doing this right. But at the same time, I think the biggest concern we will hear today will be about the unpredictable increases in insurance for our small and individual plans. And so, Madam Chair, if I might, I'd like to just mention what I'd like this amendment to look like. Essentially, what I will propose is an amendment that requires the insurance commissioner to expressly approve rates that exceed a stated threshold. Specifically, the amendment, as we are currently drafting, will provide that with respect to plans for individual and group markets, the commissioner can approve a premium rate increase for plans offered in 2014 if the rate increases are actuarially sound, in the best interest of consumers, and not excessive, inadequate, or unfairly discriminatory, and 3, based upon reasonable administrative expenses. Starting in 2015 and beyond, For certain rate increases, the Commissioner must expressly approve the rate increase. Specifically, the Commissioner must approve all rate increases that, quote, increase premium rates by more than the average annual health spending growth rate stated in the most recent National Health Expenditures Projection, published by the Centers for Medicare and Medicaid Services of the United States Department of Health and Human Services. However, beginning for 2015 rates, before the Commissioner can approve or disapprove premium rate increases, and this is very important, there must be a 30-day comment period on the proposal. The Commissioner must hold a public hearing on such a rate increase. Beginning for 2015 rates, before the Commissioner can approve or disapprove a rate increase above the amendment's threshold, the insurer must provide certain information to the Commissioner, information that is currently provided in statute. However, the Commissioner has discretion to, by rule, require insurers to provide additional information. In determining whether a premium rate increase is in the best interest of consumers, and not excessive, inadequate, or unfairly discriminatory, the Commissioner may consider the following: the insurer's financial position. The amendment is drafted so that an insurer's overall financial health can be evaluated, not just as it relates to a particular small plan. The Commissioner can consider the insurer's profitability, surpluses, revenues, and investment savings. Historical and projected loss ratios between the amount spent on medical services and earned premiums, any anticipated changes in the number of enrollees if the proposed premium rate is approved, changes to covered benefits or health plan design, changes in the insurer's health care cost containment and quality improvement efforts since the insurer's last rate filing for the same category of health plan, whether the proposed change in the premium rate is necessary to maintain the insurer's solvency or to maintain rate stability and prevent excessive rate increases in the future, any public comment received through the public comment period and hearing. The insurer bears the burden of proving that providing premium rate increases exceeding the average annual health spending growth rate as provided in the subsection B related to the plan beginning 2015 are actuarially sound, in the best interest of consumers, and not excessive, inadequate, or unfairly discriminatory, and based upon reasonable administrative expenses. And Madam Chair, I realize I'm out of time, but I just want to complete by saying that the amendment as we are currently drafting would provide that within 10 days after a public comment period, the Commissioner must provide written notice of his or her decision to approve or disapprove premium rate increases to which this amendment applies, and at any time the Commissioner may rescind his or her approval. Finally, the Commissioner must annually produce a report relating to health plans offered in the individual and small group markets in the district, which at a minimum the market report will provide: 1. All plans participating in individual and small group markets. 2. Premium rates offered by plans in the individual and small group market. 3. Average annual rate increase in the small group market. 4. Average rate increase in the individual market. And finally, the financial status of health insurers participating in the individual and small group markets in the district. Madam Chair, I appreciate the additional time you've given me. Again, this is going to be an opportunity for our staffs to work together to perfect this, and I think play defense against what many people are fearing, which will be out-of-control rate increases. It provides an affirmative obligation for our insurance commissioner to assist and play defense in that. I think these measures combined, I hope, will alleviate some of the concerns raised here today. Thank you very much for your leadership and for your vigilance on this subject.
Thank you, Councilmember Catania. You know, and I'll be the first to tell you that the Insurance Commission has a lot of work to do when it comes to rate filings. I don't think they've been as aggressive or as vigilant as they can be. So I definitely look forward to working with you on that, and would be interested, to work with the Commissioner, because I know that there will be some fiscal implications with this legislation as well, but definitely, or with your amendment, but definitely it is needed. So I do appreciate that, and I look forward to working with you. Thank you all for your testimony. Our next panel of witnesses, Ms. Barbara Lang, the Chief Executive Officer of the D.C. Chamber of Commerce, Kevin Dougherty, Vice President, Programs and Services, National Multiple Sclerosis Society, National Capital Chapter, and Peter Rosenstein, Executive Director of the American, sorry. I'm sorry. Ms. Rivlin, are you on the witness list? Yes, you're, I'm sorry.
Number 6.
Right, he was, sure, Ms. Rivlin, go right ahead. She knows the routine. I am so sorry. Senior Fellow of the Brookings Institute. Let me see. And you will be next. Good morning. Ms. Lang, you may proceed with your testimony.
Good morning, Madam Chair and other council members. I am Barbara Lang, and I'm President and CEO of the D.C. Chamber of Commerce. I'm pleased to be here today on behalf of the 1,700 plus members of the Chamber, the hundreds of thousands of employees they employ, and thousands of health insurance policies they currently have for their employees. We appreciate the opportunity to testify on Bill 20-240, the Better Prices, Better Quality, Better Choices for Health Coverage Amendment of 2013, and the status of the District of Columbia Health Benefit Exchange Authority. As you know, Councilmember Alexander, the Chamber has been actively involved in supporting the successful implementation of the exchange and participated in the discussion and development process of the exchange since the very beginning. We're pleased that this legislation reflects some of the compromise that was required to address the concerns of all stakeholders. We are on the record previously of supporting an open marketplace. However, in the absence of a dual marketplace in 2016, we still support a true 2-year transition phase-in for small group plans. The transition proposed is not actually 2 years, giving small group plans between 13 and 23 months before being required to enter the exchange. Instead of the proposed approach, we would like small group plans with 2 to 49 employees be transitioned through 2017, or at the very least in alignment with group plans that represent employers with 50 to 100 employees. We urge the Council to amend the bill to include a full 2-year transition that does not completely close off the exchange market until January 2016. We have only a few other comments. We support the legislation's recommendation for unlimited qualified health plans as long as an insurance carrier does not try to flood the market with indistinguishable plans. We believe in the flexibility. In general, we do not support the exchange going beyond federal mandates while in its infancy, and I think that the exchange has said to us that they were not planning to do that. Since we last testified, significant progress has been made for major policy decisions to get the exchange through to 2016. We have only a few months left, so we still think that there is a lot of work to do, and I think everybody would agree with that. Key area of the exchange implementation where the Chamber has some concern is with the education of small businesses about the exchange. Some, but not all, small businesses can turn to a broker to learn about what changes are coming. We assume that a concrete education and outreach plan on how the exchange will effectively educate small employers is being developed, and Ms. Kaufman has said to us that that is happening. So much of the exchange attention has been focused on getting the uninsured individual covered on the exchange, but not enough attention to the small employer. Employers cannot make decisions if they don't know the cost. After months of conjecture on what insurance companies will participate and how much plans will actually cost, we are not far from finally getting answers, and we want the exchange to be ready to hit the streets and talking to our small employees. My testimony is much longer, and you have it for the record. But let me just say finally, I mean, we've got two issues, and that is the transition period and the education of small employers we think is absolutely critical. Finally, we'd like to point out the tremendous time and effort that the Exchange Director, Mila Kaufman, and her staff have placed in getting this agency off the ground. The last couple of months have been hard on the stakeholders as we try to keep up with all the necessary policy decisions for the infant agency. Mila and her staff have been working right alongside all of us to make this exchange successful, and we thank her and the Exchange Board for that. I thank you for the opportunity to testify, and I'll be glad to answer questions at the end.
Thank you for your testimony. Good afternoon.
Good afternoon. Good afternoon, Madam Chair and members of the Committee on Health. My name is Kevin Doherty. I am Vice President of Programs and Services at the National Multiple Sclerosis Society National Capital Chapter, a member of the DC Health Benefit Exchange Standing Advisory Board, and a 20-year resident of the District of Columbia. Multiple sclerosis is a chronic, unpredictable, often progressive neurological disease. It has no cure and must be managed through a spectrum of preventative, medical, rehabilitative, mental health, and long-term services to help affected individuals and their families. The National MS Society supports the full implementation of the Affordable Care Act because we believe it will make great strides towards achieving needed improvements in health coverage and care for people who live with MS and other chronic conditions and disabilities. We believe that the health insurance marketplace in DC should be transparent, publicly accountable, and consumer-friendly and affordable. The National MS Society strongly supports the work of the DC Health Benefit Exchange. Over the past several months, the policy decisions of the Health Benefit Exchange Authority, under the governance of its executive board, have been made through a transparent public process involving diverse stakeholders, including patient advocates, physicians, other health providers, insurers, insurance brokers, employers, concerned citizens, and more. I was privileged to participate as vice chair of the Essential Health Benefits Working Group. The board has voted to create important standards for all health plans sold in the individual and small group market, including 100% parity for mental health and substance abuse services, which means behavioral health services will be equivalent to other health services. People living with MS often experience clinical depression and anxiety disorders. Insurers will not be able to substitute one benefit for another, which will help ensure consistency across plan. Drug formularies will be required to cover at least one product in each class of drugs offered in the district's benchmark plan formulary. The exchange bill that has been introduced in council will require that all insurers selling the individual and small group insurance plans post their prices, benefits, quality ratings side by side on the exchange website. This consumer-friendly portal will help people make more realistic comparisons between plans and informed decisions about the coverage that they choose. By unifying the individual and small business market within the exchange over the next few years, the district will increase the pool of people purchasing insurance and will create better competition, transparency in the marketplace. That's going to be needed to help drive down costs, improve quality, and helping to make premiums more affordable for those living with chronic illnesses such as MS. The National MS Society looks forward to our continued work with the district's Health Benefit Exchange Authority, our community partners, to help with the development and implementation of the exchange and to ensure that the healthcare needs of all DC citizens, including those with complex medical needs, are addressed. Thank you.
Thank you. Good afternoon.
Thank you, Madam Chairman. I'm Alice Rivlin, and I apologize for my excessive eagerness to testify this morning. I was just going by the list. I strongly support this bill. The Federal Affordable Care Act, passed in 2010, is a major step toward an American health care system that covers almost every sustainable cost. As you know, the legislation was controversial at the national level, but the district welcomed it as an opportunity to realize our community's goal of affordable health care coverage for all. And I'm proud of the district for moving ahead, for deciding to create its own exchange, and for doing such a good job. As you know, the district's exchange recently passed the Phase 2 testing with the Southerners for Medicare and Medicaid services. I think we should all be proud of the district for being a leader in this respect. Designing the best exchange for the district has been a challenge because the district's health insurance market is small and highly concentrated. The There are only 4 carriers, one of which controls more than 3/4 of the individual and small group markets. The individual market is especially small, in part because of DC's past success in reducing the number of uninsured residents through generous Medicaid eligibility and the creation of the Alliance. The individual market is estimated to fall below the 100,000 participants that the Urban Institute and others estimate to be the minimum size of a risk pool needed for an exchange to operate efficiently. In view of this small size and high concentration, the District Health Benefits Authority recommended and the Council supported merging the individual and small group markets after a transition period. Merging the markets recognizes that separate exchanges for the individual and small group markets would have too few carriers and too few enrollees to achieve the stability and efficiency that can be achieved in a single merged market. Now the Council is considering whether to make the exchange the sole venue for the purchase of individual and small business health insurance in the district. I believe this measure will maximize competition, transparency, and the insurance choices available to consumers. Retaining a separate market outside the exchange will reduce the risk pool below critical size and invite carriers to attempt to attract younger, healthier individuals and employer groups outside the exchange, leaving higher risks in the exchange. In a small market with a dominant insurer, it's essential that the exchange risk pool be as inclusive as possible, both to stabilize the exchange, which is the only source of the subsidies for those with modest incomes, and to maximize transparency and competition. These decisions are difficult, but I believe the Exchange Board has made the right ones. Thank you very much for this opportunity.
Thank you all for your testimony. Ms. Rivlin, that has been the benchmark, 100,000 at least, for the exchange to operate sufficiently. Under that, what do you think the shortcomings will be if it was less than 100, say about 50,000 persons in the exchange?
You just have less competition, less choices, and the rest that it doesn't work very well.
So it would be necessary, you feel, from your testimony, for small group and individual to be mandated to use the exchange?
I think that's, yes, necessary, at least highly desirable. Transitions are difficult, and you have to worry about that, but I think we would be in trouble if we allowed market to persist outside the exchange.
Thank you. And Ms. Lang, you mentioned the education component, and I know that there's a lot of effort being put into outreach. Have you coordinated with the board at all for businesses to become educated, and what efforts have been made?
Yeah, we are in those discussions with the exchange now. Since we are the largest business organization in the city, in fact in the region, we feel that we have an obligation to our members, but also be very helpful to the exchange on how this is going to roll out. So we are in conversation with Ms. Kaufman, and however the chamber can be helpful in this, we plan to do that.
Thank you. And Mr. Dougherty, you mentioned you were on the working group. Were you in the, what working group were you in?
Essential Health Benefits.
The Essential Health Benefits. Is there a report forthcoming from the working group?
Yes, and I believe it is online, actually, from the on the Exchange website.
Thank you. I don't have any further questions. I want to acknowledge we've been joined as well from another member of the committee, at-large member, Councilmember Anita Bonds, and Councilmember Bonds after Councilmember Grosso and Catania. If they have any questions, I'll acknowledge you for opening statement and any questions that you may have. Thank you. Councilmember Grosso.
Thank you very much, and good afternoon. Thank you all for coming down. I appreciate it. Ms. Rivlin, I'm curious if you could just walk me through this a little bit more. If you have 4 or 5 carriers that agree to go on the exchange up front, you have a federal subsidy that goes through the exchange, so anyone who needs a subsidy will have to go through the exchange already. And then you do a good job marketing it. You do the education that Ms. Lang's talking about. You get out there and do it. Isn't there a federal subsidy for the exchange itself until 2015 that you basically? What year do you have to become self-sufficient?
Yes, but then it has to become self-sufficient.
So, I guess with these things in mind, when we talk about transition, that's really, I think, the crux of the issue for me, is this: how do we do the transition properly? I'm all for it. If the exchange is up and running in a couple of years and is working and, clicking along, doing a great job, enrolling people, paying, making sure they get their subsidies, doing their checks and all, I'm all for them closing the outside market and making it a robust pool of basically membership. But my fear is that, we're doing something new here. And I wonder if that fear I have outweighs the issue that you've raised at all in your mind, that if we do this and we dump it on our on our residents, saying essentially you have to come in January and you have to buy through this, and people have navigated these systems for years, and believe it or not, most people have been able to navigate them. So now they're going to have to do something new. I don't know where to go from there, but if you can just respond to that and tell me your thoughts, what outweighs what in the transition period?
Well, in the first place, there is a transition period for small businesses, and Mr. Catania may extend it, but in any case, I don't understand everything that was said in your amendment, but there is a transition for businesses, and that's a sensible thing. For the individuals, actually there aren't really any of them. It's a small market anyway, and many of them will be eligible for the exchange's subsidies and will have to go into the exchange. Right. So I don't see much downside to saying everybody has to come in.
But with the same logic, there wouldn't be much downside in saying, come along. I mean, it's not a mandate, and I think that's the kind of where I'm bothered by it. If everyone's pretty much qualified for a subsidy, there aren't many people out there in the first place. You do a good job of it, then people are going to come. That's what they're going to do. Why do we have to say you must purchase here? That's my fear, is that you're going to have even just a dozen people mad at me about this. So why is it that we're saying they have to do it, if you think they're going to come in there in the first place?
Well, I think it's better to go there in the first place, but I think the ones that are left out, I mean, it's a shame if they let it in pickles and jars.
Yes, it does. I know that. But that's what I'm trying to make sure to say.
But I think it makes sense to put all the individuals in immediately.
All right. Thank you very much.
Thank you. Councilmember Catania.
Thank you, Madam Chair. The notion behind the amendment that I hope to have agreement on is intended to play defense against the rate increases that I think many in this room fear. Mm-hmm. By way of background, it doesn't seem to be, and it's important that we be fair about this. I mean, we simply can't put restrictions on the insurance industry that are not sustainable, because that will serve as a deterrent for good products to come and serve our citizens. So this isn't a pile on the insurance company as much as it is a necessary, regulatory piece that I think is missing. With the anticipated increases especially for our small businesses, I think I've heard estimates from United Health Plan that they believe that premiums can increase as much as 116% in the near future. For small businesses, 25 to 50%. Aetna is projecting 55% increases on small businesses. I mean, these kinds of numbers send shockwaves legitimately through small businesses, and we have a very underwhelming individual plan market in this city. When Blue Cross Blue Shield owns 80% of the individual market and they propose a 25% increase, it doesn't matter how many are on the actual, if you don't have anywhere else to go, there's no way to play defense against 25%. And I think the amendment that I hope will be accepted as we bring this measure forward is going to say that you can have rate increases, but when you cross the threshold of this HHS standard, it triggers an affirmative obligation for the insurance company to prove that it needs it. Not that it can't have it, but to prove that it needs it. And when you look at the proposed increases, in the double digits, 25, 30, 40%, and you compare it to what in the last 3 years has been our increase, our HHS increase. The last 2 years it's been 3.9%, and the year before that 3.8%. So you start comparing roughly 4% numbers with 40% numbers, and it's obvious that we need a set of eyes to make sure that whatever increase is actually passed, the insurance company bears the burden of proving this, and that it does so pursuant to a public comment period and an affirmative obligation. I think this is fair. And so, Ms. Rivlin, that's what we're trying to get at with this amendment. And it's, we're in uncharted territory, and I think that's why, I support the chairman and her caution about the rollout over 2 years. And this, coupled with some additional regulatory, tools, might actually help present a balanced approach going forward. And, our insurance commissioner currently has quite extensive power as it is. But I want to go a step further and implement affirmative obligations on our insurance commissioner. Because in the absence of these, if we have these, again, with an underdeveloped individual market and with a panicked small employer market, and if there are no mechanisms to oversee these increases, we could have, a very bad situation on our hands. And it does me no good to hear that there are federal subsidies, because I believe we have an obligation to get the best benefit we can for our federal tax dollars as well. And so that is part of our responsibility as a local government to safeguard the treasury that we all fill. So I look forward to this continued discussion. Unfortunately, Madam Chair, I won't be able to stay. I'll have staff throughout. I have a scheduled meeting with our chairman to discuss education policy that will take me from this, but I will be collecting the testimony and reviewing it, so anyone who presents, I'll go through the testimony. And I know that this is a work in progress, and I want to thank everyone in advance for their participation. And thank you, Chairman Alexander, for your vigilance on this subject.
Thank you, Councilmember Catania. Councilmember Bonds?
Well, thank you very much, Chairperson. I am here today primarily to listen to how we are advancing this product, this very important product. I'm particularly interested in the implementation of this product as it relates to our residents and our workers, and would like to really learn more about how we plan on making this work so that those in the insurance industry feel comfortable, and at the same time those residents and employees are comfortable. This is going to be a tough call, it seems, but I believe that we can do it. The transition period that's being proposed is something I'm very interested in, because quite frankly this is uncharted waters. I respect our president and what he has mandated for all of the country, and I think that it works for all of us ultimately, but I certainly applaud my government here in the District of Columbia for standing alone to some degree and saying we're going to create a system that works for everyone, and I'm looking forward to hearing how it's working. I know it's going to take us some time, and I'm just very curious and hope that we can work this out so that those who are insured profit, as well as those who provide the insurance profit. So I'm looking for a win-win, Madam Chair. Thank you.
Thank you. Thank you all for your testimony. And I'd like to call up our next panel of witnesses. Peter Rosenstein from the American Executive Director, American Academy of Orthotists and Prosthetists. Did I get that right?
Orthotists and prosthetists.
Thank you.
It took me 2 weeks when I started to get it right, too, so it's okay.
Darren Kopak, Darren Kopak, President and CEO, Agricultural Retailers Association, National Multiple Sclerosis Society, and Mr. Ron Polak, Executive Director of Families USA. Do we have a copy of all of your written testimony? Thank you. Good morning.
Good morning. Thank you, Madam Council Chair. I appreciate the opportunity to speak today, and I thank all the council members who are here. I have a concern with the bill that was introduced called Better Prices, Better Quality, Better Choices for Healthcare Coverage Amendment Act 2013. I think at this point the word potentially should be put in front of that, since the reality is we don't know what that will be, and we hope it's going to be great. I am unequivocally supportive of the Patient Protection and Affordable Care Act, colloquially known as Obamacare, and of the District of Columbia's plan to launch the exchange, which the federal government is now referring to as marketplaces. My concern has been mentioned before, and that is that as the legislation that was passed by the amendment to the legislation passed by the Council on December 20th, 2011, my lingering concern is that literally thousands of district residents and businesses, those who signed the letter to the Council, are still concerned that approval of this amendment as it is will create a problem. And I have no problem in the long run with creating one marketplace. But as Councilmember Grasso has said, and I know Councilmember Catania and some others, the issue is how long that transition takes. I don't believe that the transition should occur in less than 2 years. And for individuals, clearly, they should not be forced on in the first year. Part of the problem, and I have participated in 2 of the working groups of the Healthcare Exchange Authority, and I compliment the staff and the board for the work they've done. It's been incredible. But the reality is that in a number of policy issues that have come up to date, when they pass them, the board has said, well, that's a great idea, but we can't do it now because we can't get it on the IT system. We have a deadline for that. Therefore, that may go on next year. We talked about pediatric dental care, other kinds of issues. Well, if people are being forced onto the exchange the day it opens, but we already know there are going to be changes to the IT system and information they get in the following year, that's an issue. And I think it's an issue that the Council needs to address. We also know that new IT systems take time. What may be humorous, but it's not in some ways, is board meetings of the authority had to be public anytime they took a vote. But the reality is they took a vote on this transition at a meeting that was announced as a public meeting. It was a teleconference. No one could get into that teleconference. The staff couldn't open the lines. So many of us sat on the phone and online for 40 minutes, could not get into that meeting, and then were told the meeting's over and take a look online and you can read the notes. So that wasn't a public meeting, and that was a teleconference. I think that in the long run, we have to be careful of making sure that everybody has the potential to get all the information they need on these exchanges. I run a small business, though it's a nonprofit, and nonprofits are businesses. I provide insurance for my staff. I want to make sure that they can continue to get the best possible insurance. As I said, I would suggest to the Council at this point that they move the dates of this amendment forward, that for individuals, at a minimum, it's not mandated that they come on in 2014, but rather 2015, and for small groups that rather than 2015, you move it to 2016. That would be the full 2 years. That would give the authority, the public, and everyone the chance to see if this is working correctly. One other thing I suggest politically to the Council, and Councilmember Grasso mentioned it, we all know that there are going to be huge rate increases next year for insurance. Explaining to the public, if you force people onto this exchange now, that the insurance rates aren't the fault of the exchange. They will not be going to the board of the exchange. They will be coming to you. And the insurance increases that we're anticipating are anywhere from 20 to 40%. We don't know what those will be. But it shouldn't be declared that those are the fault of the exchange, because they're not. They're the fault of the essential health benefits package and numerous other things. If you force the exchange to close, you will get the blame for that.
Thank you for your testimony. We're trying to stick to the timeline, but your point is well taken, and I'm going to follow up on this question of the 2-year transition, because I think we're all a little confused about 2 years. I thought 2 years was 2016, so maybe our count is off, but I'll get to the bottom of that. Thank you. Good afternoon.
Good afternoon. Thank you, Madam Chair, members of the committee. My name is Darren Kopic. I'm the President and CEO of the Agricultural Retailers Association. The agenda also says that I'm from the National Multiple Sclerosis Society. That is not the case. I'm only representing ARA, so don't want any confusion there. I represent a small trade association that has its principal office in the District of Columbia.
I did think that was a weird combination.
It struck me as odd also. Our headquarters is here, but we're incorporated in the state of Missouri. We're a national organization representing farm supply dealers and distributors with a full-time staff of 9 people. And there are many organizations like ours with offices in the district. With a staff of this size, we would fall under the requirement to purchase insurance through the exchange no later than January 1, 2015. And in fact, the law or the bill says that that's the only place, the only place that we could buy, issue, or renew coverage would be through that exchange. Over the past several years, we've developed a very good relationship with our insurance broker, who is responsive to our needs, provides us with flexible options for us to compare and to choose our health insurance. Our employees are happy with the coverage we get and the service we receive. The insurance product itself and the broker from which we purchase it are inextricably linked. Both are part of the package we provide to our employees. I'm highly doubtful that we will receive better service, more competitive rates, or better coverage by being forced to purchase our insurance through a government-run exchange. I've been assured that we can continue to work with our broker on our specific needs. But if that's the case, what is the added benefit to us or our employees of being forced to purchase through the exchange? Adding a layer of administration to our existing relationship will come at a cost to someone. That cost has been estimated in excess of $20 million annually. It will no doubt fall on employers and employees eventually. So from my perspective, this bill will cost me more money to employ people and provide their insurance, cost them more to obtain their coverage, and in return we'll get a layer of bureaucratic confusion and in all likelihood poor and less personalized service. The Affordable Care Act does not require the private insurance market to be closed. I would have no objection to a voluntary exchange where we would have the option to compare our current offering to other alternatives, but I object to being compelled to participate and left with no other option. My request, therefore, is simple, that you allow employers like me who are content with our current arrangements, regardless of the number of employees, to continue those arrangements. We've been able to handle this on our own successfully, and our desire is to continue to do so. If the district does decide to force small employers onto a costly and unproven exchange, do not be surprised when our leases are up if you see us begin to exit the district for more favorable conditions in Virginia or Maryland. Thank you very much.
Thank you. Now, from what I believe, if your organization, your business has been with their insurance company, you're grandfathered in from 2010 and previously. So have you been insured since 2010?
We've been insured for a while, but as I read the legislation, it says that it will be, let me grab the quote, on or after January 1, all small group health benefit plans shall be offered and issued or renewed solely through the district's exchange. To me, that says there's no other option.
Now, I believe if you are grandfathered in.
There will be very few grandfathered plans. It's only if you have made no change to your plan since 2010 and your insurance company still offers that plan that you will have a grandfathered plan. But if you've made changes in 2011 or 12, you can't be grandfathered. And if the insurance company, many of them will not offer those plans anymore, then you can't be grandfathered either.
So a change with regards to benefits?
Benefits, provider, whatever they want to do.
And it's highly unlikely that from year to year, businesses do not make changes. Is that correct?
In fact, if I remember correctly, we actually had to affirmatively request to be grandfathered, and we did not do that.
Okay. Thank you. Good afternoon.
Good afternoon. My name is Ron Pollack. I'm Executive Director of Families USA, the national organization for healthcare consumers that has worked for over 3 decades to try to achieve meaningful healthcare reform. And just as a preliminary comment, I'd say I don't simply want to see that the exchange function here in the district simply work in a good way. I would like to see it function in the best way. I think there's an opportunity for the district actually to be that shining light on the hill that will be an example for states across the country. Given the wonderful people who are working in the exchange, Chairman Akhtar, Executive Director Mila Kaufman, and the excellent staff, I think there's a real opportunity to do this. Now, I want to focus my comments on the unification question that Mr. Grasso raised in the beginning. Given the district's small population size, maintaining 2 separate insurance markets, one inside the exchange and one out, would be a highly inefficient and expensive endeavor. Delaware, which is a state that's also grappling with a small population, decided that it had no choice but to turn its exchange over to the federal government. It has a partnership exchange due to fears that the state lacked a critical mass to operate an exchange efficiently. The mayor and the exchange authority have established a reasonable, common-sense approach to allowing the district to keep full control over its health insurance markets despite its small population. By unifying the individual and small group markets in the exchange, the district will not be forced to turn exchange operations, including the website, toll-free call center, navigator, and assister programs, over to the federal government because it is such a small jurisdiction. Maintaining this independence is critical to ensuring that we can meet the D.C. specific needs of individuals and small businesses in our city. Now, Mr. Grasso, you had indicated very thoughtfully that you thought that there would be a natural migration of people to the exchange if you had a bifurcated system because people will be eligible for tax credit premium subsidies. And those tax credit premium subsidies are significant. For a family of 4, goes up to $94,200 in annual income. For an individual, it's $46,000. And by and large, these subsidies are in the thousands of dollars. My problem, however, with the assumption is that as I have seen survey data, focus groups, in terms of people's understanding about the tax credit premium subsidy, the overwhelming majority, more than 3 out of 4 people eligible for the subsidies don't know it. And so if we have folks migrating into a single market, we will not have that confusion. The people who are eligible for these substantial tax credit subsidies will get them. And I'm afraid, among other reasons, that if you did not have such a unified market, a lot of people who need those subsidies to get affordable coverage will not get it.
Thank you for your testimony. So you do believe that all individuals and small groups should go through the exchange?
I do, and I think there are a number of reasons for it, but I thought Mr. Grasso's very thoughtful comment about the subsidies really should be taken into account. My fear is that the assumption that all of us in this room may know that certain folks are eligible for the tax credit premium subsidies really does not adhere to people at large. And I will tell you that 78% of the people eligible for the tax credit premium subsidies right now do not know that.
Well, there's a great effort, and there is, I guess, there are resources available through the Exchange Authority to make people aware of this. It's incumbent upon the exchange to get people out there, to use the exchange, and there's a outreach effort that's going on. So I would hope that the residents of the District of Columbia know about this benefit.
No question, Chairwoman Alexander. It is a very important thing to do, this outreach and public education. But I will tell you that based on experiences of new programs, we've seen this with the Children's Health Insurance Program, with Medicare Part D that provided a prescription drug benefit. It takes a while for people to know the new benefits that are available that had never been available before. And I'm afraid a lot of people will lose out on those significant benefits if we have two different markets.
Thank you. Thank you all for your testimony. We'll have 5-minute rounds of questions. Councilmember Grasso.
Thank you. And, I hear what you're saying. I think that makes some sense. I would argue, however, that our population is fairly unique. We are a highly covered population. Our population is, especially folks that are in the federal poverty levels that we're talking about here, are fairly well taken care of in the District of Columbia. And I think the education effort will be easier here than it is in other states where it's very disconnected, where you don't have very high Medicaid uptake or alliance programs like we have. So we touch this population fairly regularly. And in fact, I think the groups that work with this population will have even greater motivation because of these subsidies to be pushing people that can qualify through the exchange to get them for the reasons you stated. That they can get thousands of dollars in coverage that right now they don't have access to.
Mr. Grasso, you're absolutely right that the district has significant eligibility standards for Medicaid that are unusual and very good. And that puts the district in a better position in certain ways. But I will tell you that the income standards of people who are eligible, even for those folks over 200% of poverty, the percentage of folks who are aware of this is dismally low. And I think despite what will be significant outreach and public education efforts, past programs that have come into being show that it takes a while for people to learn about this. And I'd hate to see people lose these tax credit subsidies in the first year or second year because of a bifurcated market.
Well, I guess the only other thought I have on that, I hear what you're saying. I have a little bit of, it's kind of a little bit of conflict in what you're saying, though. It does take time to get these things up and running, and it takes a lot of education in lots of different ways. And I think I guess you're saying just force people to come into it would get them that subsidy, and that's a good way to go about doing it?
I don't think you're forcing people. I think it's in people's best interest, actually, to do it. But they first have to know about it, and there has to be a lack of confusion. I think if you have a bifurcated market, I think you're going to have a whole lot more confusion than if you have a unified system. And the unified system creates a whole bunch of things in terms of transparency.
Let me just follow up. I think I hear what you're saying. I'm not trying to disagree with you, but do you understand where I get confused? It's if you have people that go, like right now, I would argue there are two different types of individual or two different types of small groups. Some that are very active and engaged in these issues and already know about these options and will go in and do it and have advocacy and support and all that. And then you have the kind of people that don't pay attention to this stuff very much at all, which I think you've hit on pretty well. They're kind of floating through alone. They're dealing with it in other ways. They're just like a lot of people, just not paying attention. Those are the ones I'm concerned about here, because all of a sudden you're going to say, you have to pay attention and you have to go do this, and then they're going to go do it, and they're going to call us and they're going to say, the only place I can buy this is through the government? What are you talking about? Come on, give me some choice outside of the government to buy this. That's where you get what I'm saying?
I think anyone who reflects that notion, it's like the folks who say, keep the government out of my Medicare.
No, I know. I'm not against it. I'm for having the government involved. I support the exchange. I'm not for necessarily mandating that people have to go. It's like if the government decided to open its own coffee shop and said everyone's got to buy coffee from us. Think about it.
All I can tell you, having sat through many focus groups, having looked at national surveys that also reflect the district, I'm telling you that even what you would and I would call high info people do not really know yet the benefits that are available.
True.
I am sure that the district is going to do an extraordinary job with its talented staff, but still, this public education effort is really a very difficult hill to climb.
One last question. Do you think that the District of Columbia should have taken the same route that Delaware took, or was contemplating taking, and let the federal government set up its own exchange?
No, I'm really pleased that the district has chosen to do it on its own, and that the district can be a shining example of what other states could do.
I hope you're right.
Thank you, Councilmember. Councilmember Bonds?
Mr. Pollack, thank you very much. I'm very curious about your description of what you think may not happen, and would want to know more about the kind of outreach program or process that you would have in mind that would inform the public about this tax credit.
Well, there are a number of efforts being made both by the district through the exchange in terms of in-person assistance being provided to people. And there are going to be private sector efforts as well. But right now, there is a huge burden that both the public and the private sector will have to bear in terms of making sure that people understand this very new program that can provide, just in the tax credit subsidies alone, thousands of dollars that could make health insurance affordable when it isn't today.
Okay, and do you have any ideas of how that information could be disseminated quickly to the public?
The Health Benefit Exchange expects to have 150 to 200 people on the ground providing in-person assistance, and there will be additional efforts made to do public education. And those of us in the private sector are creating different mechanisms as well to do this public education. A new organization, Enroll America, has been started simply for the purpose of informing people and making sure they understand the new benefits that will be available to them.
And the federal government hasn't started their efforts yet. They just began this week, and they're 6 months. There's been a great debate of where to take the money in the federal government to do the education.
That's right.
They decided they were not going to do that public education yet. Secretary Sebelius actually said they waited because until someone can actually act on what they're telling them to do, which is until October 1st, they were holding off. So the reality is that many people will know about this on a major federal effort, but it hasn't even started yet.
Yes, as my understanding, it hasn't started also because there's this national fundraising effort.
Right.
In order to
pay for it.
Yes. Okay. Thank you. Thank you, Madam Chair.
Thank you all for your testimony. And I'd like to call up our next panel of witnesses, and I believe, well, if I don't have your copies of your testimony, please provide them.
Thank you.
Mr. Wayne McGowan, Executive Director of the District of Columbia Insurance Federation. Ed Lazier, Executive Director of the DC Fiscal Policy Institute. John H. Graham, is Mr. Graham here? John H. Graham, is that Lee V. Bethel, President of Comprehensive Benefits Services Incorporated. Good afternoon. And I have a copy of your testimony. You may proceed.
Thank you. Good afternoon, Chairperson Alexander and members of the Health Committee. My name is Wayne E. McGowan. I represent the District of Columbia Insurance Federation, a state insurance trade association whose members provide property, casualty, life, and health insurance products and services in the District of Columbia. On behalf of the DCIF, I offer the following remarks with regard to the District of Columbia Health Benefit Exchange Authority and its continuing efforts to implement the Affordable Care Act. The DCIF commends the members of the Exchange Board for their diligence in providing a pathway for the implementation of the Affordable Care Act. We applaud the efforts of the DC Committee on Health, under your leadership as chair, to ensure that that pathway is fair, effective, and well serves the district's health insurance consumers. Toward that end, we encourage this committee and the Council of the District of Columbia to require that such pathway be constructed in a way to ensure an exchange marketplace that, 1, promotes meaningful choice, 2, provides enhanced benefits, and 3, builds a competitive private health insurance marketplace. Currently before the Council is proposed legislation intending to achieve these three objectives, B240, the Better Prices, Better Quality, Better Choices for Health Coverage Amendment Act. It is our view that this is an excellent beginning, but we believe that it falls short in its current form of encouraging an environment in which these objectives can be successfully met within the timetable established by this initiative. Most specifically, small employers are currently providing coverage for their employees would be granted a transition period, which we believe is inadequate. A transition period after which coverage would be required to be purchased exclusively from the exchange. While we support the establishment of a health benefit exchange as a government facility to supplement the existing private insurance marketplace and primarily intended to serve the uninsured, we have concerns with the proposition that it should so quickly replace it. The DCIF does not oppose a plan to bring the benefits of the federal health care reform to district residents. In fact, we embrace it. But exclusivity for an untested model as a replacement for a highly regulated and already paid for private marketplace is questionable and portends the possibility for unanticipated and potentially adverse consequences. We encourage the district leadership to consider an environment in which the exchange augments the private market, not replaces it. We encourage district leaders to pursue an approach that enhances healthcare choices and competition, not one that would dismantle the existing system and eliminate choices, particularly for the small business consumer. As an alternative, we suggest a marketplace in which the exchange would coexist with private insurers for a transition period of 3 years, ending 2017. At the conclusion of that transition period, an independent resource would be commissioned by the Council to evaluate the market. Armed with the documented evidence of the then effectiveness of the market, district leaders would be in the best position to oversee the implementation of a permanent delivery system, providing consumers with cost-effective exchange and non-exchange options. Thank you for the opportunity to provide input on this. And I would add just one point that was not in my testimony, but hearing prior witnesses talk about public education and the efforts to inform the citizens, I would say the District of Columbia's Insurance Federation would recognize its responsibility to help to support that initiative and would participate in it. Thank you.
Thank you. Just to ask you briefly, I'm going to hold all questions, but do you represent all the insurance companies that will be participating in the exchange?
I represent the insurance companies that are members of DCIF, which would not necessarily be all the members that would participate in the exchange.
Thank you. I'll hold the other questions. Thank you. Mr. Lazier, good morning. Good afternoon.
Good afternoon, Chairwoman Alexander, Councilmember Grasso, and Councilmember Bonds. My name is Ed Lazier, and I'm the Executive Director of the DC Fiscal Policy Institute. DCFPI engages in research and public education on the fiscal and economic health of the district, with a particular emphasis on policies that affect low and moderate income residents. I am here today to support the DC Health Benefit Exchange's effort to ensure that small employers and residents who buy individual insurance have access to a range of high-quality health plans, helping fulfill the promise of the Affordable Care Act here in the district to improve consumer protections and health benefit standards. The DC Fiscal Policy Institute supports the transition to a unified health insurance market under the exchange, which we believe is the best way to foster transparency, competition, and choice for district consumers. The exchange's online shopping portal will give small businesses and individuals an easy way to shop for plans and a way to help pay for them. The exchange will act as a clearinghouse of options, helping individuals decide what plan is best for them. It also will help make health insurance more affordable to both individuals and small businesses as the place they go to apply for tax credits and other subsidies. We believe the exchange will create real transparency, allowing consumers to know exactly what they are getting with a specific plan and to compare features across plans side by side. The online portal will also allow for stronger monitoring and enforcement of both local and federal standards. ACA protections that are currently hard to monitor, such as guaranteed issue or the ban on pricing based on pre-existing conditions, can be easily tested and enforced within the exchange. A unified exchange is critical to enabling the exchange to live up to this potential in many ways. It will create one large pool of individual residents and small business employees, creating the purchasing power that is traditionally reserved for large employers. This will incentivize insurance companies to compete for business, which we believe will drive down prices and expand the number of options available. With full carrier participation in the exchange and a transparent shopping portal, insurers will have to compete based on price and quality of their products, sparking innovation in benefit design and improving the consumer experience. The unified market also will result in improved choice for individuals, small businesses, nonprofits, and employees. Today, most small businesses and individuals have few, if any, real choices that they can afford. The unified market will allow insurance carriers to sell as many products as they want and will help residents connect with any plan available in the market. Small employers, including nonprofits like ours, will have similar, if not more, choices than they do today. It's important to note that the exchange will let small businesses expand choice for their employees by allowing them to choose from a wide range of insurance carriers instead of the common practice of offering just one or a few plan options. The district has the opportunity to improve the quality, affordability, and accessibility of health plans sold in the district using the unified market. The transition time allows for the exchange authority to assess and improve the market structure and the information and technology needed to give residents and small businesses the optimal experience. DCFPI supports this transition to a unified market exchange, and we urge the Council to do the same. Thank you.
Thank you for your testimony. Good afternoon.
Good afternoon. To Chairperson Alexander, members of the Health Insurance Committee, members of the Executive Board of the DC Health Benefit Exchange, and other distinguished attendees. My name is Lee Bethel, and I'm a Ward 7 District of Columbia resident, and I am President of Comprehensive Benefit Services. I've been a health insurance broker for over 25 years here in the metropolitan DC area. I've served on the DC Health Benefit Exchange Plan Options Working Group, and I'm currently the chairperson of the DC Health Benefit Exchange Broker Advisory Committee. First, I would like to take a moment to compliment the DC Health Benefit Exchange Executive Board for all of their hard work. I feel that the board members are truly dedicated to making the DC Health Benefit Exchange the best exchange in the country, as evidenced by the fact that our IT system has recently passed Wave 2 of the federal IT system testing requirements. I would also like to thank Mila Kaufman for her leadership and dedication as well. I had the opportunity to hear Mila speak at a church in Southeast Washington, D.C. a few weeks ago. She provided the members an excellent overview of the benefits of the DC Health Benefit Exchange. As an executive director, I thought this was above and beyond the call of duty because it was not something that she had to do. This was another example of her dedication to the Health Benefit Exchange. As a broker, I am deeply committed to making the exchange work for the business owners and the individuals of the District of Columbia. I and other brokers are currently serving on many of the DC Health Benefit Exchange committees to bring the benefit of our knowledge and experience to the overall development of the exchange. As a result of her belief that we as brokers are critical to the success of the exchange, Mila has created a very broker-friendly atmosphere for which I am very thankful. In a few days, the Council will be voting on legislation that would effectively close the private health insurance market in the District of Columbia beginning in 2015. This would force all small employers to purchase their health insurance from an exchange that is presently untested. I'm sure by now you've heard from a cross-section of District of Columbia business owners, trade organizations, broker groups expressing their concern regarding the closing of the private market without an adequate evaluation of how the exchange is performing. I would also like to note that most of the other exchanges in the country, including Maryland, will have both private and exchange markets. The Council, in effect, is voting on closing the market before an objective review process of how the exchange is working can be completed. In the first edition of anything, there are always adjustments and modifications that must be made. When a drug manufacturer develops a new drug, there is an evaluation and trial period that must be successfully completed before the FDA will give an approval for the drug to be marketed. I would like to recommend that the Council implement a wait-and-see strategy for a time period that evaluates the first 2 years of exchange operation before you vote on the closure of the current private market. This strategy would allow you ample time to properly evaluate the performance of the exchange. If the exchange is working, you can vote to close the market. If it's not working, then you will still have the private market in place to handle the health insurance needs of DC business owners and their employees. Rates are going to be a critical factor to the success of the exchange. I would also like to recommend that you establish a rate review advisory group that would work with the insurance carriers, the DC Health Benefit Exchange, and the Department of Insurance, Securities, and Banking to develop strategies that would ensure that both the initial and renewal rates are workable for all the stakeholders involved. The goal being that the exchange rates are affordable for both the businesses and the individuals who are located in the District of Columbia. By all of us working together, we can all ensure that our exchange will be successful and that it will become a model for all of the other exchanges in the country. So respectfully submitted, Lee Bethel.
Thank you all for your testimony. I can ask all three of you with regards to the transition. I'm hearing two different things about the transition. One, I'm hearing people support the transition, but there are two different, I guess, views of it. The transition seems to be something that will definitely take place, say, for example, in 2 years. Some people think the transition may or may not happen. Some people looked at the transition as saying, when the transition was stated, that means if things aren't working, we'll transition. And then others are thinking we're definitely going to transition in 2 years. And some are thinking we're going to transition depending on how the market is within the exchange in 2 years. So what is your view with the transition? Is the transition, I can ask each of you, do you view the transition as something definite to take place at a time certain, or a transition as an optional choice?
My understanding of the current legislation is that there is a transition to a closed market, and that the closed market will begin in January of 2015. So what I was proposing or recommending is that there would be a complete 2-year period, because January of 2015 or sometime in 2015 is not actually a full 2-year period, that there would be a 2-year period of transition and then an evaluation made to close the market. So I guess the first scenario is, right now the way everything is written, the market is closing in 2015, and the vote now would effectively close the market at that time. Now recommending a wait and see, giving a full 2-year period, and then vote to close the market.
A unified market is really the only way in the district with its size to have a transparent marketplace where there's enough competition to keep the prices down. So we see the transition as really a balance between knowing that we want to go to a unified market but needing some time to adjust to it. So that we see the transition as a process for working out the kinks, where we know that in January 2015 we will transition to a unified market.
So there's no hope or no confidence that without a unified market this is going to work?
It's really hard to believe that it will work without a unified market, yes.
Thank you. Mr. McGowan?
I see the transition similarly to my colleague on my far left. That is, that it is a requirement that there needs to be a period of time through which to get through this process. And but my position, our position, is that the transition is too short. I've been in the insurance business since 1968, which is a really long time, and I have witnessed the implementation of package policies versus monoline policies, the creation of risk retention groups, the creation of involuntary insurance pools like flood and wind, the creation of the Terrorism Risk Insurance Act. All of these initiatives, like this exchange, which is inspired by federal legislation, are very complex. They have many moving parts. They require a deliberative approach. And there's no question that we have a deliberative approach. Certainly all of the hearings and the roundtables that you have called and all of the work that's being done. But our position is simply that you can't guess at the outset how it's going to work out. And that we feel that a 3-year transition period is a more effective, a more reasonable transition period. And at the end of that, we get a non-invested resource to evaluate the exchange and the marketplace, and then to go forward from there.
So your anticipated date would be January 2017?
Yes.
And let me ask you, because I don't know if you were here with Councilmember Catania's proposal. I wanted to ask DISB, how would you rate them in terms of their reviewing rate filings at this at this point?
Well, I think that the industry generally commends the Department of Insurance, Security, and Banking. It has a deliberative approach to rate filings. The Department of Insurance must look at both forms, the kinds of coverages that are provided to the policyholders and to the consumers in the district, and it also looks at the viability of the rates that are charged for those coverage forms. It must satisfy two constituencies. It must satisfy the policyholder, the purchaser of the business, in terms of the rate not being overly aggressive or unfair or arbitrary, and it must satisfy the requirement to keep the insurance community fiscally viable. And so those are very complex issues with actuarial reports that look at those rates and the outcomes to try to evaluate that insurance companies will be charging the right premium in order to have sufficient surplus to actually pay the claims. And at the end of the day, this is what the insurance business is supposed to be there for, to write the check.
Now, I would imagine the public has access to the rate filings, but I can tell you how often the public may request a rate filing or a filing for a rate increase. So do you think it would be a wise decision to have public input? It's a provision, I believe, that states the public should have the opportunity for a 30-day input period.
Well, I think
does that exist currently?
It does exist. Transparency is a good thing. It exists in many jurisdictions. I believe that New York frequently has public hearings on rate filings, and other jurisdictions do. I certainly don't speak for the Department of Insurance, Securities, and Banking, but from the perspective of the industry, transparency is a good thing. And the more information you have, and the more it is shared, and the more the opportunity for the public to understand the underpinnings of rates, I think that benefits everyone.
Thank you. If you could provide for me, the states who currently have a public input period, a 30-day review. And what about in terms of the open or closed market? Some people argue that closed market or unified market, as Mr. Lazier puts it, would provide for more transparency and more affordability. So what would your argument be, either of you, for that? That if the plans are listing all of their, if the insurance companies are listing all of their plans through the exchange, it would be definitely transparent and more affordable and definitely more competitive in nature.
My comment on that simply is that competitiveness is what makes business successful. And certainly the more participants you have to a process, theoretically, the more competitive that process is. The more competitive it is, the more beneficial it is to the consumer. So all we are saying is that we don't think that there is sufficient time given in this legislation to determine that it will be sufficiently competitive.
Thank you. Councilmember Grasso?
Did either of the other ones of you want to answer that question as well? I didn't know if there was some more thoughts you wanted to add to it.
Well, I mean, absolutely. We believe that the online portal of the exchange is intended to make health insurance easy to shop for because it's all in one place. And so if it is all in one place, that will be indeed more transparent. So we think if this is intended to be a consumer-friendly exchange, that a unified market is the best way for residents and small businesses to find insurance. And we also agree that it is the best way to foster competition, where the competition is really based on the quality of the product and the adequacy of networks and things like that.
I think the only thing that I would add is that the transition period that we've been discussing would allow the time for the review of those rates and those renewal rates to go through a renewal cycle. We'll see how things are looking at that point in time. And then a firm determination could be made. If you make that decision prior to seeing everything, you really don't know how the rates are going to be structured and what the renewals, because it's really the renewal rates that are really critical. I've had groups that you get 15, 20% increases 3 years in a row, it becomes extremely unaffordable. So something has to be in place to handle and to cap or limit those renewal increases as well.
Great. Thank you very much.
Thank you.
Councilmember Bonds.
Chairman, I wanted to say I'm very interested in this rate renewals and how the public may react to such a hearing. And so I applaud you for even putting that on the table, and I'm looking forward to that being a part of the process. Thank you.
Thank you. Thank you all for your testimony.
Thank you.
Our next set of witnesses, Robert M. Brandon, President of Brandon and Associates. Kevin Reggie, founder, Pulse Issues and Advocacy, LLC. And Stephanie Cohen, Principal, NFP Golden and Cohen, LLC. Good afternoon.
Good afternoon.
You may proceed. I have a copy of your testimony, Mr. Brandon.
Thank you. Thank you, Chairperson Alexander and members of the committee. My name is Robert Brandon. I'm a 35-year resident of the district, and I've owned my own public affairs business for the last 20 years. I also chair the city's statewide health coordinating council that advises the Department of Health on health planning issues. But I'm here today to speak on my own behalf as a small business owner who provides health insurance for my 6 employees. The district should be very proud that it's one of the first jurisdictions to embrace the centerpiece of the President Obama's health insurance marketplace. And we should celebrate Obamacare generally, not only for the importance that it provides to the nation, but also what it will mean to the residents of the district and its 45,000 uninsured citizens, its the thousands of people with inadequate insurance, and the many small businesses and employees that struggle to afford good health insurance in a market that is not competitive enough. The President's health reform is designed to accomplish 2 main goals. 1, guaranteeing that everyone has access to quality, affordable health care, and 2, ending the abuses of the private health insurance marketplace. We've already seen many of the improvements to health insurance: preventive care without co-pays, an end to lifetime limits on coverage, an end to insurance denials because of pre-existing conditions. What's left is the heart of Obamacare, the implementation of the health exchange marketplaces to create affordable health insurance in a truly competitive market. And the district's already adding, as Mr. Grasso had mentioned earlier, many people because we provide a high level of insurance for individuals. So the real people now that don't have insurance tend to be small business owners, like sole proprietors, or the employees that they represent, or individuals. They're the ones who are going to most benefit from the health exchange. You will set up a truly competitive marketplace where at least 4 major health insurers will compete head-to-head and transparently, listing their policies, benefits, and prices, and over time consumer satisfaction information in a simple and consumer-friendly format, so consumers can really shop for the best plans. Rather than limiting choices, as some opponents to Obamacare would like us to believe, this system really increases meaningful choice. And I think that's the key. My experience in being involved in health planning in the city for over 10 years leads me to the conclusion that many small business owners would like to provide insurance to their employees, but they simply can't afford it currently. Unfortunately, many of those small businesses and their uncovered employees and the individuals who also have no insurance now will not only be able to access quality health insurance options through the exchange, but they'll be eligible for substantial subsidies or tax credits to make that insurance affordable. As a small business owner, I'm well aware of the health insurance market here. I've also seen 2 of my daughters who had to buy individual health insurance coverage. And the current D.C. market, as you've heard, for small businesses and individuals is not competitive, with CareFirst controlling about 75% of the market. The proposed exchange will transform this uncompetitive market into a robustly competitive market where all health insurance companies will have to compete in one market on a level playing field with their prices that will be public as well as their offerings. The key is really the one big market. And in order to make the health exchange work in a relatively small market like D.C., there needs to be the one unified market. Some have said we should keep separate an outside market. That would simply leave somebody like myself, a small business owner, with two very bad choices. I could choose to continue to get insurance in the current uncompetitive market dominated by one company, or I could choose to get insurance in the new, smaller exchange because the other market would stay outside and still see higher prices through the smaller exchange. That leaves two bad choices. So I think you have to ultimately have a unified market for this to work. And the small business owners, if you don't, the only winner in the bifurcated market is going to be Care First, because they'll continue to dominate the small business and individual market. And we would lose as small business owners, and individuals would lose who gain coverage, because we'd all be paying more than we should under a unified plan. So I hope that the district has obviously embraced the President's plan, and the Health Exchange Board has created a proposal that embraces the best of what the President's health reform is all about. So I hope that the Council will push through and endorse this program with a strong unified health exchange, a guaranteed success, so the guarantee of success around lower costs, better insurance coverage, and better health care. Thank you.
Thank you for your testimony. Good afternoon.
Good afternoon, Chairman Alexander, Councilmember Bonds, and staff. I appreciate the opportunity to present testimony on the district's health reform implementation efforts, and in particular, B-2240. As you know, I represent two regional health insurance producer organizations, the Greater Association of Health Underwriters and the National Association of Insurance and Financial Advisors of Greater Washington, D.C. These two groups work closely with individual consumers and especially with small businesses, with small business purchasers to assist them with their health care coverage decisions. I want to underscore at the outset that we commend the D.C. Health Benefit Exchange Board and its staff for the enormous amount of hard work and dedication they have put into the goal of implementing the district's HBX in a timely manner. In particular, we want to single out HBX Executive Director Mila Coffin for her thoughtful and tireless leadership on a number of challenging exchange implementation issues. We especially appreciate Ms. Coffin's concerted efforts to bring a wide range of stakeholders, including health insurance producers and their small business clients, into the implementation process. The single issue on which we have consistently raised concerns, both on our own behalf and importantly on behalf of tens of thousands of small business clients throughout the district, is the HBX Board decision to close the existing private market and mandate that all district residents and small business employees purchase coverage exclusively through the exchange. At a minimum, we urge the Committee on Health to consider the following changes to the market structure proposals put forth in the legislation. First, the bill should be amended to require the board to contract with a qualified independent entity to conduct a market structure analysis to evaluate both the inside exchange and outside exchange markets and provide a report to the council on its findings no later than August 31st, 2016. Also, we would urge that the council take this report into consideration in making its final legislative determination on the ultimate structure of the D.C. health market, i.e. whether district consumers would have a choice to obtain coverage off exchange or on exchange, or merely the sole option of purchasing on the D.C. HBX. There are a number of reasons why we support a reasonable transition period for the council to evaluate a decision whether to close the private market, and I will briefly discuss a few of those today. First, the district is the only jurisdiction in the country that is now actively considering closing down its existing health insurance marketplace. This represents a truly unprecedented step, and it should be undertaken cautiously and only after policymakers have had an opportunity to study both the intended and the unintended consequences of such a potential market disruption. I just want to pause here and just say parenthetically that I know that there's been testimony and other information suggesting that there is a magic number that the exchange needs to achieve in terms of its marketplace with respect to its viability, its sustainability. I respectfully disagree with that contention. I think we're looking at smaller jurisdictions in other parts of the country. They are all contemplating moving forward with two markets, and I would suggest to you that you don't need 100,000 people to make this market work. You can run the exchange market perfectly capably, and I would argue that it's an easier market to manage with smaller numbers. So I just wanted to just point that out. Second, despite prodigious efforts by the D.C. Exchange Board and staff.
Wrap it up, Mr. Reggie.
Yes. To meet daunting federal deadlines, there are elements of the exchange customization that will not be available to district consumers when the exchange operations commence in 2014. As Mr. Rosenstein has noted, we anticipate that there will, at the very least, be bumps along the road of a new untested exchange marketplace as it becomes fully operational. Keeping the existing market open through this period is not only reasonable, we believe it is the only prudent course of action. And with that, I would be happy to entertain any questions you might have. Thank you.
Thank you. Just one briefly, when you mentioned other states are all using the dual markets for the exchange, in comparison to the District of Columbia, do other states have the extensive amount of residents covered as we do in the District of Columbia? I believe we have about, 93% of our residents covered. Do other states compare to that?
No, and I think it's an important question, an important issue, because this is a success story. We have a marketplace bolstered by public offerings that's largely been successful and largely been a stable, healthy marketplace for consumers. That doesn't mean it's a perfect marketplace, but this to me means that we should move cautiously on all the new changes that we have in this marketplace, most of them coming through the federal Affordable Care legislation. The fact that we have a stable, highly insured market now augurs for taking our time and making sure this transition is a smooth one rather than moving to a new framework which will close off the existing marketplace, because this marketplace has been successful on a regional and a local basis.
Right, and that's why I guess my question was why it may be necessary, because unlike any other state, we do have such a high number of insureds. But that was the point. So your point was well taken.
Sure. May I respond to that briefly?
Yes.
I don't believe there's a necessity to get everybody into the exchange pool all at once. I think that if you have a smaller, more modest exchange, at least during this transition period, you're going to have a better opportunity to evaluate the entire marketplace, both within and outside the exchange.
Thank you. Ms. Cohen?
Good afternoon. My name is Stephanie Cohen, and I own an insurance brokerage firm serving hundreds of businesses in the D.C. marketplace for over 23 years. As a broker consultant for the businesses and individuals in the D.C. market, I feel it is essential to urge you not to close the marketplace down. Once it's closed, you can never open it up again. I support the exchange as a means to supplement the private health insurance market, but not to replace it. No one knows for sure how the exchange will work, or what the products will be, or what carriers will commit to play in a closed market. We do know that in our neighboring states, there will be offerings that are in the same are the same inside the exchange as outside, as well as alternative offerings outside the exchange, thus giving the consumer more choice than they will have in the D.C. market if we close it. We do know that the more ambitious the exchange, the higher the cost, thus increasing costs to the D.C. workers and residences needlessly. There is an estimated $22 to $29 million annual operating costs for the exchange. All federal subsidies will end after 2014. D.C. has the lowest rates compared to Virginia and Maryland currently. This will dramatically change for all. We do know that this model is untested and not being considered anywhere else in the country. When you go to the supermarket to purchase food, there are varying products between one store and another. One may say that under one marketplace, all products will be available. However, this is unrealistic and contrary to the idea that consumers will have a choice of where they purchase insurance. Choice is an essential part of the ACA. When you have only one place to purchase, there is no choice. I close with these questions. Have the carriers committed in writing what products will be available and how many products they will put on the shelves of the D.C. marketplace? Number 2, has this marketplace been compared with the surrounding marketplaces in Maryland and Virginia to see if the offerings will be competitive in order to keep businesses in the district? Number 3, has it been reviewed with the carriers if the costs can be aggregated without adverse selection with the private market and the exchange running together versus a closed market as proposed? And lastly, has the Exchange Board and the Insurance Commissioner reviewed the proposed plans and prices the carriers have filed for the exchange and the outside market to analyze what products would be lost in the closing of the marketplace? There is a great deal of confusion, unanswered questions, and untested terrains. While commending the Board, the Council, and WSB for their hard work in complying with the ACA, I urge you to join the rest of the country and your neighbors in pursuing a more moderate, cost-effective HBX options that enhance healthcare choice and competition rather than take choice away. Thank you so much for your time.
Thank you all for your testimony. I just wanted to get your take, Mr. Breggy, on Mr. Brandon's testimony that states for his company that right now his rates are, I guess he only has to choose between one dominant provider in the marketplace. And his argument is that if the market remains closed, actually open, I should say, if the exchange remains open, his rates would be higher.
Well, we do know that there's going to be a lot
because it would be a smaller pool, I guess, within the exchange.
Well, Councilmember, there's a single pool for rating purposes, both inside and outside the market, and that's why these other jurisdictions are not as concerned about the size of the enrollment for their exchange, certainly starting off. But I'd also turn that question around, or that issue around about choice, which is we don't know which carriers are going to participate in the exchange, either starting off or over the longer run. We've already had one carrier publicly announce that consolidating the market here in the district violates one of their core principles for determination as to whether or not they will provide coverage in particular markets. That carrier that's now participating in the D.C. market is, at least for the time being, has made a decision not to participate in the marketplace. So when we talk about choices, I think we have to look at this question of how many options you're going to have holistically. It's certainly possible that you'll have fewer choices within the exchange on a consolidated basis than you would if you kept both markets open. And I think in an environment where you have a lot of pressures on rates that we're not going to be able to have a whole lot of control over, all of those driven by the Affordable Care Act itself, it makes sense to afford consumers more choices, not fewer.
Can I just respond? First of all, again, I think we just get the worst of both worlds when we wind up having an exchange that's hampered because it's too small and an outside market that's dominated by one company. And we've heard that, the insurance companies during the whole debate over Obamacare was they were going to stop providing coverage if they forced them into a marketplace. They want the business. There are going to be more people insured under the marketplace because we're now going to have subsidies for people that now can't afford insurance. Let me mention two other quick things. To answer your other question about the high level of insuredness in the district, Massachusetts also has a very high level of insuredness, and it has a unified market, and it has done a great job in keeping prices down and providing affordable and comprehensive coverage to its citizens.
Thank you. Thank you all for your testimony. Councilmember Bonds.
Thank you, Chair, but I have no questions. I'm very curious about this rate, so we'll wait for later.
I thank you all for your testimony.
Thank you.
And next, I would like to call up Christina Postolowski, a legal fellow with the Young Invincibles. Mr. David Wilmot, Executive Director, the District of Columbia Association of Health Plans, and Shannon Hall, Executive Director of the DC Behavioral Health Association. Good afternoon.
Good afternoon.
The Young Invincibles.
Yes.
Wow.
Thank you all for the opportunity to speak today. Young Invincibles is a nonprofit, nonpartisan policy research and advocacy organization. We represent young adults ages 18 to 34. And we were founded in 2009 to make sure young people's voices were heard in the health reform debate. We're here today to testify in support of a unified market in D.C. With your permission, can I submit that via email? Thanks. So imagine Jason, a 26-year-old community college student here in the district. Jason is working part-time in retail. He receives a Pell Grant to cover tuition and earns a little over $23,000 a year. He's currently uninsured. Like most young people, Jason would get covered if he had an affordable option, but that has not been in the cards for him. He sees something about new insurance options and requirements on a flyer at his school, Googles 26-year-old in D.C. needs insurance, sees a Google ad, and signs up for a plan for $130 a month. Little did Jason know, though, that he could have enrolled in a bronze plan on the exchange for $78 a month after subsidies. That's a difference of over $600 a year for Jason. Jason's story is not atypical. Half of the uninsured population in D.C. is between ages 18 and 34, and 3/4 of young adults look for health insurance information, including information on health insurance options online. Of the uninsured 18 to 34-year-olds in the district, 75% have incomes below 400% of the poverty level and will qualify for some subsidies or Medicaid. And 54% have incomes below 250% of poverty and will qualify for more substantial subsidies or coverage under Medicaid. However, these young people are far more likely to learn they're eligible for Medicaid or tax credits if they apply for a plan through the exchange. If individual insurers are allowed to market plans to young adults off the exchange, young people may end up with less comprehensive and more expensive coverage, exactly what happened to Jason. Without key provisions in this legislation, young adults might just seek cheap, catastrophic plans in a market outside the exchange because they have the lowest premiums, without knowing that these plans have very high deductibles and without realizing they may have been eligible for financial assistance to get coverage. If young adults don't buy insurance because they can't find an affordable plan, that's bad for everyone. For health reform to work, we need younger, healthier residents to buy coverage and be in the risk pool. So each state and the federal government needs to make sure young people are part of this important new system. Under the proposed legislation, young people in the individual market would buy plans through the exchange. In applying for a plan, they would find out if they're eligible for subsidies or Medicaid. Like other consumers, they would be able to compare plans side by side. This could be saving the Jasons of the world hundreds, if not thousands of dollars. And for those who don't know their exchange options and go without coverage, this proposal could even help save their health and financial futures. Thank you.
Thank you. You may proceed, Ms. Hall.
Good afternoon. I'm Shannon Hall. I'm Executive Director of the DC Behavioral Health Association. Thank you. We seek to improve the quality of community-based behavioral health services in the District of Columbia and to improve access to those services. Every year, our members help over 20,000 DC residents find recovery, resilience, and support through behavioral health. For the past several decades, our field has been fighting for parity, the principle that mental health and substance abuse treatment should be covered equally with medical services. The Affordable Care Act requires the insurance exchanges to cover mental health services at parity, and the DC Health Benefit Exchange has taken important steps to strengthen this promise. Notably, the DC Health Benefit Exchange requires participating health plans to report their network adequacy. Based on our experience, this level of transparency is going to be essential for making the promise of parity real for DC residents. One way that health plans discourage access to care is by not having enough providers. Thus, a benefit package could say that it offers parity, but if the health plan hasn't enrolled enough providers, the beneficiaries who need those services are going to have long waits before they can access care. This isn't a hypothetical concern. We've seen it happen as recently as under the Medicaid expansion, where we added a lot of beneficiaries to our Medicaid program, and the plans hadn't expanded up their mental health networks in time. And as a result, at that point, 9 in 10 of the Medicaid beneficiaries in the managed care program weren't able to access mental health services. This is truly a case where an ounce of prevention through transparency in the network adequacy reporting can be worth a pound of cure. And we're delighted that the DC Health Benefit Exchange makes network adequacy reporting such an essential element of its work. It's precisely because the Health Benefit Exchange is doing this network adequacy that we must have a unified market. If plans under the exchange are held to actually delivering these parity standards and those outside the exchange are not, we're going to see beneficiaries with mental health needs are going to migrate to the plans that meet their needs. And when we see beneficiaries with different health needs migrating, that's where we run into problems that we're going to have risk assumptions that will impact the cost of care under these plans. We believe that a unified market is truly a good way to ensure that everybody in the DC who's getting the health care under these plans, it gets the same access and level of benefits. So the issues here are very complex, and it's easy to lose sight of what really matters in this debate. But I feel like I know firsthand what's at stake. My mother was diagnosed with schizophrenia in her early 20s. For the following 4 decades, she followed a cycle as predictable as the changing of the seasons. She'd be involuntarily committed to a state psychiatric hospital, and she'd stay there until she stabilized. Then she would be discharged, and she would be in good shape. She'd get a low-wage job after her discharge, but without insurance that covered mental health, she would slowly decompensate until she ended up being recommitted, often after a period of homelessness or police intervention. It was the same over and over until she qualified for Medicare and began access to treatment. And now, for the first time since my early adolescence, I'm beginning to develop a relationship with my mother. And this is, I think, what's at stake for parity and for DC residents today. It's access to treatment. Thank you.
Thank you. And mental health benefits are so important. Now, I do know that whatever plan is offered in the exchange will be offered outside of the exchange. However, mental health benefits, is that one of the essential benefits?
Yes, so the essential health benefit applies whether you're in the exchange or out of it, but that the standards for network adequacy only apply to the plans in the exchange. So that's where it, I think, really becomes critical in it's not just that you have to deliver parity, but we're going to make sure you're delivering it. That's the difference that makes a unified market important.
Thank you, and thank you for sharing your personal story as well. Mr. Milne.
Good afternoon, Madam Chair, Councilmember Bonds, and members of the committee. I feel somewhat privileged to be here with the Young Invincibles as a senior citizen, former invisible. And what came to mind is that they're so invisible, why do they need health insurance? But let's put that aside for a minute. Let me just get to my testimony. I'm Dave Womack. I serve as the Executive Director of the D.C. Association of Health Plans. I should first commend the authority, its Executive Director, and others who have worked tirelessly to get the exchange up, notwithstanding all of the myriads of meetings that they've had to undertake, and I applaud them for reaching out into the community as well. At the outset, I should note that our member plans are actively engaged and have been actively engaged in the efforts to implement the federal mandates of the Affordable Care Act. In that regard, representatives of our member plans have participated in all the working groups advising DC Health Benefit Exchange. Likewise, hundreds of member plan staff hours have been devoted to reviewing and commenting on the innumerable policy options faced in the Exchange Board. In short, our member plans have sought to help the district develop the most effective, efficient, and accessible exchange possible. On the most significant policy concerns for a number of our member plans, the exchange market rules, we continue to urge policymakers to act with extreme caution. The District of Columbia Exchange Authority proposes to limit the sale of health insurance plans in individual and small group markets solely to the exchange. Given the unprecedented changes facing health consumers, employer groups as the Affordable Care myriad provisions are rolled out beginning in 2014, the district should do everything possible to limit market disruption to the degree possible. Several of our member plans are deeply concerned that the authority's proposal to close and consolidate the existing marketplace in the district could aggravate the market disruptions greatly by eliminating options for individuals and small employers seeking health coverage. The bill would require carriers to offer individual and small group benefit plans solely through the DC Exchange with a transition period for groups with existing health plans. To ensure maximum choice for consumers, a number of our member plans continue to believe that plans should be offered both on and off the DC Exchange. At a minimum, policymakers should be provided the opportunity to evaluate the effectiveness of both markets before a decision is made to limit the marketplace solely to qualified health plans offered on the exchange. The bill does not offer the Council that opportunity. As proposed, individual consumers must purchase insurance solely from the exchange immediately, and small employers who currently offer their employees coverage would be granted a 1-year reprieve from the same requirement and would then be forced to purchase plans on the exchange. In the opinion of many of our members, the proposed transition period is insufficient to determine whether the exchange should serve as the only place for individuals and small groups employers to shop for health insurance coverage in the district. More importantly, such a critical decision
To grant monopoly power to the exchange would rest with the Council of the District of Columbia. To address our concerns, we propose the following alternative to you for your consideration. Maintain on-office exchange marketplaces and separate risk pools for individual and small group employers through December 2015. Then, all elements of the Affordable Care Act would have been implemented. There should be a clear picture of the state of the health insurance delivery system in the District of Columbia. 2, require the exchange authority to contract with an independent evaluator to analyze and provide a comprehensive report to the Council by August 2016 detailing the state of the on-off exchange health insurance market. That report should serve as a foundation for establishing a final policy on the structure of the district's exchange. I see that my time, but I'm representing an association. Do I get 5 minutes or 3 minutes? Because if I thought that's what...
Well, I said everyone gets 3 minutes because we have such an extensive...
I see. I wasn't here, and shame on me. But I will. What I will do is simply. There's some other amendments that we've listed here. They're really more for the staff to go through and to look, because if you're going to pass this piece of legislation, it has impacts on existing statutes and statutory provisions. You need to look at those. They're reflected in my testimony. I'm willing to sit with you and your staff and others to get through these amendments as well.
Okay, definitely I will review this, because I did state in my opening statement that I plan to introduce this as an emergency on May the 22nd at our next legislative session. So noted. And Councilmember Bonds, if you have any questions for the panel, thank you all.
No questions. Thank you very much. Thank you, Pam.
Thank you all for your testimony. Next witnesses, Dania Palanker, Senior Counsel, National Women's Law Center. Dave Chandra, Senior Policy Analyst, Center on Budget and Policy Priorities. And I understand the next group is a panel, but we only have 3 chairs up there. So if Dr. Christine Wiley is here, if she doesn't mind coming up, and that's pastor of Covenant Baptist United Church of Christ. Welcome. You may proceed with your testimony.
My name is Dania Palanker. I am Senior Counsel for the National Women's Law Center. I apologize. I made lots of last-minute edits, so I can submit a copy of my testimony afterwards. I've been involved with the process as a member of the Standing Advisory Board, Chair of the Standing Plan Management Committee, and an active member of many of the work groups. And I and the National Women's Law Center support the entire legislative package. This has been and continues to be an extraordinary process. Policy decisions that went into the legislation were made with input from all constituent types, including consumer advocates, healthcare providers, small businesses, brokers and producers, and health and dental insurance companies. The Standing Advisory Board has come together when asked to by the board or exchange staff to make recommendations, including a recommendation on a transition process to a unified market. As a part of that process, we were guided by an expert and received public input. And we were unanimous in our support of no transition for the individual market because of access, in part because of access to the subsidies and easily accessible and comparable information. Many other recommendations were made by various work groups that came together to work intensively over a 2 to 3 week period, and where there wasn't consensus, there were always work committees by the executive board that worked through the issues. And having listened to multiple different committees, I'm confident that they really had heard the various concerns and positions raised by the different constituents and were very considered in their deliberation of these issues. And overall, I would like to say I've been very proud to be a part of this process because it's been so inclusive. And I'll also note for ongoing things, the Standing Plan Management Committee, which I chair, has been meeting every other week to provide technical guidance on issues of implementation, and we are working with the staff and the board to make sure that the exchanges work. The Law Center advocated for passage of the ACA and continues to advocate because it will tremendously expand women's access to affordable coverage. Women will no longer be able to be gender-rated in the individual and small group market, which can save women up to $1 billion each year. Nor can women be denied coverage because of a pre-existing condition. A unified market will help enforce these provisions. Too long a transition could undermine these provisions. A unified market is not a mandate on individuals, but regulation of the insurance market. It means plans will not be offered without access to the premium tax credits or the small business tax credits, which could result in confusion and some individuals and small businesses not getting credits. In addition, an insurance company will not be able to choose to only offer outside of the exchange with a business plan that is really aimed at attracting younger, healthier individuals or employees, and therefore working to undermine the rating protections in the law. And I just want to close by noting that the National Women's Law Center will be considered a small employer when the definition increases to 100 employees. And not just the Law Center, but myself as an individual, I'm actually looking forward to having that opportunity to make choice in my employer coverage.
Thank you for your testimony. Good afternoon.
Good afternoon, Chairwoman Alexander, members of the Council. I am not Dave Chandra. I'm not nearly as good-looking and as young as he is, but because they have to catch a train in a few minutes, he agreed to swap places with me. My name is Wendell Potter, and I was a health insurance executive for nearly 20 years, and during those 2 decades, I worked for 2 of the largest health insurance companies in the country, Humana and Cigna. And I might still be in my old job had it not been for a crisis of conscience. As I have testified before several congressional committees, I came to understand how the practices of insurance companies have contributed to the rapidly rising cost of coverage and the fact that nearly 50 million Americans are uninsured. What I've done since leaving the industry is pull the curtains back to reveal the tactics that insurers have used to influence public policy, to preserve the status quo, and to explain their motives for doing so. Even though the status quo of our healthcare system is not in the best interest of either individuals or businesses in this country, it is profitable for insurance carriers that dominate any given market, including the District of Columbia and for many agents and brokers. One of the most effective tactics that we use to influence public officials was to form so-called coalitions that supposedly represented the interests of small businesses. We hired a big PR firm to create one such group. For example, when we wanted to make sure that Congress would not pass a Patient's Bill of Rights. Even though insurance companies provided most of the funding, we wanted to create the impression that small business owners were behind that group. The real reason for its existence, though, was the insurance industry's fear that the Patient's Bill of Rights would have an adverse effect on profits. One of the reasons insurers resist changing how they operate is because change might threaten their dominance in any given market and consequently their profits. From coast to coast, just 1 or 2 carriers dominate every health insurance marketplace. And although insurers profess support for choice and competition, their business practices and numerous mergers and acquisitions have actually reduced the number of choices that employers and individuals now have to choose from. The health insurance exchanges represent the best hope we have of restoring some of the choice and competition we've lost. And if the D.C. exchange is successful, those who will benefit most from renewed competition will be your constituents, the small business owners in your district and the women and men who work for them. I mention that because we need to remember whose best interests are really at stake here. Many of your constituents are uninsured because their small business employers have been priced out of the health insurance market as a result of business practices designed to boost profits and because of the lack of real competition. The exchange holds the promise of making coverage affordable for them again, but only if you give it the best chance of working on their behalf. In a relatively small market like the District of Columbia, the success of the exchange will depend on the size of the risk pool. That's why a single marketplace in which all eligible small businesses participate is so crucial. Although we're still 4.5 months away from the date the exchanges must be up and running, we're already seeing evidence that they will work well for consumers under the new rules of transparency and fairness that will distinguish the exchanges from today's unorganized marketplace. just last week when the Oregon Insurance Department published monthly premiums that insurers said they planned to charge on that state's exchange, the companies that had proposed the highest rates announced within 24 hours of seeing what their competitors planned to charge that they would lower their rates substantially. The same thing can happen here, but the key will be the single unified marketplace, and such a marketplace will be a win for both small business owners who will be able to offer multiple health plans at no additional cost, and of course their employees, your constituents. If you keep their best interests in mind, I'm confident you'll support the single market unified approach for the DC Benefit Exchange. Thank you.
Thank you. So you definitely, I know you have a train to catch, so I wanted to ask you, and if you have to leave the panel, I understand. But you think that the lower prices, the more affordable prices would come with the unified market?
I have no doubt. I'm certain that'll happen because it will, as I said, create an atmosphere of greater transparency and fairness. And I think that will create a competitive marketplace like we've never seen before.
So even if, how do you feel if an insurance company is able to offer in the exchange those prices would be affordable, and then the outside, if the outside is not affordable, then they would go into the exchange anyway? So if I call up a company and I feel their prices aren't affordable, then my next option would be to go into the exchange and say, well, let me check in the exchange because that's too high for me.
If there is awareness of that, and if there is really that kind of a situation, I think most people would find that somewhat confusing to try to figure out what's inside the marketplace and what's outside of the marketplace, in my view. I think it adds a burden to the potential purchaser that is unnecessary.
Thank you. Thank you, Pastor Wiley. Good afternoon.
Good afternoon. Thank you for being able to be here today. I have been serving the Covenant Baptist United Church of Christ in Washington for over 30 years. And having been trained in nursing and psychotherapy and social work, I've been trying to care for the body, mind, and spirit of parishioners for that time. And I've seen too many men and women come to me with heartbreaking stories of being ill and having no health insurance, stories of people being turned away by insurance companies because they have diabetes or high blood pressure or asthma, and stories of families going into bankruptcy because they were unable to pay their medical bills. And this has been a common theme in our congregation. The promise of affordable, high-quality health care coverage for every person, no matter their means, no matter their health, no matter where they live, is a true lifesaver. And I've long believed that all people have a right to health care, regardless of their race, class, gender, or sexual orientation. So with this law in place, their dream can actually become a reality. No longer can people living with a chronic condition be turned away or charged high premiums. No longer can women be charged higher premiums than men. And annual and lifetime limits on benefits will be a thing of the past. I'm especially pleased by the emphasis on prevention, especially for women. By spending a few dollars up front for things like mammograms and immunizations for maternity care and contraception and for well women visits once a year, we can prevent spending thousands and thousands of dollars once disease occurs. The health care law puts prevention first and gets rid of barriers to care. As a member of the Mayor's HIV/AIDS Commission, I'm thrilled that people living with HIV and AIDS will no longer be discriminated against in the private insurance market. They'll be eligible for the same benefits at the same cost as everyone else. And I'm very happy that HIV testing will be a benefit for everyone at no charge to the patient. I'm gratified that the district has taken the lead in implementing the President's Health Care Act by building a marketplace exchange. We're one of only 18 jurisdictions in the country that has taken on that responsibility of building. While other states have said no, we said yes. While other states left it to the federal government to create a one-size-fits-all marketplace, we stood up and said we will create our own so that the needs and the values of our people are part of the structure. One of our core values at my church is inclusiveness, and so Mayor Gray talks eloquently about his vision of one city, and I agree wholeheartedly. When we're divided, we are weaker. When we're united, we're incredibly strong, and that's why I fully support the legislation before the council that will create one market for everyone who wants to buy insurance. one market that recognizes no boundaries or border, and one market that brings our neighborhoods together instead of driving them apart. And so I commend this committee, and I commend the mayor for his forward-thinking proposal, and I commend us as we go forward as a city and ask that we please pass the Better Prices, Better Quality, Better Choices for Health Coverage Amendment Act of 2013. Thank you.
Thank you. Thank you all for your testimony. Just wanted to ask Dr. Wiley, have you conducted any outreach in terms of your congregation or community to let them know about the healthcare exchange, or has anyone reached out to you in your leadership position to spread the word about the benefit?
We've been doing our own outreach and trying to bring information to our congregation. We have a wellness center, and one of the things that we know is that if we don't give information and give education, people are not going to know about it. What we understand, particularly with African Americans, is that regardless of the socioeconomics, health disparities are the same. And so we have to make sure that we educate people about access to service and also information.
Thank you. And any particular policies with regards to women's health that you would like to stress, or to make sure that everything is included in terms of essential benefits?
I think the essential health benefits, I was part of that work group. I know that there are, one of the most important aspects, but maternity coverage is a part of it by the Affordable Care Act, which is an incredible importance for women. The other one, which does connect to the unified market, is the ban on gender rating and the general rules around the rating for the affordable care for the small and individual group markets. Because the concern is really you just need one insurance company that could decide that they're not going to participate in the exchange, but they'll participate outside of the exchange, and really figure out a way to create a business plan that's around trying to attract young, healthy men primarily. And if you took that group then out of the exchange, then that's really going to result in a system where you end up having ratings still based on health status or other factors in the exchange, because the healthy people are outside of the exchange, the sick people are in the exchange. So the issue of rating is an incredibly important part to women, not just because of gender rating, but there are, as women do get older, women do have more chronic conditions, and wanting to make sure that it's not the women left.
Now, someone, and I guess I should have asked this in earlier testimony, the Young Invincibles stated that the average age of uninsured is between 18 and 34. And I would think, but I can't assume that, but that's a fairly healthy market.
It's a fairly healthy market. I'm sure others say it's, for many people, I mean, myself included, it was in that age that I discovered I had a chronic condition, which is an important part of wanting to make sure that that market is covered for that reason long term, as well as making sure that we can have the healthy people in the rating. I'll also add that if that's a group that's probably more likely to be single, or at least the younger end of that age, and how that impacts where people are as a percentage of the poverty level, since the poverty level varies based on your family size. So the other issue you have is that you may have an individual who's making $35,000 a year who's actually eligible for those premium tax credits, but if there's a market outside of the exchange and they just go on the internet and Google for health insurance, and there's other stuff that comes up before, or because of their browser history or whatever that they find out of, may never find out they have access to those premium tax credits.
Have you talked to people, have any of you talked to any residents, young people, or parishioners in your church? Are people aware of the exchange? Are people aware that they have this option that you come in contact with?
I say because so many of the people I come in contact with are people who work in policy. It's probably not the example.
I would say in general, because we serve about 500 persons a month just from the community doing services, and in doing surveys with them, they are not aware, and persons in the congregation are also not aware until we share it with them.
Thank you.
And If I can add, although it was something that happened after this legislation, the Plan Management Committee had recently submitted recommendations to the board, which the board, I think, actually took action to pass, on also making sure that the preventive services that were discussed, that there would be work to really have a plan for the exchange to work to educate the district residents around the preventive services, including tobacco cessation, as that's going to be included in all of these plans.
Great. Councilmember Bonds, I thought was still here. Thank you all for your testimony. Much appreciated. I'd like to call up our next panel of witnesses, Reverend Willie Wilson, Union Temple Baptist Church, Reverend Frank D. Tucker, pastor of the First Baptist Church Leadership Council for Health Communities, Bishop Kwabini Cheeks.
Bishop Cheeks has to be.
Okay. Vincent King, the President and CEO of Unity Healthcare. Good afternoon, and Pastor Wilson, I just wanted to thank you. Of course, you are my neighbor and constituent, but I want to thank you and Reverend Tucker. I enjoyed myself and commend you for your work working through faith-based communities with regards to HIV/AIDS for women and prevention and awareness in women. So I would really like to commend you on your efforts. We had a wonderful and informative day at Union Temple Church. So thank you all for all the work that you do, and I have a copy of your testimony. So you may go right ahead.
All right. Well, let me say good morning to Chairman Alexander and to the committee, President absent. Let me just say I didn't preach yesterday. My daughter preached, so I feel like preaching, especially about a subject of which I feel so passionate, but I promise not to be preachy this morning. It is a great pleasure to appear before you today to discuss the imperative of providing the people of our District of Columbia with access to high-quality health insurance. I want to thank you for all of you are doing for the district and for your leadership on this critical topic. Of course, I am Reverend Wilson, having served as senior pastor of the Union Temple Baptist Church in Anacostia, Southeast Washington, D.C., for the last 40 years. In Jesus' inaugural address in Luke 4:18 and 19, he laid out his mission when he said, "The Spirit of the Lord is upon me, because he has anointed me to bring good news to the poor. He has sent me to proclaim release to the captives, and recover sight to the blind, and to set free those who are oppressed, and to proclaim the acceptable year of the Lord." This was Jesus' mission. Proper exegesis of this text will reveal that the good news to the poor was that God had not created those who are poor to receive inferior treatment or services. The release of the captives did not just mean those in physical captivity, but those who were psychologically, socially, and economically incarcerated. He then said he came to help the poor not just to have physical eyesight, but to help them to see that they had supreme value, having been created in the image and likeness of God. And finally, Jesus declared that the time for change was now. As a follower of Jesus, and he pastored in Anacostia for over 40 years, my mission has been the same. But for too long in this city, in this country, the least among us, especially those who live with the burden of disease and disability, have been last in line when it comes to getting good health care. In the area of health care, many of the poor, who also happen to be African American, are at the top of the list of every negative health statistic. Hepatitis, diabetes, cancer, heart disease, HIV/AIDS, the list is endless. Thanks to President Obama, we now have a chance to heal the sick and improve the health of our entire community, those who have, as well as those who have not. It took took more than 100 years for President Obama to do what many before him could not do. The Affordable Care Act guarantees every American the right to have high-quality health care coverage. By providing every American with the ability to get real coverage for an affordable price, this law can change the lives of millions of our brothers and sisters. But notice I said it can change people's lives for the better. You all know that we have had many promises made to our citizens that have not been kept. This is a promise we must keep. I'm proud of my city for being one of the best places in the nation when it comes to health care. Thanks to the leadership of the mayor and the city council, we have the strongest Medicaid program in the country. In the community east of the river, far too many of our people are uninsured. Like you, Madam Chair, my home is Ward 7, where more than 18% of uninsured in the district live. People without insurance do not go to the doctor to get care for themselves and their families. They wait until the very last minute to get care, and by that time, it is often too late. More than half of the uninsured in the District of Columbia are African American, and 2/3 are men. That is outrageous, and it has got to change. For years, I have fought strong and hard to provide better health care to the residents of our city, especially in Wards 7 and 8, where I reside as pastor and live respectively. I led a valiant effort to keep D.C. General Hospital open. My adept research had revealed to me that the company being brought in to manage an already ineffective Greater Southeast Hospital had an extensive record of extracting large sums of money from cities and then absconding, leaving the provision of health services for the worse. I prophesied the same, and my prophecy proved to be correct. Still, far too many of our residents east of the river are without adequate health care. At Union Temple, we tend to many people who are living with diabetes, high blood pressure, heart disease, and other afflictions. Until recently, we operated a full-service health and wellness center with every manner of preventive health care in the Salvation Army building in Anacostia, until they were built, defrauded, and lied to, and surreptitiously and stealthily evicted by the Salvation Army. We do monthly screenings for various ailments. The sad thing is many of these conditions could be prevented if people had access to high-quality health care. In September, I will lead a prostate cancer walk for a disease that disproportionately affects African-American males with the support of the local hospitals, churches, the Masons Cancer Consortium, NAACP, and survivors of the disease. Churches like mine and faith leaders throughout this city are ready to work hand in hand with you and with the district to develop DC Health Benefit Exchange to make sure our people receive the benefits that are due them. We will open our doors and open our mouths to get the message to all of the citizens of this great city. The mayor's bill will create a one big marketplace that unites our city and puts all of our citizens on one level playing field. One market for our families, our neighbors, and our local businesses. By sharing the risk, we will share the wealth. And by doing so, we can begin to erase the disparities in health that divide our city. We can and we must work to keep this a healthy city and healthy residents well. Thank you again for the opportunity.
Thank you, Pastor Wilson. You see, you were over 3 minutes over your time, but I did not attend church yesterday, and you didn't preach yesterday, so I think that was in God's divine order.
And I cut it.
But thank you. Point well taken, and thank you for all your work. Reverend Tucker. They just command such, it's like God is speaking.
Yeah.
And you're scared to cut them off. Thank you, Reverend Tucker.
Chairperson Alexander and members of this distinguished committee, I'm honored to join you this morning, this afternoon now, I believe it is, to talk about a topic that is very close to my heart, and that is improving the health of the people of the District of Columbia. I'm Reverend Frank D. Tucker, Senior Pastor of the First Baptist Church located at 712 Randolph Street, Northwest, Washington, D.C. which will be celebrating its 150th anniversary this year. I have had the distinct honor of preaching at First Baptist for more than 37 years. One of the high points of my career came in 1993 when I was honored with the Martin Luther King Jr. Humanitarian Service Award. To be mentioned in the same breath as Reverend King is an honor and a privilege, and it is indeed an obligation to follow in Dr. King's footsteps and help fulfill his famous dream. In 1966, while speaking to the Medical Committee on Human Rights, Dr. King made this observation: of all the forms of inequality, injustice in health is the most shocking and inhumane. Like the other pastors here today, and those that I've talked to over the past several months and weeks, I've listened to the stories of too many members of my congregation who struggle to get health care for themselves and for their children. We do what we can to help, but too often there is little we can do because it's too late. Instead of getting the care they need to make them well and keep them healthy, people who are uninsured often must go to the emergency room for care and struggle to pay the bills. That is why the Affordable Care Act is such a significant milestone in the history of our nation. Thanks to the hard work and the stubborn leadership of President Barack Obama, who we finally have a law on the books that guarantee every American a chance to have high quality, affordable health care as a right and not a privilege. With the law on our side, we can lift up our neighbors and provide them with the peace of mind and financial security that good insurance brings. Now that the President has created this law, it is our responsibility to complete the task by making sure the benefits reach the people. Following the enactment of the Voters' Rights Act of 1965, it took the hard work and perspiration of thousands of men and women to make sure our brothers and sisters registered to vote. We fought hard for these rights, and we continue to fight for them today. We must make a similar effort to ensure the benefits of the health care law reach the people who need them most. Churches all over the district stand ready to work with the DC Health Benefit Exchange to go ward to ward, block to block, house to house, to make this a success across the city. The City Council also has a role to play. In the coming days, you will be considering legislation that will make the DC Exchange the strongest in the nation. And I hope you will say yes to the policies presented to you. We know the powers of those who want to retain the status quo. They walk these halls and bend your ears. But we will be walking the streets for our city to make sure that the promise of health care for all are truly achieved. I urge you to enact
Mayor Gray's legislation and all due haste so that the work of improving the health of our people can begin. Thank you so very much for this opportunity.
Thank you both for your testimony, and it's so important that I stress with Reverend Riley as well that you let your congregations know about the healthcare exchange. I think our churches, our faith-based community reaches so many people, and it's important that we do have a successful exchange. And I know both of you have health ministries at your churches. We really need to let people know, because there's still a lot of uninsured persons out there. There's still a lot of persons with pre-existing conditions that may not have had coverage before that need the coverage. So we really need to spread the word, and I'm counting on you to continue your work with me to let every person know that they will have affordable, quality health care in 2014. So thank you both. And Mr. Keene, good afternoon.
Good afternoon, Chairman Alexander and members of the committee. My name is Vincent Keene, President and CEO of Unity Healthcare. I guess if listening to Reverend Wilson and Reverend Tucker was like listening to God, the pressure is now on me. Right? I'm here to testify in support of the Better Prices, Better Quality, Better Choices for Health Coverage Amendment Act of 2013. I believe this bill will create a more viable and transparent health insurance market. The district got roughly $90 million to establish the exchange, and today it has had some very positive results. I want to commend Director Kaufman, Dr. Akhtar and their staff, and yourself, Chairman Alexander, because under your leadership we have moved forward very rapidly. One of the decisions was to establish advisory groups, and those advisory groups have been very active, and most of the recommendations in the bill actually come out of that, and I think that's a reflection of the input of the community, and I hope this committee will give serious consideration to supporting the act. For Unity, at least 2,000 of our current patients earn more than 200% of federal poverty level, and they may qualify for coverage under the exchange. While we would care for those people regardless of their ability to pay, these patients will greatly, we will now be able to shift them out of a sliding fee scale into a health insurance coverage. And we believe that the Amendment Act provides for a number of core participants in the exchange, and we believe that the larger the pool, the cheaper the premium, which is a big concern to lots and lots of people despite the federal subsidy. This legislation ensures that employees of small business will have improved access to a robust health insurance exchange. It will enhance continuity of care by creating more pathways for people over 200% of poverty. One of the experiences we will have, we no doubt, is the churning of patients from Medicaid to the exchange and back and forth. We are there to provide health care regardless of what their insurance status. We believe that at the same time, the ability of patients to navigate a very, at times, complicated system will be very valuable. We are somewhat concerned about the network adequacy because normally federally qualified health centers such as Unity and other health centers in the district would be able to participate in caring for people with private insurance, but there is literally no mandate, either in the ACA, even though it's recommended, or in this bill, that health insurers would actually contract with federally qualified health centers. I believe there's a real value in that because we do provide a medical home concept which emphasizes prevention that has already been addressed here, as well as continuity of care. I hope that the committee will give strong consideration, I hope the exchange will give strong consideration to including all 30 qualified health centers and community-based organizations to participate in the exchange and make some demands upon the insurers as they actually participate in the exchange. I have other things that's in my official testimony, but I think I will finish my testimony at this time. And thank you again, Chairman Alexander.
No, so you will be a provider in the exchange, or you're interested?
Very interested in being a provider in the exchange. Right now, we currently serve private insurance people, but the rate of reimbursement not very high, but also we serve predominantly Medicaid, uninsured, Alliance, and Medicare patients in all wards of the city.
Are you working with the exchange? Do you think that
we have had staff on, we have had members of Unity staff on the advisory committee, and while it was the decision of the it was the consensus of the advisory committee not to, one of the advisory groups on network adequacy, not to put that mandate in. I believe there's strong openness on the part of the director to actually encourage, advise, and probably ask insurers to contract with us.
I would definitely think they should. You provide great service now, so who wouldn't?
Well, we'll continue to push for that.
Thank you. Thank you all for your testimony. I would like to call up our next panel of witnesses, Karen Brown, Benefits Trust Director, Center for Nonprofit Advancement, Mr. Samuel Jordan, Deborah Cholette, board member with the D.C. Appleseed Center for Law and Justice. Thank you. You may proceed with your testimony. Good afternoon.
Good afternoon. My name is Karen Brown. I am the Benefits Trust Director for the Center for Nonprofit Advancement. The Center for Nonprofit Advancement, it is an association of 1,000 nonprofit organizations with more than 500 located and serving children, youth, family, and communities in the District of Columbia. The center helps area nonprofits achieve their missions through training and technical assistance programs, advocacy, and group buying power. Over 29 years ago, the center established a group health program to offer employees of nonprofit organizations the ability to access high-quality health insurance at a more reasonable and consistent cost. Today, the center's group health program supports a combined total number of lives of 5,000, which represents nearly 425 nonprofit organizations. We offer 8 plans for dental plans, vision, and life insurance. My points today express our concerns regarding the district closing the small group market in 2016, which will force small employers to the D.C. Health Exchange. We are also concerned with the district's plan to combine the individual and small group markets within the district's exchange. The Better Prices, Better Quality, Better Choices for Health Coverage Amendment Act of 2013 will take away the true intent of President Obama's Affordable Care Act, which proposed that an employee would be able to keep their current health care plan if he or she is happy with it. The recommendations to close the small group market will limit the choice and competition between plan options, disrupt coverage for policyholders, and could lead to higher premiums because of decrease in competition. In addition, the exchange is not operational, and there is no way to ensure that this is the best option for residents at this time. there are no actual facts to confirm that there will be better quality, choice, and prices. There is actually very little information as the insurance carriers will not submit their plan designs with the required benefits and rates until May 31st. What if the plans and rates offered by the exchange are not as robust and competitive as anticipated? The intended beneficiaries, the uninsured residents, and those without quality health care may not benefit from the bill at all. Some employers and their employees need access to a range of benefit options to meet their diverse needs and budgets. Their budgets are already stretched thin, and closed market does not expand options. It simply substitutes one market for another. I see the administrative burdens associated with all the changes being passed on to the small employers through increased premium costs. Without affordable health care, nonprofit organizations will not be able to adequately compete for top talent within our sector, or retain the employees that they currently have. Our nonprofit organizations provide services including food, shelter, violence prevention, workforce training, support for people living with HIV and AIDS, just to name a few, and rely on limited capacity and resources they currently have in place to remain sustainable. We ask that the private marketplace not be closed as proposed by this bill in 2016, and that small employers who currently have group health plans be excluded from the mandate to join the DC Exchange in 2016. Thank you.
Thank you. Can I ask you, Ms. Brown, if you are grouped according to your entire association, or are you broken down in each individual nonprofit organization?
No, we're one group.
So you're one group. So you're a large group. You're not a small group.
But we still service. Not everybody who's a member of our association participates in our health program. So we're here speaking on behalf of not just those that do, but for those that aren't.
Just curious, why would anyone, if you have 5,000 lives, why wouldn't any organization participate in that large group?
Again, it's about choice. Again, about education, not really knowing that we exist. And being honest, we've gotten more in the last 3 months of more people calling us about the health program because they weren't aware that it existed. So in that way, it's more of the education of the public about who we are.
Right, because technically your organization would not be mandated.
No.
But you're speaking for those
that do not participate.
Well, couldn't you even invite them to participate in your health?
Correct, we do. And we don't. Not that we don't. But again, I mean, we're asked as a member association to speak and advocate for them.
Okay.
And so that's what we're doing here today.
Fair enough. Thank you for your testimony. Good afternoon. And is Walter Smith, are you going to provide testimony for?
I will give some preliminary comments, and then Walter Smith will follow up and explain the issue for DC Appleseed on the next panel.
Okay, thank you.
Okay. So, I want to start by introducing myself. I'm Deborah Cholet. I'm an economist. I've spent my career looking at issues around healthcare financing and private insurance in particular. I'm a longtime resident of Ward 6. So, I want to make some preliminary comments that will track on the testimony you have before you, and then address some of the issues that have been raised by various panelists, not just this panelist, over the course of the late morning and early afternoon. I believe, and DC Appleseed believes, that competition is essential in the district, that we have not had a competitive market, and I think it's fairly clear just from the facts of the situation that we don't have a competitive market. Competition will do a number of things that we don't have now, we believe. It will offer better prices. It will offer price discipline in the market that has not occurred, despite the best efforts of regulators to make sure prices are fair. We have a cost platform that is fundamentally not competitive and fundamentally, therefore, higher than it needs to be for health insurance in the district. DC Appleseed's issue, which Mr. Smith will explain, relates to surplus and holding of surplus in the district. And we believe that one of the best ways, if not the best way, to bring all competitors to a reasonable and efficient surplus is for competition actually to exist, and therefore pricing to be competitive in a way that it is not now competitive. I'd like to make a few points that are not in our testimony, but again, as I said, relate to issues you've heard. First of all, we believe that the proposal before the council for a unified market is the best way to make the market competitive. Second, that a competitive market is essential for keeping prices low, and despite the fact that there will be subsidies available to residents in the district, I think everyone will be surprised at how fast the premium subsidies phase out. So absolutely minimum prices are essential for this market to work. At 250% of poverty, there will be no more premium subsidies in the exchange. That is a very modest income. We're looking at something like $25,000, $30,000 for a couple. At that point, they're paying full fare for their health insurance premiums. Third, I think competition delayed is competition denied in this case. There seems to be no reason not to move forward with a game plan that maximizes competition. Fourth, I don't believe that we're per se closing down a market in a unified market. We're simply placing the entire market on a single competitive platform. And I think the idea that we're closing a market is really a misnomer in this case. And finally, I think the idea that we would delay competition or we would delay the decision whether to have a unified market, we would place the exchange on an uneasy, unstable footing and then evaluate it after a period of time to see if it succeeded, is setting the exchange up to fail. I think you cannot move this market forward in a compromised way and then evaluate whether it worked to see if you should actually make it a more stable framework for operation.
Thank you. So you don't believe if an insurance company was outside of the exchange and if they didn't offer, if prices were not competitive with those within the exchange, why would a person go outside of the exchange? Or is it based on based on the assumption that people don't know about the exchange?
I think, number one, maybe people will know or not know, but I think you're placing a burden on consumers to do more shopping and with less information than the exchange would allow them. The idea of the exchange is that it is a place where informed consumers can shop and the information is there. That same information will not be available to consumers with respect to products outside the exchange. So in the exchange, they're shopping apples to apples. Outside the exchange, they're shopping without the same level of information.
Thank you. Mr. Jordan?
Yes, and thank you. I'm Samuel Jordan, a resident of Washington, D.C.'s Ward 7. I'm also a long-time advocate for special attention to the health status indicators for all district residents, particularly those residing in the communities east of the river in Ward 7 and 8 in nearby Prince George's County, Maryland. You have my written testimony, and I would like to sort of depart from it in order to make a few comments within the time given for the record. In 2003-2004, I was a member of the Mayor's special panel on extending health insurance coverage. We made several recommendations in an attempt to provide for even greater coverage for the indigent and those earning 300% or more of the federal poverty level, but who were nevertheless uninsured or underinsured. Along with additional reforms, we can be proud that the district ranks 7th among the nation's states and 2nd among its major cities in the percentage of its inhabitants who have basic health insurance coverage. In reviewing the legislation, it's clear that the key clauses in the proposed legislation, when ranked in importance to the achievement of the twin goals of transparent and a competitive marketplace, the proposed measure, more important than all others, is that requiring all plans sold in the district to be posted on the exchange. All in, none out. Only that feature of the marketplace guarantees that individuals and small employers have equal access to comprehensive comparative data on all plans certified as eligible for trading on the exchange. Progress for the residents of the district means a single insurance marketplace in which all plans are governed by a single accessible set of standards in pricing, quality, and coverage. A second, less well-regulated shadow marketplace for small employers or other market niche would sabotage the effort to regulate the insurance market openly and fairly in the interests of buyers and sellers. I think I am representative of the majority of health insurance consumer advocates when insisting that the slogan, all in, none out, conveys our single most important concern in this proceeding. With respect to comment on some of the prior discussion, I would say first, there was a discussion about the transition and well-warranted. But the nation, there is a context. The nation is in transition. And we're transitioning away from a market that we know already that doesn't work well. The major dysfunction in that market is a price and cost structure that is determined by the insurers, but totally detached from health outcomes. We're not getting half the results for what we're paying. I also want to refer to Mr. Catania's proposal for an amendment. I would, in fact, go a little further, not only support it as it is, but hope that it might be the first step toward the district setting up its own rate-setting commission. We've seen nearby in Maryland there's been a great deal of success with that commission, and it has proven effective, I believe, in maintaining a health insurance market atmosphere that's consumer-friendly and it's consumer-supportive. I would also point out that there is some confusion when we speak about the need for public outreach for what the exchange is and what it is not. It is not a rate-setting commission. It is not a price control agency. And its impact on prices, for that matter, is pretty modest. Only with the 3-to-1 ratio feature and the fact of transparency in the exchange itself provides some pressure, as we have seen in the Oregon example, on prices. So I would think that this slogan that we are sort of promoting, all in, none out, would be one that helps guide toward a full and responsible exchange and marketplace.
Thank you. You mentioned Maryland has a rate commission.
Yes.
What is the role of the Maryland Insurance Commission? Do you know when it comes to rate buying?
Well, one has a actually a rate-setting commission. The insurance commissioner does a lot more like we do with our Department of Insurance and Securities. For example, when CareFirst Blue Cross Blue Shield wanted to convert from nonprofit to for-profit status, that was a decision made by the insurance commissioner. With respect to rates charged for certain procedures and procedures in the hospitals, the rate-setting commission was that board that sort of exercised supervision over the charge masters, frankly.
So they work with the insurance companies. The
rate-setting commission worked with the companies and the hospitals.
But the insurance commission still approves the rates.
Right, the insurance commissioner approves it, but the insurance commissioner also had the wider authority of making certain that there was enforcement as well as monitoring the programs offered by the insurance companies.
Thank you. Well, thank you all for your testimony.
Thank you.
Thank you. Before I call up the next panel of witnesses, I'm going to take a 5-minute recess, and we will reconvene with our next panel. Thank you.
Oh, good. No. I could be like, oh, and by the way, Massachusetts does not have a single. Oh, and by the way.
Just by definition, those people are going to be in there.
Yeah, no, you're right. People
Are less healthy, and that's
probably
make it possible.
Well, we can survive. Like we sat through how many hours? And I brought someone.
This is when I wish I had brought a pillow with me.
I brought someone from Children's Hospital. She's going to be coming in the town after me. I feel bad for myself, but it works for her. She's got a real job.
A real job.
All I do is talk to people. She's got a real job.
A real job, but she does more than just
talk to people.
Yeah, exactly.
Talk in rooms full of people who have more degrees.
Okay, guys, we're going to get back. Good. Let's do it. Thank you for your patience. Let's do it.
Okay, I love it.
Good afternoon. We're going to reconvene our roundtable. Our next panel of witnesses, Walter Smith, Executive Director of DC Appleseed Center for Law and Justice, Stuart Spielman, Senior Policy Advisor and Counsel, Autism Speaks, and Claire McAndrew, Vice Chair, Health Benefit Exchange Advisory Board. Good afternoon.
Good afternoon. Thank you very much. And I appreciate you hearing from my board member, Deborah Chalet. We'd actually planned to be a 1-2 punch, and now we're going to be a 2-1 punch, if that's okay with you. Madam Chair, a number of organizations approached DC Appleseed and wanted to know if we would come testify in front of you, because I think we are known in the community as having played a role for quite some time with regard to monitoring the performance of the dominant health insurance company here in the region, CareFirst, which has been mentioned a number of times, as you know, so far today. And there is a direct relationship, I believe, between the bill that's in front of you and earlier legislation that the Council passed, and that's the point that I want to make to you. In 2008, the Council adopted a statute I know you know quite a lot about, under the leadership of Councilmember Che and Councilmember Grasso. The Council passed something we call MEIA, the Medical Insurance Empowerment Act of 2008. And the purpose of that act was to put in place a standard to hold the biggest health insurance company in this region accountable to the public, because it is owned by the public. As you well know, GHMSI, which is CareFirst's affiliate, is federally chartered. It is a charitable and benevolent not-for-profit. And under that federal charter, this council was authorized to enact legislation to hold GHMSI accountable to its obligation under that federal charter. And that's what the council did. And the standard that the council passed, and I want to read it because I want to get it exactly right, was that this company, I'm talking about GHMSI, is to, and I quote the statute this council passed, is to engage in community health reinvestment to the maximum feasible extent consistent with financial soundness and efficiency. That's the good news, the standard this council adopted. The bad news is that to this day, That standard, now more than 4 years ago passed by this council, has not yet been implemented. But now there's some good news coming. We expect sometime in the next month or two that the current insurance commissioner is going to complete his work, or at least announce preliminarily the results of his work, to determine whether or not the surplus of this company is excessive under the standard that I just read to you. That will be one avenue to make sure that the assets of this company are used in the public interest. The bill in front of you is a second way to achieve that. Because if, as Deborah Chalet mentioned, we have a competitive marketplace that holds prices down and makes insurance more affordable, more accessible to more people, then further surplus will not be built up by this company. That is the best way to make sure that the standard this council adopted gets implemented. We make sure first that excessive surplus was not built up in the past, and make sure we have in place a competitive marketplace going forward that brings down prices, increases benefits, and doesn't build up surplus going forward. So we therefore support this bill, and we hope that you enact it.
Thank you, but now, can I ask, with regards to the surplus, isn't there a certain percentage of that surplus mandated to be recycled back into the District of Columbia?
That's exactly right, and
so more surplus, more services for the District of Columbia.
Well, yes, but surplus, if you have excess surplus in the company, as the CEO of the company testified at the hearing the insurance commissioner held, if there's excess surplus in the company, it came exclusively, he said, and he's right, from overcharging subscribers. If you don't overcharge your subscribers, you will not create excess surplus. This exchange proposal is designed to ensure more competition, no overcharging of subscribers.
Thank you. Thank you for your testimony. Good afternoon.
Good afternoon, Chairwoman Alexander. I'm Stuart Spillman. I'm Senior Policy Advisor and Counsel for Autism Speaks. I'm also the father of an 18-year-old young man with autism who was born in Columbia Women's Hospital that was in the district. Thanks for allowing me to testify. Autism Speaks is the nation's leading autism science and advocacy organization. We're dedicated to funding research, increasing awareness, and advocating on behalf of individuals affected by autism and their families. In the 8 years since our founding, Autism Speaks has committed more than $195 million to research and has supported innovative scientific and clinical programs. We strive to make life better for children and adults on the autism spectrum as well as their families. Healthcare is a major concern for people affected by autism. Families with a child on the autism spectrum commonly report that their child's health insurance coverage is inadequate to meet their needs and that their child's health condition has caused financial problems for the family. A mother of a child with autism, and I think I should note this since yesterday was Mother's Day, a mother of a child with autism on average earns less, works fewer hours per week, and is more likely to be unemployed than the mother of a child with no disability. The legislation before the Council will not solve all of these problems, but is an important step forward. The strengthened definition of rehabilitative services, the product of a long and thoughtful discussion that began with the formation of an Essential Health Benefits Advisory Working Group in January, will help children with autism get the care they need. Too often, children with autism get a diagnosis and little more. That has to change. According to the Centers for Disease Control, 1 in 50 school children have an autism spectrum disorder. That's a significant increase from previous estimates, but the true picture may be even worse. A comprehensive study completed in South Korea in 2011 found a prevalence of 1 in 38 children, including 1 in 27 boys. At one time, autism was thought to be a rare disorder. That's not true anymore. While the reported prevalence of autism has increased, disparities in identifying and treating children remain. According to the Centers for Disease Control, the estimated prevalence among non-Hispanic white children is significantly greater than that among non-Hispanic black children and Hispanic children. Minority children are identified later and are treated later. There are, in fact, treatments available to help all children. Controlled clinical trials have shown that early intensive behavioral intervention significantly increases IQ, language abilities, and daily living skills while reducing the symptoms of autism. Behavioral interventions that use the methods of applied behavior analysis have become widely accepted among healthcare professionals as an effective treatment for autism. The promise of these new treatments is something we should all strive for. I was a member of the Essential Health Benefits Advisory Group, and we worked very hard to come up with a definition that would serve developmentally disabled children, including kids with autism, and I think we succeeded, and this is very powerful legislation, and we hope for your favorable consideration.
Thank you, Mr. Spillman. I'm so glad that autism is going to be included in the treatment among the benefits through the exchange. It's interesting, the statistic you gave for Mother's Day, that mothers on average earn less or work fewer hours. I can tell you, are likely to be unemployed. Now, I don't know, I think she makes a good salary. I have a friend who has a 20-year-old daughter, but she has worked out of her home. Probably her job accommodated her, actually, to work from her home, and she's been working at home for probably about 4 years. So before then, it was a struggle because she and her husband, I believe, are on different schedules to accommodate the daughter. But that is difficult, so she definitely does work at home, and it's made a major difference for her.
Well, we often think about healthcare in a somewhat isolated way in terms of just purely a public health context, but the financial context is enormously important. As you note, families change what they do to make sure that their children, their young adults, get the health care they need. They'll quit jobs, they'll leave the district if the health care services aren't what will serve their children, and that's an important part of this discussion.
Thank you. And for full disclosure, she lives in Maryland, but still. Maybe she'll move to the district.
Let's hope so.
Thank you for your testimony. Good afternoon.
Good afternoon, Chairwoman Alexander. Thank you so much for having me here today. I'm Claire McAndrew. I'm a Senior Health Policy Analyst at Families USA. We are a national healthcare advocacy organization, and you heard from my Executive Director earlier, but I'm actually here today in my capacity as the Vice Chair of the Standing Advisory Board to the Health Benefit Exchange. We are the body that was formally appointed. We are comprised of multiple stakeholders, and we recommended the proposal to transition the marketplace to a unified market in the exchange. And so as Vice Chair of that Standing Advisory Board, I strongly support that proposal. It is my goal, both professionally and personally, to ensure that businesses of all sizes and consumers of all walks of life have many options for coverage. I would not endorse a proposal that in any way violated that goal. And in fact, I'm so excited about this proposal because it finally opens the market. I've been troubled by this phrase, closing the private insurance market, because the reason I support this proposal is that it opens the black box of insurance terms, insurance policies, so that consumers can see standardized information about health plan costs, benefits, and quality in a way that no insurance plan is exempt from. And to give you a specific example, one of the working groups that I actually also vice-chaired on benefit standardization recommends having every insurer in the exchange offer a standardized plan that would have set deductibles, set cost sharing, so that consumers compare across plans. And I do want to say that's in addition to other plans they would sell, so it's just one standardized plan. But the idea behind this is that when you have your out-of-pocket costs standardized across all the insurance companies, consumers can actually learn what's different about these companies, if the costs that they'll pay out-of-pocket are the same. Is it the quality of the company? Is it the provider network? Or are two companies offering very comparable products, one with a premium up here, one with a premium down there? When you have that situation, the exchange makes it possible for consumers to vote for with their feet. They can go to the plan that offers better value, which is one of the ways, just one of the ways, the exchange will drive competition. But also, by opening the market through the unification proposal, we'll get to a place where health plans, instead of competing on marketing tactics, competing on cherry-picking the healthiest enrollees, or competing in a way where they leave critical plan information to fine print, so they might be attracting customers who don't know what they're purchasing, we'll get to a place where customers are actually choosing their plans based on value through this standardized information. Another term I find troubling that's been used today is the word force, forcing people as if we're dictating a certain product to them. But there's nothing about the exchange that dictates or limits either the number of insurance companies that will be available in the district or the number of products those insurers can offer. In fact, the legislation specifically states that there is no cap on the number of plans a company can offer. Furthermore, any provisions of the Affordable Care Act that affect plan design apply both inside and outside the exchange. So the essential health benefits, the metal tiers of bronze, silver, gold, and platinum coverage, those are also offered outside of the exchange. So I truly struggle to understand what people see as a policy of the exchange that might limit choice or increase costs. If anything, the exchange proposal that would unify the individual and small group markets in the exchange opens the market to regulators, giving them more information than they've ever had in the district about health plan benefits, provider networks, and quality. For example, under the Affordable Care Act, if you want to sell coverage in the exchange, you must provide information to regulators about how you are ensuring that you have an adequate provider network, including essential community providers like federally qualified health centers in your network. So I believe that there is no reason that any health plan operating in the district should be exempted from these consumer protection and transparency standards that will hold them accountable to consumers. Again, we are not forcing consumers into any specific plan. We're not forcing consumers or businesses to forego a relationship with their existing carrier. We're not forcing any consumers or businesses to stop using the broker they've relied on. Brokers are fully permitted to sell exchange coverage, but we are holding the health market accountable to consumers. And I've talked to many consumers, and they are desperate for fairer rates, better access to providers, and frankly just coverage they can count on. And to that end, I do want to say that Families USA really supports an amendment like what Councilmember Catania proposed to strengthen our rate review in DC. I got an email last week from a consumer who told me that he had received a 25% individual market rate increase effective May 1st. He asked if I could help him understand that, so I said, sure, can you send me the explanation of why your rate was increased? And his insurer is a very large carrier in the district, and he wrote back, Blank Insurer's customer service supervisor promised to get back to me with an explanation for my 1-year 25% increase, as well as to discuss my options for other coverage. He never got back to me. So I think that when you have consumers going through that, that really shows how important it is that we do have a public input process that is formalized for people to weigh in on rate increases. Because right now I often serve as the intermediary between a consumer and the insurance department. And I know the insurance department does its best, but after getting this information, I proactively said to the insurance department, can you please let this consumer know next time there is an opportunity to weigh in on a rate increase and how that increase affects him? And I'm yet to hear back. And I know they're busy, and which is why I think formalizing that process is essential. So again, I really support this legislation. I support anything we can do to strengthen our rate review process, and I appreciate your time.
Thank you. Do you know how many states have that review process with the public?
I can get back to you on the public input process. I know that Oregon is an excellent model where there's been a lot of strong consumer input in rate hearings that have had a key impact. And I do want to say that...
And how effective it is.
And how effective it is. And I want to say, too, public input is an important part of this, but the legislation we already have, or the law we have regarding rate review, does list out many criteria that should be considered when improving rates. And to Mr. Smith's testimony, it does include looking at surplus, reserves, profits of health insurers. And to your point about what does surplus mean for consumers, if surplus is used to provide benefit to enrollees, that's great. But if somebody can't get into the health plan to benefit from that because their rates are going up 25%, that surplus is not benefiting them. Surpluses can be most helpful to consumers if they're used to lower rates.
Thank you for your testimony. You also mentioned, and it's important for competition, it's important for rates to be affordable. what would be the deciding factor? So if everyone is within the exchange, all the insurance companies, what's going to be the deciding factor for a person to pick plan insurance company A over insurance company B if they're going to be virtually all the same? What's going to be the deciding factor for the consumer?
So they most definitely will not be all the same. What I was saying is that when you open up the terms of the plan so that the people can make an apples-to-apples comparison. They can see, here's this deductible, here's this cost-sharing amount, here's the quality rating for this plan that's required under the Affordable Care Act to be posted on the exchange website. That's not required outside of an exchange. When they can get all that information in front of them, they can figure out what's different about the plans. And when I was referring to the one required standardized plan, what I was saying there is that by having your costs when you go to the doctor standardized, so you know if I see the doctor, it'll be $20 for a specialist, I have a $250 deductible, etc. Once those cost sharings are the same across the board, you can actually start to figure out, as a consumer, what makes these companies different. Do they have the same cost sharing, yet one has a much broader network? Well, maybe that's why this company costs more. Do they have the same cost sharing, but these quality ratings are much higher, so I'm willing to pay a higher premium? Or, as I was saying, do they have the same cost sharing, same quality rating, provider networks look comparable, but this plan charges twice as much? Right now, a consumer could never clearly gather that information. So
providing a one-stop shop for consumers to see everything.
Right, and a one-stop shop, but also information that's layperson friendly and clear. So no more caveats in fine print. No more flashy marketing materials that don't have any information about the product. Instead, standardized information that's available to the consumer directly, which I think can really make or break competition in the market.
I have to remember, everyone isn't a shopaholic like me. I'll go around and shop around and ask the same questions to 50 people, or go to every store around town and look for one.
Well, I think the problem too is not only is not everyone a shopaholic like you, but also not everyone insurance shopaholic. Not everyone knows the terms that you know about insurance. So you're able to shop around about deductibles, about in-network versus out-of-network, but the average consumer isn't. Even the average highly educated consumer, which is why we need the exchange to have that information in a standardized way, presumably with definitions for each of those terms. We can't guarantee that if plans aren't going through the exchange, they're going to be providing that same level of clear information.
Thank you. We've been joined by Councilmember Grasso. If you have any questions for the panel.
No, I don't have any questions. Thank you all for coming down. Appreciate it.
Thank you all for your testimony. And our next set of witnesses, I just want to ensure that Mr. Paul Brayshaw, did he come in? Mr. Brayshaw. Judith Levy, Coordinator, DC Coalition on Long-Term Care. Kathleen Atmore. Ms. Atmore. Developmental Neuropsychologist, Children's National Medical Center. Wes Rivers. I saw Mr. Rivers. Oh, okay. So just give your name for the record. Good afternoon. Good afternoon.
Good afternoon, Chairperson Alexander and members of the Committee on Health. My name is Judith Levy, and I am coordinator of the District of Columbia Long-Term Care Coalition. I am pleased to testify regarding the Health Insurance Exchange Authority and the pending legislation. The DC Coalition on Long-Term Care has worked with the DC government for over 16 years to develop and implement home and community care options for low-income DC residents with chronic care needs. Its consumers, advocates, and healthcare providers have assisted in the development and implementation of expanded Medicaid home care, the regulations of assisted living residents and home care agencies, and the improvement of the workforce essential to these programs. It is regarding the direct care workforce that I feel compelled to testify in support of the Health Insurance Exchange Authority and the legislation. This is the fastest growing workforce in the U.S. and one most likely will touch all of our lives. In particular, home health aides are vital to the desire of most district residents to age with dignity and in their homes. Yet this group of workers is primarily women, poorly paid, who frequently do not have benefits and have a higher rate of job injuries than minors. Many of these workers are eligible for Medicaid because of poor compensation. The coalition sees the health insurance exchange as another opportunity for these workers to be covered by health insurance. The health insurance exchange should make purchasing health insurance easier since it will supply assistance and support to applicants. This is extremely important to this group who most likely consider purchasing health insurance daunting. The health insurance exchange is vital for the direct care workers who do not have insurance through their agency for a variety of reasons, such as the agency does not offer it, it is unaffordable, or because they are part-time workers. Through the exchange, they can obtain tax credit subsidies if their income is between 200% and 400% of federal poverty level. If they are below 200%, they will, of course, get Medicaid. And a number of them are on Medicaid because of the income that they have. As part-time workers with hours and incomes that fluctuate, with perhaps a spouse whose income may also fluctuate, they could likely be above 200% and below 200% for various parts of the year. That would make them cycle between Medicaid and the exchange. While this is an unavoidable reality for people in every state, it does mean that the district has a vested interest in making sure exchange premium levels are truly as affordable as possible so that people don't feel a massive jump in costs when they move from Medicaid to the exchange. Having one big marketplace helps force better competition and ultimately better prices in the exchange. Home care workers may move between agencies or between full-time and part-time as well. If they are at an agency that buys coverage in the shop and then becomes part-time or moves to another agency that does not provide coverage, if there is a unified market, then their health plan options from their previous employer and under their new position will be the same. It will make it more likely that they can keep their same plan or doctor, even if their work situation fluctuates during the year. Thank you very much.
Thank you. Just curious, the majority of this population already would qualify for Medicaid or the Alliance, correct?
A lot of them would qualify for Medicaid. Not all of them, no.
Do you have any numbers on? I'd be curious.
I can get you the numbers. There are approximately about 6,000 home health aides in the District of Columbia. Mm-hmm. Not all working at this time, but I would have to get you the statistics on how many are covered. I don't have them at the moment.
Okay,
Sorry.
thank you. Thank you for your testimony. Good afternoon.
Hi. My name is Dr. Kathleen Atmore, and I'm a neuropsychologist at Children's National Medical Center. I work in the Center for Autism, and I'm here today to represent children in foster care, the underserved children of Washington, D.C., and the underserved families. And I wanted to speak about maybe a misconception about the wonderful way the law is written to protect children, but the reality is that even with Medicaid, when children come to our hospital and they have a developmental disability or autism, they're not able to see me. And I am the person that, among others, who can identify what they need to function, to go to school, to learn life skills. And so what I've done...
Why aren't they able to see you?
Because I don't know how this happens, but when companies contract with Medicaid, they can change the ways that children have access to care for a provider like me for behavioral health and psychology. So I'm a medical faculty member, but I'm not a physician. And so physicians always have access, but psychologists don't. And I'm a specialist in autism, so the physicians call on me to help them with their patients with autism. So I'm just here to ask that the law, the provision of these services are fairly provided to all children, even those without a parent who can advocate, without a parent who can purchase insurance. I've had tremendous difficulties with kids in foster care getting appropriate services.
Thank you, because I really want to work with Director Barron. That is a major objective for behavioral health care, especially with our young people. And if it takes a psychologist, the entire team effort should definitely be there to care for a child. And right now, is there an amendment that needs to be made in terms of the state plan for your coverage, for reimbursement?
The habilitative care amendment, I don't know if it's an amendment, but the habilitative care is what our services would fall under. So even in the District of Columbia, the diagnostic services, which would be neuropsychology, diagnostic, mental health, behavioral health, it's all different names and different companies. But we can't even see these kids to diagnose autism. So we cannot count the numbers of children with autism in the District of Columbia.
Please follow up with my office on that.
Okay.
Thank you for your testimony. Thank you. Good afternoon. And could you please state your name?
Good afternoon, Chairwoman Alexander, Councilmember Grasso. My name is Dave Chandra. I'm a senior policy analyst with the Center on Budget and Policy Priorities. As you know, Wendell Potter had to catch a train back up to Philly, so I wanted to make sure he made his train home. And then my colleague, Wes, was kind enough to let me hop in this spot.
Mr. Rivers, did you want to provide testimony? Okay. What a gentleman.
Yes, he is quite a gentleman. I have a call at 4 p.m. actually with lots of state legislators from around the country who are tackling exchange issues, and I'm very happy to be able to share with them the lessons we're learning here that Council and others are weighing in. The Center is providing assistance to many states as they implement the Affordable Care Act, the President's health reform law, but we've made it a priority to spend a significant amount of time and participate here in D.C., and that's because we are a nonprofit and an employer here in the district. My written comments are longer and have been submitted for the record, but I really just wanted to focus today on the proposal to unify the market, most of what we've been discussing today. The Center is fully supportive of the proposed legislation that is here to unify the market, along with a number of other standards that it will adopt. The main reason is, frankly, we feel it'll make insurance more affordable and transparent. And that's something we believe that everyone here today is looking for. Consumers, small business owners, brokers, advocates, etc., want to make sure that insurance is affordable and is understandable. And we believe the exchange is an ideal vehicle to foster competition because, as others have said, insurers will have to line up their prices and products side by side on a website in an easy-to-use manner that folks will finally be able to compare and contrast. In setting premiums, insurers will know that that consumers and small businesses can easily see a competitor's price on the same screen. The exchange will also feature quality ratings and other important measures, as well as monitor compliance with all of the market standards set by the ACA and by the district. We think this level of competition and transparency has been largely absent in the market today and is going to be sorely critical moving forward. We believe that combining together groups of consumers into larger purchasing pools will help ensure more stable premiums over time. That's why large employers are able to obtain the best rates. And a unified market in the exchange would provide small businesses and individuals a similar advantage. One big pool in the exchange would spread risk over the largest possible population and limit adverse selection, keeping premiums affordable over time. But in addition, one of the main issues today that's been discussed is choice. And I know, Councilmember Grasso, you brought this up a lot. We believe that a unified market, individuals and small business owners will actually gain significantly greater access to real meaningful choice. It represents a vast improvement over the marketplace that exists today. People usually have a limited number of options if they're lucky enough to be able to buy coverage, and it's very transparent. The Center actually initially advocated for limiting the number of health plans to be sold on the exchange. Research shows that an excessive number of plan choices can be confusing, overwhelming, and could result in consumers selecting a plan that's not necessarily the most suitable. But Director Kaufman and others made compelling arguments that the exchange should allow insurers to offer as many plans as they want, that the marketplace and that different dynamics and consumer selections will dictate how many choices should be there and what those choices should look. So we do, in fact, support the fact that without a limit, the exchange will have a robust number of options. We think there's no reason it'll have any less options. In fact, we think it'll have as many or more. The difference, though, is it'll all be in one place where you can easily find them. But we do want to point out, while individuals and small business owners can benefit from this choice, we really care a lot about what's happening to employees. Right now, they usually get one plan, whatever the employer picks. In the exchange, they're actually able to choose from multiple options. An employer can make an array of plans, 15, 20, even more available. That's the kind of choice that just doesn't exist today. So we do believe that if increasing choice is a priority for the district and for our small businesses, then a unified market in the exchange is by far the better solution. I see I'm out of time, so I'll stop there and we can answer any questions you may have.
Thank you. I don't have any further questions for you, Councilmember Grasso.
I just want to thank you all for coming down and testify. You know, I hear what you're saying, and I definitely take it into consideration as we move forward. Thank you.
Thank you.
Thank you.
Thank you very much. Thanks.
Our next panel, Benita Panino, Government Relations Director, American Cancer Society, Cancer Action Network. Gillian Sherland, Senior Manager, HR and Administration, American Immigration Lawyers Association, and Don Blanchon. Hi. Whitman Walker Health. Welcome. Good afternoon.
Good afternoon, Madam Chair, members of the committee. My name is Benita Panino. I'm the Government Relations Director for the American Cancer Society Cancer Action Network. We have 2 points to make today. The first one is on the unified marketplace, and the second is about access to needed cancer prescription medications. Creating a marketplace is the best way to assure that all residents have access to quality health insurance that they deserve. And doing it in a unified manner is going to, with everybody in the same pool, will help bring the cost of insurance down, especially for those that are going to be on the cusp of being able to afford or not afford insurance, with or without the federal subsidy. We want to have it all in one place. Also, it allows for, as individuals have said before, is a comparison of apples to apples. If we have 2 separate markets, although we may have something outside the exchange that looks similar to something inside the exchange, we can really not compare it. As a consumer, I'm not going to be able to compare that item per item and look at it in an educated manner. What's outside the exchange is not going to have as robust amount of information about the particular policies in comparison to the other policies provided. And individuals that are cancer survivors are going to want to be able to have the full menu of what's being able provided and to be able to look at that in an educated manner. The second point we want to make is on the access to prescription medications. Right now there is a formulary within the exchange, and that is all fine and good. What we would like is to make sure that when a doctor, an oncologist, or another physician prescribes a particular medicine that is not in the formulary, that the doctor's choice and the patient choice supersedes the choice of the insurance carrier to deny the individual access to that medicine. As you know, there are a lot of cancer medicines in the pipeline right now. Your cancer and my cancer, although they most would be breast cancer, it's not the same cancer. My cancer is different than yours. The prescription medication for me may be significantly different for you than it is for me. We want to make sure that individuals have the choice to choose what it is they need. Thank you so much, Madam Chair and members of the committee.
Thank you for your testimony. Good afternoon.
Good afternoon, Chairman Alexander, members of the committee, and staff. My name is Jillian Sherlin, and today I offer testimony on behalf of the American Immigration Lawyers Association. Thank you for providing the small business community an opportunity to express our views and concerns regarding the closure of the outside insurance marketplace. Oftentimes, smaller voices go unheard. Thus, we appreciate that you have taken time to consider how future decisions of the Council will have a devastating effect to our businesses. Based on the recommended legislation under consideration, it appears that the DC Healthcare Exchange Board has lost the intent and true essence of the Affordable Care Act. When the Act was introduced, it was meant to capture those individuals and businesses that did not have or offer healthcare coverage and allow for more competitive yet affordable rates. The intention was not for states, including DC, to close existing markets or force individuals and businesses to abandon existing coverage. Simply stated, exchanges were created to provide alternative options to obtaining health insurance, not take away, replace, or eliminate the existing options readily available in the marketplace. Closing the outside insurance market will do great harm and inhibit growth of small business. As a small nonprofit employer, Oftentimes, we are unable to compete with other larger for-profit organizations when it comes to salaries. However, like most associations, we make up this gap by offering our employees an extremely generous and robust benefits package. We shoulder most of the burden for our employees and dependents, even in the light of premium increases. We have maintained our high-quality, low out-of-pocket triple option plan with our carrier. It is with great trepidation that we await the decision of the DC Council as to our fate as a small business. If forced into the DC Health Exchange, there is certainty that the level of coverage we make available to our employees today will drastically change. As a result of the exchange, we foresee added administrative costs, higher premiums, and lower quality benefits. Our leverage as an employer of choice will be lost for both current and future employees. To members of the DC Health Exchange Board and the DC City Council, our organization would like to know, is it more important to be first or to get it right? We support the goals of the exchange to provide insurance of its relatively small uninsured population. However, like AILA, much of the small business community is not uninsured. Small employer groups are against disrupting the lives of 300,000 plus employees before the exchange has had an opportunity to open for business, operate, test the waters, flush itself out, and ensure that it is meeting all requirements of the Affordable Care Act. How, in good conscience, can the DC Council vote to mandate employer participation in the exchange without first knowing which carriers will participate, what plans will be offered, and potential costs of premiums? Although some on the DC Health Exchange Board would like consumers to believe that the exchange somehow will protect against rate increases, the reality is that rate increases are a national trend, and like it or not, DC is not and will not be immune. Which is more important, to be first or to get it right? If the latter, instead of continuing down the path of forced participation, allow the outside market to continue to operate alongside the DC Health Exchange, if the exchange proves to be better based on affordability and coverage offered, employers, regardless of size, willingly will participate. Finally, if the small business community is forced to participate in the DC Health Exchange as an employer, the DC government should serve as its ambassador and voluntarily purchase coverage for its employees without the exchange. This way, in addition to the small business community, DC also would have skin in the game. There are many pathways to success. If the Council votes to approve the pending legislation, it will be clear to the small business community that the Council has chosen the path most difficult, expensive, and unpopular. Is it more important to be first out of the gate, risk mistakes and failure, or allow time for the DC Health Exchange to settle itself and get things right the first time? Remember, a nation will be watching, and as you ponder legislation before you as a state, consider what you want your legacy to be. Don't simply choose to be the first in the nation to close the outside insurance marketplace. Choose to get the DC Health Exchange right the first time. Thank you.
Thank you for your testimony.
Great to see you this afternoon, Chair Alexander, Councilmember Grosso. My name is Don Blanchard. I'm the Executive Director of Whitman Walker Health. We are a federally qualified health center lookalike, a.k.a. a community health center that served over 13,000 patients last year, many of whom are living with HIV/AIDS or are members of the LGBT community. And I'm going to offer perspective today in part from our role and participation in the exchange planning, but also to give you the voices of the patients we serve who will be impacted by whatever path we take on the exchange. I provided some remarks in a previous roundtable, and I was supportive of the unified market model then. I am even a stronger proponent for that now. I have listened for 3.5 hours to the various perspectives from a whole bunch of different stakeholders. And the practical reality is to build a successful exchange, we need scale, we need transparency, we need competition, and we need to start focusing on the actual delivery of care rather than pricing or market discrepancies. And I want to be very clear about that. A unified market doesn't take away some of the things we need, which is robust competition, market differentiation on products, differentiation on competition between plans, but it's really to bring all of this out in the open, and that's extremely important for us. There are those who, in today's comments, talk a little bit about going slow, or taking a little bit of a breath and trying to figure out how to do this over a 2 or 3 year period. And I would ask that we take the same intellectual rigor that we're putting the unified model through, that we would put that concept or option through, which is there are issues with going slow and trying to do a transition over a period of time where potentially the decisions that you make and how you do the transition actually could threaten the successfulness, the viability of an exchange. And so, for example, you run markets side by side, and insurance entities and their extensions can move risk between the 2 or 3 or 4 models or markets. The pricing is not the same and is not transparent. There are costs in both markets. And that's one of the things that hasn't been discussed today. If you run and you're in a closed market or an open market, but if you run the 2 markets side by side, the insurance carrier, if they're in both, will have costs in both markets. So there are elements to this. I just wanted to make sure that if the council wants to proceed down that path, that we go through that with the same intellectual rigor that we're going through the unified market model. And then the last thing that I think I want to share with you is really the clock's ticking. And those of us in the community health center world that are going to deal with patients and by extension their families know that in 140 days, October 1st is here, and we start dealing with open enrollment issues. And we want to be as robust in how we do education, outreach, getting information to all the different community groups, and we want to do the district proud by doing that enrollment process to the best of our ability. And so we need to move from our perspective, as we shared at the February roundtable, we really need to move from the policy decision around unified versus side-by-side market to how are we going to spend the next roughly 5 months to really do a great job on education, outreach, and enrollment, because that's where the success is. The success isn't going to be necessarily built in on the market side. The success is going to be on the uptake and how many people can we get enrolled into the exchange as quickly as possible. With that, I'd take any questions.
Thank you. So currently, you have contracts, you accept what insurance?
So we have at Whitman Walker over 30 insurances, both public and private. So we accept, obviously, we have agreements with Care First, we have agreements with Aetna, we have agreements with United, both on the physical and the behavioral health side.
And will they also include you as a provider if they go in the exchange?
So we fully expect to participate in the exchange with those insurers. It's in the best interest of our current patients. And then, as I shared with you at the last roundtable, we've got about 7% of our patient base who is un- or underinsured, and the exchange is absolutely going to be the tool by which we move them into coverage.
So they don't qualify for anything at this time? They don't
Not right now, and we have at Whitman Walker one of the most robust public and private insurance eligibility groups that are staffed by attorneys and paralegals, and so we pride ourselves on being able to get people into public and private insurance, and even then we still have about 7% of our patient base.
And so how do you treat them currently?
So as an FQHC, we have a sliding fee scale. So we offer discounts based on their income. And then we also fundraise about 12% of our budget every year. So we fundraise a little over $3.3 million to subsidize care right now.
Awesome. Thank you. I was going to ask the same for the persons living with cancer. Currently, do you know how many in that population currently are uninsured?
In the district of Columbia? No, ma'am, I don't, but I can get you that figure.
And I just wanted to ask you, Ms. Sherlin, with your company and the insurance plan, have you been insured since 2010?
Yes, we have been insured for a longer period of time, so we are grandfathered.
You were grandfathered
Yes.
in. So you're speaking for those that may not be grandfathered in.
Right.
A lot, and I'm just asking, a lot of the testimony today that people testify doesn't apply to them. The woman in earlier testimony who belonged to the Association of Nonprofits, they insure over 5,000 in their network. And, you know, I do agree with you. I feel you advocating for other people, but it's just my concern that a lot of people who have testified today are testifying on behalf of other people. But I wanted to just ensure you that you would not
We are
be in that
actually
category?
testifying for ourselves because we're a small nonprofit organization and we have 60 members, and so yes, we're in the grandfathered status, but what we are saying is that because of being a nonprofit, we're not sure what the exchange will allow, and we're just saying that don't close the private markets until we know for sure exactly what the DC exchange will be made of. And we're just saying that who knows, if the DC exchange does have very competitive rates, we may, get on board as well as other small employers. So that's our take on it.
And would you be able to see that by January 2016?
I wouldn't like to put a time frame on it, definitely, but that is in 2 years' time. 2 years' time, we possibly may be able to make that determination on whether, the rates are comparable or something that we would, definitely think about in getting into.
Thank you. And one other important question, because I think that's definitely important, the drug formularies. And right now, currently, with the market now, a lot of persons don't have their medications covered under their insurance plan, or it changes from month to month. So, I guess I want to ask this, and are you aware with the exchange, and especially with persons living with HIV/AIDS, it's crucial, that their drugs and maybe even the combination of drugs that they have to take is important. Is there is there any mandate on how long that those prescriptions, those drug formularies be in place within the exchange?
I'm unaware of whether or not there are any limits on how long a formulary is in place. What we're asking is that when a doctor prescribes a newly released medication for a cancer patient that is the best drug for that cancer patient, that there is no other drug that's going to treat that individual's cancer, that individual have access to that medication without the insurance industry saying, no, it's not on the formulary. By saying, no, it's not on the formulary, basically they're saying, you can't have the drug that's going to cure you. We're going to let you do some other drug that's not going to cure you. That's a waste of money all the way around, and potentially death for the individual with the cancer.
And how is that going to work out? And this is for, I guess, for any chronic illness.
Absolutely, it would be for any chronic illness. It's going to have to be a decision that can be made by the physician and the cancer patient, that this is the best medication for them. We are going to have to trust our care providers' decisions in doing this. They are going to have the power to provide the medicine that is best for this patient.
Thank you. Thank you. Oh, I'm sorry, Councilmember Grosso. Some questions, I'm sure.
I just have one comment, Mr. Blanchard. I hear what you're saying about having the same kind of intellectual rigor on the other side. I want to assure you that I am already taking that into consideration. When I think about the unified market, I also think about the costs that are associated with not doing it, with what it means to have two separate markets versus one independent market, and all that goes into my consideration. So when I focus on it, I am focusing on all those things. So I appreciate your testimony, but don't sell me short, man.
No, I wasn't selling you short, Councilman, but what I wanted to share was more from the testimony from the group, not from the committee.
Okay.
And what I wanted to hear from, and this is true of anybody who's a proponent on the unified side versus longer transition, is there are ways for the council and for the committee at large to do the transition well. So if it wants to put together, if the council wants a rate review commission to look at it externally for rate increases, it can do that. If it wants to structure an OMSBUD program, OMSBUD person program, so that everybody isn't running to you with complaints, we can do that. If we want to do a transition advisory group, and this is done, not just here in D.C. and other parts of our government, but we could do that if we needed to.
I just think we need to do all of the above when it comes to trying to make sure that the community can be engaged in this. And not feel like when they call somebody or when something goes wrong and they're trying to go through an exchange that is potentially not the best thing in the world at the beginning, that they have recourse. And if the recourse is simply saying, sorry, keep trying, because that's your only option, I think that's not fair. And so that's why I'm raising concerns about it. I think we should still be able to say to people, you know what, you're not mandated to go here. You can continue to do what you've been doing. But I'm open for it. I'm hearing these arguments. I'm listening to them, and some of them are very compelling. So certainly make the right decision as we move forward. I think, Ms. Sherlin, your issue is interesting because being grandfathered in is not. I don't think it's that simple. I mean, I think it was hard work to get grandfathered to where you are, and to stay there is not a simple thing. You're basically locking yourself in at a moment of time. And then, frankly, I don't think that insurance companies have to maintain that package either. I think that they are choosing to do the same, right?
Yeah, we certainly know, because there was discussion on them actually ending grandfather status in 2014. So we know that there's going to be some changes in the market. Yes, we're totally up to that.
Yeah.
But we have had a long relationship with our carrier, and because of this we have been able to work with them and also create specific plans which cater to our employees. And so because of that reason we have been able to get lower rates and get flexible plans which would allow them to choose whatever plan which serves their best interest. And so we have been able to handle those administrative costs and keep it low for our employees and also for us as well. And so we're not saying, no, don't have the exchange. We're just saying, don't take away the choice from us.
Right. Well, I obviously appreciate that point of view. I also think that you shouldn't be too fearful of what you can get when you're in the exchange. I think that there may be a good argument that it's the best place to go and get that kind of variety that you want. I think the argument people make about, right now an employer does really only have the option to say, here, this is your carrier, and now maybe there's some variety in the plans you offer, but not much. In this scenario, from what I understand, the exchange is trying to formulate a plan that would allow people to buy from different carriers, would allow them to buy, whatever fit that individual. My other fear is, though, is that a lot of these smaller entities, under 20, under 25, are going to do the logical thing, which is bump up the salary a little bit of their employees and tell them to go get it themselves on the exchange, rather than go through the kind of headache of trying to figure it out for them. They're going to say, look. And some of the less scrupulous ones might even say, you know what, this is an opportunity. There's no penalties. I can just go ahead and drop everybody, go to the exchange and figure it out yourselves. And, I don't know how we monitor that, and we're going to have to be really vigilant, both at the Department of Insurance, Securities and Banking, around consumer protections. They're going to have to be beefed up there, not to mention also the rate review issues as well. And I think the federal government's going to play a big role there, which I think we shouldn't underestimate the value of that, but also at the exchange board. So thank you all for your testimony.
Thank you.
Thank you all. I was just going to have a comment, but you all don't have to stay at the table. I don't have any other questions. That's okay, Chairman Grosso.
Please, I'd be with you 5 minutes.
No, but I was just going to state how important it is for businesses to know, and how important for the exchange to make people aware of the benefit with the exchange. From what I'm hearing from a lot of people is that they don't feel they will have a comparable plan if they go through the exchange. They don't feel the benefits or the quality of their plans will be the same. And maybe that's something that Ms. Kaufman can address, because I'm hearing that fear of I'm not going to get the best plan through the exchange as I have right now. And that may be a myth that needs to be dispelled. I also wanted to make a comment about the Department of Insurance, Securities and Banking, and I'm really concerned because as a former employee with that agency, with that department, I know what they can do with regards to rate filings and rate review. And if they've gotten lax, in that area, they definitely need to beef it up. And maybe the commissioner can come in to our next roundtable. I think that's really important to answer some of those questions about the department's ability or lack thereof of adequate rate review.
I think you're right on about that. Now, I think that there's a little bit of complexity with this because that agency is now under a different committee than ours, so we'll have to work with that committee. But it would be, I think, extremely appropriate to have him come in and explain what rate review process he's required to go through, how he goes through it, what he does with it, and have that in relation to the new federal reform rate review, which is also an excessive rate review process that is publicized. So I would support that, and hopefully before we take up Mr. Catania's, Councilmember Catania's amendment, which would add more to that regulatory framework.
Definitely. I'd like to call up our next panel. Thank you, Councilmember Grosso. Jennifer Whitten. Okay, that's fine. It's open. Are you going to, is anyone going to testify? So just written. Thank you. Chelsea Crescitti. You have testimony?
Yeah, that is.
Thank you. Ms. Smith will get it for you. Associate Director, State Government Affairs, Consumer Healthcare Products Association. Kathleen Atmore. Oh, already. Vera Meyer, I'm sorry, DC Coalition on Long-Term Care. Okay. Susan Walker, DC Coalition on Long-Term Care. Doreen Hodges. Stephanie Akpa. Barbara Kavanaugh. Ms. Kavanaugh is Executive Director, Employer Justice Center. Thank you. Employment Justice Center. You may proceed with your testimony. Good afternoon.
Chairwoman, Council Member, thank you very much for your time today. My name is Chelsea Crescitti. I'm with the Consumer Healthcare Products Association. We are a small trade association, 35 employees, and we represent the national manufacturers of over-the-counter medicines and dietary supplements. We were established in 1881, and for over 75 years, we have called DC our home. We applaud the efforts by the district to implement the health exchange provisions of the Affordable Care Act. However, we do oppose legislation that may require small businesses with fewer than 50 employees to abandon a health insurance plan that works for them. CHPA provides health insurance to all its employees, and they share in the cost of providing it. While it is the second most expensive employee benefit, it is an incredibly important one. As an association involved in the daily health care, our board and staff leadership understand the importance of providing proper health care to its employees. To be able to maintain affordable health insurance, we work with our broker every year to select the most appropriate plan. In fact, we've switched health insurance providers 3 times in the last 5 years. By doing that, we have been able to maintain a strong benefit at an affordable cost for our company and, more importantly, for our employees. For these reasons, we want to maintain the freedom to select the option that is best suited for us. And our worry is that such a plan may not be included in exchange options. But if the Council is intent on moving forward with a decision to close the private market, we strongly recommend that you take into consideration a few recommendations. First, we recommend eliminating the provision allowing for an automatic end to the private market. A robust transition period is essential to observe how the marketplace reacts to the exchange. Second, with the evidence gathered during this transition period, a much more accurate, well-informed decision about the exchange and small businesses can be made. Finally, we think a decision of this magnitude, with so much at stake for districts' small businesses, should be based on sound reasoning, evidence, and experience, and not on theories and estimates. Thank you.
Thank you. I was discussing, that's just the statement that I made previously, that you are worried about
I know you were just
your benefits. We were on the same page. So we want to ensure that. But in terms of the grandfather provision too, now, it's stated here, and I'm going to verify with the board, that you can make routine changes to include cost adjustments or adding new benefits to the plan. So it's going to be interesting. I don't know what the cutoff is going to be, or what those changes entail. And I think we need more specifics with regard to the grandfather provision as well.
Thank you.
But thank you for your testimony. Good afternoon.
Good afternoon, Madam Chair Alexander and Councilman Grasso. Thank you for this opportunity to speak in support of the Health Benefit Exchange. My name is Susan Walker. I'm a retired home health care medical social worker and now a volunteer consumer advocate with the DC Coalition on Long-Term Care. I would like to start by giving a brief final report on the Health Benefit Exchange work group process. There have been 15 work groups, and I have attended 10 of them as a consumer member. All the work groups completed their work on May 9, 2013. And in my opinion, it was a successful process because so many people took part and honestly exchanged ideas and positions. It was encouraging to see how many people were interested in the outcomes of the groups and how much time they dedicated to attending and participating on behalf of the Health Benefit Exchange. Everyone, consumer advocates, providers, and insurance companies, represented their point of view, and yet in most of the policy issue, consensus was reached except on a few issues. Those issues were decided by the exchange boards, work groups, or committees, and all the recommendations by the working groups were uniquely tailored to the DC community that it will be serving. They have been voted on by the Health Exchange Board to become policy. My main reason, however, for testifying today is to talk about what I think the Health Benefit Exchange will do for low-income DC workers. The DC Coalition on Long-Term Care's mission has been to assist the DC government in developing a continuum of long-term care settings for low-income DC residents with chronic health care needs. It was through these efforts that the Coalition became aware of the plight of the healthcare workers in low-wage jobs who themselves lack health care. The wage issue was addressed by this committee's periodic wage increases for Medicaid-funded workers and then by the enactment of the living wage legislation. The availability of the affordable health care for workers will be addressed by the Health Benefit Exchange. It has seemed ironic to the Coalition that the workers who care for our seniors and disabled were not covered by health insurance. It is our firm belief that the DC Health Benefit Exchange will finally fulfill this goal for those workers who do not qualify for Medicaid or Alliance. For 12 years as a board member of Home Care Partners, a nonprofit home care agency providing care for low-income seniors and persons with disabilities, I've learned how difficult it is to obtain affordable, quality health insurance through the current insurance market for this wage-level worker. Home Care Partners has close to 200 home care aides who provide 1,091 46/7 hours of care for approximately 1,000 people to help them remain in their homes and age in place. Without the services of Home Care Partners, many of their clients would have had to go to nursing homes and have cost the city many times more than home care costs. Home Care Partners is able to provide this quality, affordable care through a contact with the DC Office on Aging and the DC Adult Protective Services. In turn, Home Care Partner aides are paid a living wage of $12.50 per hour, the district's living wage, and many earn more due to their length of service. Home Care Partners also provides personal leave days for each year as well as overtime pay, both a rarity for this type of agency. And for many years, Home Care Partners has tried to provide affordable quality health care as well for its staff, but it's been difficult. Home Care Partners' insurance rates are high because it's mostly female staff and older staff, and they work in a high-risk industry. It is this reality of how difficult it is to provide this level of employee affordable health care that has made the DC Coalition realize that there needs to be another alternative for hard-working, low-wage employees and has caused us to support the DC Benefit Exchange. We respectfully urge the committee to support the exchange so these DC residents will finally be insured. Thank you.
Thank you. Will these individuals most likely go through as individuals or through a group setting? Does do they have, so they're not offered insurance through their employer?
They are offered insurance for their employee, but, with what they make a year and what it costs, even like the lowest price insurance they have is $450 a month.
Through a group?
Through a group. It's through actually the Center for Nonprofit Advancement. And even though the DC Home Care Parties is going to try to pay a significant portion of that in the coming year, it's still a lot of times more than these people can afford. So it's really through the exchange. In addition, it isn't just because they are individuals. Most of them are for families, and if they have to family issue, it can catapult them out of that. So it's really the exchange is the place that offers them the most chance to look at what's best for them to meet their needs and to be insured. And it just seems ironic for them not to be insured when they're caring for all of us.
What would be the difference? I'm a single person, and I take that for granted. So what's the difference between the premium for a single person and a family coverage?
$1,000. Costs $1,000 for a family and $450 for an individual.
Thank you. That's a big difference.
It's a horrible difference.
Thank you. Good afternoon.
Good afternoon. My name is Barbara Kavanaugh, and I'm the Executive Director of the Employment Justice Center. I want to thank you for the opportunity to testify today. It's been a very long day, but a very educational one for me. Unlike most of the other people who have testified before you today, I am not a professional in the healthcare industry. I am not an insurance professional or policymaker, and this is, in fact, my first roundtable. But as the Executive Director of the Employment Justice Center, an advocacy organization for low-wage workers, I am well aware, as many have testified today, of the high levels of health disparities and gaps in access to care in the district. And for those reasons, I would, like many others have today, urge you to support the DC Exchange Board's the single market. However, what I really came here to talk to you about today is my position as essentially a small business owner. I employ 10 people. And as someone running a small business, I know that I need and we need strong health plan quality standards and a unified market. Because as an executive director running a small business, I don't have access to human resource specialists or healthcare advisors. Only under a unified market will all individuals and small employers benefit from the consumer protection and quality standards promised by the Affordable Care Act and tailored to fit DC's needs. As an executive director who's responsible for running programs on a very tight budget, I know that I can benefit from being the member of one big pool for individuals and small businesses to have the same kind of purchasing power normally held only by large businesses. A unified market helps us achieve this larger pool and empowers individuals and small business owners like me by providing me greater health plan choice. Finally, as an executive director of a small nonprofit involved with workplace justice, we are committed to and in fact pay full health care for our employees. I need to make sure that my employees have access to the best plans at the best prices. In the exchange, all insurers can spell as many health plans as they like, but will have to list their products and prices side by side in an easy-to-use online shopping portal. This transparency will force insurers to compete on quality and price and not marketing gimmicks, helping stabilize premiums so they rise slower than they do today. Each budget year, I have to weigh the cost, the increase in wages against what I can negotiate from my staff. So all of this is to say that while you might see my title and expect me to testify on behalf of the low-wage workers who would undoubtedly be served by this legislation, I'm actually here as a small business owner who's directly affected by the exchange and would be unquestionably assisted in providing what I need to my employees by having this exchange available.
Thank you. So you would be one of the small employers that would definitely go through the exchange.
Absolutely.
And you feel that the outside market right now does not benefit you, or you could benefit more?
I can benefit more, as I said, and anyone who's run a small business can tell you, I wear many, many, many hats. I'm HR, I'm, finance management, and when you wear that many hats, you don't wear any of them especially well. And being able to assess the healthcare options that I have to offer my employees is just something that I can do more easily if there was an exchange available to me.
And do you feel, and I know you may not want to take this stance for all small businesses, but a business the size of yours with about 10 employees, do you feel they would probably feel the same way?
My employees?
No, other businesses.
I can't see why they wouldn't. I mean, it really allows us to get better information, more transparent, and to be able to shop and basically, as you use the expression, one-stop shopping, to really comparison shop with the products that are out there.
Thank you. Councilmember Grasso?
Thank you for coming down. I don't have any questions.
Thank you.
Thank you.
And we're going to backtrack. I see Ms. Stephanie Akpa is here. She will come right up. Attorney with the Legal Aid Society for the District of Columbia. Maria Gomez with Mary Center, President and CEO. Eric Vicks. I don't see Mr. Vicks. Ethan Rohn. Is Ethan Rohn? Executive Director, Healthcare for America Now. Good afternoon.
Good afternoon.
We'll shift from right to left.
Okay, sorry for mixing it up. Good afternoon. My name is Stephanie Akpa. I'm an attorney and an Equal Justice Works Fellow with the Legal Aid Society of the District of Columbia. The District of Columbia Health Benefit Exchange Authority has promoted stakeholder engagement from its inception, encouraging a diverse group of stakeholders to take part in the process of building the district's exchange from the ground up. After considering stakeholder input regarding the particular needs of district residents and small businesses, and closely examining the distinct characteristics of the district, including its small size compared to states and the stark disparities in health care coverage, the Exchange Executive Board developed a legislative package that will provide the foundation for a strong exchange. My previous testimony to this committee has focused on legal aid support for the Exchange Board's proposed legislative package as an advocate for consumers in the individual market. My testimony today will focus on legal aid, on the reason why legal aid as a small business that will be part of the shop also supports the implementation of the exchange and the creation of a unified marketplace. First, a unified marketplace will promote freedom of choice. The Exchange Executive Board's proposed legislative package permits insurance carriers to sell as many plans as they choose within the exchange. Moreover, all of the district's major insurance carriers have expressed their intent to participate in the exchange. As a result, small businesses will have access to the full array of insurance plan options in one place and will be able to compare and select the plan that best fits their needs. Many small businesses have never had the opportunity to make a side-by-side comparison of all of their insurance options. The shop will allow them to do just that, enhancing their ability to provide their employees with quality, affordable health care. Second, a unified marketplace will increase transparency, oversight, and regulation. The exchange has built-in consumer protections that, among other things, require insurers to publish prices and benefits so that small businesses can make side-by-side comparisons. It also requires that insurance carriers provide information regarding the adequacy of their provider networks. By having one big market, the exchange and the Department of Insurance, Securities, and Banking can more easily monitor insurance carriers and ensure that they're in compliance with federal and district law. Third, a unified marketplace will help address a competitive disadvantage that small businesses have had vis-a-vis larger companies, a lack of purchasing power. By uniting the individual market and small group market, small businesses will have better access to the lower costs and better benefits that larger companies have long enjoyed. A larger pool will work to spread the risk over more individuals, thus creating better prices for the entire market. The improved purchasing power as a result of this pooling will also have the effect of stabilizing premiums over time. The plan that the Exchange Executive Board has developed will create a strong, viable exchange that is good for consumers and good for small businesses. Legal Aid supports the Exchange Executive Board's legislative package and urges this committee to affirm its commitment to ensuring that every district resident has access to quality health care by also supporting the legislative package. Thank you.
Thank you for your testimony. Ms. Gomez, good afternoon.
Good afternoon. Thank you for taking the time to be with us.
Is your red light on? I mean, your green light.
There's my green light.
Okay.
All right. So thank you so much for being with us today, and Chairman Alexander and the committee. Thank you. With over 25 years of experience in the healthcare business and presently serving over 35,000 individuals in the city, we're keenly aware of the health disparities in this city in both our public and privately insured individuals. I am here to provide testimony to support the DC Health Benefits Exchange effort to ensure that all residents have access to a range of high-quality plans that will improve consumer protections. As important, therefore, is that we truly have a change of the paradigm of our citizens' healthcare outcomes. And to me, in Mary Center and all the people that we serve, the change in the healthcare outcomes is crucial. At Mary Center, what has always been complicated for our employees and our participants has been the complexity of the insurance company benefits and constantly being solely dependent on the knowledge of our brokers. The transparency of our choices and the adequacy of the network that we expect to see with the unified health insurance market under the DC Exchange will be truly, truly refreshing. For most of us running small and mid-sized businesses for profit or not, we will still be soliciting the services of our brokers, no doubt. I don't see that coming to an end. Instead, what we will have is better information to formulate the right questions, which now we don't have the time to really learn about. And it will allow our Mary Center to really make the appropriate choices so that all of our 400 employees can afford to have health insurance through Mary Center. Right now, only about less than 60% of our employees actually take the choice to take health insurance. I have known that for years that we have wasted many hours and dollars trying to understand the best choice of insurance for our employees, and therefore I can't wait to provide the utmost comprehensive plan that keep our employees healthy, highly productive, and knowing that their employer has made the right choice benefit for their well-being. They work way too hard for us, and they provide not only provide affordable and high-quality health care to our constituents in DC, but for us to be able to provide them an insurance that is really affordable and accessible is really our duty. Their wellness and happiness translates to better health care providers and therefore better health outcomes for our citizens. In addition, the online portal will allow also for stronger monitoring and enforcement of what I believe is two of the biggest benefits: the ban on pricing based on pre-existing condition and the coverage for greater preventable health services. To me, these have been the greatest obstacles to young women, causing us to pay too much money at the end of a preventable health issue such as cervical and breast cancer. Too many lives in my 25 years of experience have gone through this. I urge you to consider the Unified Market Exchange to improve the quality, affordability, and accessibility of health plans sold in the District of Columbia. This is not only the right thing to do, Councilwoman and members of the committee, but the only thing to do given the number of people that will qualify and need to be insured. Thank you.
Thank you. I thought that you provided free health insurance for your employees at Mary Center.
You're kidding, right?
Yes, I
We provide $7 million of free care to our community. $7.2 million last year.
And how many referrals do you think you would be able, are you letting people know through Mary Center about the healthcare exchange?
Every day we have a home visiting program that goes from home to home, and we're trying to make that message right now. And we have many people, actually many of our clients who actually would qualify because they're at that place where they just make, a few dollars, but can't be on Medicaid and can't afford health insurance right now.
Thank you. Thank you for all your work. And Mr. Rowe, good afternoon.
Good afternoon. I thank you, Madam Chairwoman and Councilman Grosso. Thank you for giving me the opportunity to testify today on the Health Benefit Exchange Authority's proposal for a unified exchange, and I would also be remiss if I did not thank you for your endurance today, because that is very, very, very good. I am the Executive Director of Healthcare for America Now. We are a DC-based but national coalition that led the fight to win health care reform, and we now work to promote the Affordable Care Act and protect Medicare and Medicaid. And I myself live here on Church Street in Logan Circle. The way I think about the Affordable Care Act is very simple. It's about providing health insurance for people who don't have it and improving it for people that do. And so we are blessed to live in a city in which 93-something% of the folks have insurance. So let's make it better. Let's make it better. And that's what the ACA does, and that's what your proposal does. No more pre-existing conditions. No more lifetime limits. None of that business. And so that is part of what's going to make people come into the marketplace. And we've talked a whole bunch. People have kind of made every point. And I apologize to the people who are going to follow me. But darn near every point's been made. Right? We've talked about what a common sense proposal this is. What have we talked about all day? We've talked about the fact that people are going to be able to compare, businesses are going to be able to compare plans side by side for the first time ever. And as a result, people are going to have choice. And that's what will bring us competition. No more of the 75% of the market being controlled by one insurer. That does nothing for the consumers who live in this city. Now, the last couple of things I want to say is this. What the unified market will help us do is it raises the standards for the care we get. Now, I think as district residents and as folks who work here, I think we deserve that. I think we deserve the best care. Now, I am also all for setting a national example. People have talked about that, and I am for that. I would love it if we could be the best of the 18 states, have the best exchange, right? First, we got to become a state. But in the meantime, right, that's not an incidental thing, right? That would help. That would help us be the best state. But in the meantime, we can have the best exchange. And then we can let the folks know who have states, what it's like. I want to say one or two things about the implementation, and you've raised some very good questions, Mr. Grosso, and that is very simply this. Whatever we do, it's going to be a first. So there will be lessons learned. That's what the 2-year transition is about. And the only thing that I want to say about that is this. If the insurance system wasn't broken, we wouldn't be here today. And the bifurcated market is about preserving the broken system alongside the good one. And if we're going to take a few chances, if we're going to move forward and do what's best for small businesses and individuals, let's unify the market, let's learn lessons together, let's implement this in a way that makes sense, and then let's focus on driving people to get enrolled. Because in a few short months, that is all we ought to be talking about. Thank you.
Are you running for anything? Because I'll vote for you. Let me know. Follow up with me.
That is very kind.
Thank you for your testimony. Now, you do believe, and your position is that market should be unified in the exchange.
Yes.
Correct. Okay. And with regards to the transition, That's just a definite. Do you have any position on that? January 2015, January 2016?
In terms of the specific dates, I don't want to punt. What I would say, which is that, what I want to say is, I think that's what makes that's what those of you who are deep in the details should do. I do want to say this: I am a strong supporter of the transition because there will be lessons learned, and there will be some bumps in the road, and I'm okay with that. Right? I'm not worried about that in the rest of the country. As a supporter of the ACA, people always hammer us and say, well, this is happening and that's happening. So transition good, lessons learned important, and which specific date? I think that's what makes the most sense to those of you who are deep in this.
It's just, I guess, well, what if the district government, and this has been a proposal that people have said, to just have all district government employees insured join the DC exchange? And then would that be a game changer in terms of the mandate for small businesses and individuals going through the exchange?
I haven't followed the discussion on that, and so I suspect there's a little bit of politics involved.
Say about 35,000
right.
Insured. And the reason why I said it was brought up before, I know many states had a risk pool before, and the District of Columbia never had a risk pool for the uninsured. This was before the alliance, took place, before we had so many residents covered with insurance, and that came up before about a risk pool for the district. And when we talked about district government employees, everyone kind of said, well, maybe we need to rethink this. But I'd just be curious if anyone had thoughts on if we just said, forget this about, going back and forth with the small business market, let's just mandate district government employees go through the exchange.
Right. I want to take that as an opportunity to say one thing that relates to the exchange. That I believe that the purpose of the ACA is to get folks covered, make insurance better, but to do so by enhancing the employer-based system. Right? I don't think that the goal is to get everybody into the exchange, because I think we want employer-based insurance. We're not talking about changing the system. The debate in the Congress was about just that, and where everybody landed was, we're going to build on the employer-based system, which is to say, we're going to build on the system we have in the United States and make it better. And so there are enormous complications that you know better than I that would be involved in moving district employees into, not that there's any politics involved, but there are important things like a union contract and everything else.
Well, some small businesses say that's great, that their rates are sky high and they want to give their employees the best coverage. Some are saying, I'm afraid that I have this great plan now and I don't want to lose it. So how do we, how do we console or put their minds at ease to the small businesses who are saying, I like what I have now, leave me alone? How do we answer them?
As I understand this proposal, you're a small business person who's going to be able to get the same plan or the same type of plan through the exchange. And
so I go through the exchange.
The reason to go through the exchange is because over time it will make the cost of insurance lower because you'll have larger purchasing power. If you're sitting out
so
here...
we do want everyone to go through the exchange.
We don't want we're talking about small businesses. I'm not talking about whether or not you move the entire government. Right now what we're talking about is what happens if you had a bifurcated market. All sorts of problems occur. One is the insurance companies get to do one of the worst things they do, which is skim. Right? They just get to collect healthy people right outside the exchange and send the unhealthy people into the exchange. That would drive rates up for the folks in the exchange. The alternative is put everybody in the exchange. And over time, my plan, the one I like so much, my small business plan is going to do better. We're going to reduce administrative costs, and we're going to take advantage of the purchasing power and all of the things that the Unified Exchange is about.
I think Councilmember Grosso wants to continue this questioning.
So how does it reduce administrative costs when you add another government agency to it?
You're bringing together all the different plans. And so, for example...
No, I mean, like, just basic administrative costs. I hear what you're saying. I'm not trying to disagree with you, but I don't understand how it... Like, I think everyone already agrees that there's going to be rate shock that goes into this exchange. You're not going to have lower rates at the beginning. I agree that over time, if you have the right utilization and you have the right pool and you get the right risk mix in there, you can actually bring costs down over time. But I do not see how when you first start, if you put everybody in the exchange, you're going to see a lowering of cost.
I think that, and this isn't my area of expertise, but I would say this. Number one, it depends how you buy your insurance. And so it depends on whether or not you buy it through a broker or whether or not you buy it directly.
That's right.
So if you shop directly, I think you're going to save some money. And if someone were to decide, and I very much respect the work of brokers, but if someone were to decide that because of the simplicity of the exchange, that they were going to purchase, right? If a small business person said, because of this simplicity, I'm going to go with the exchange, right. They've just saved money. And then over time, more small businesses would want to be in because of the power of the purchasing.
I hope you're right. And I've said this before. I think everybody is buying into this, and I think there's some value in that. I'm afraid it's not going to work like that. And there's a lot of unpredictability. And I think you have made a good point. The transition is really valuable here. I'm not saying I advocate to put 35,000 D.C. residents into this, but if you want to build a plan that has the right mix and has the large enough risk pool to actually spread costs, that's how you do it. I mean, that's how insurance works. And so, one of the ways to do it also is to try to mix the risk pools across inside and outside the exchange, which has been discussed, which is also possible and is part of the ACA as we move forward. So there will be a lowering of cost across it. I think, as Councilmember Catania raised, another way to do it is very arduous, intense rate review. That's very important so that you are transparent about what the costs are. I think some people will be surprised over the long run to notice that the costs are not necessarily built in just to the insurance rate, but that it's also the cost of medical care and the number of procedures that are referred and used on a regular basis that may or may not be necessary. So I don't see how I do not buy your argument at all that in the beginning there's going to be lower costs. I think there aren't going to be, and I don't think we should have people thinking that way. So. But at the same time, it seems like most people think that this is the way to go. So more smart people are dealing with than I too. So I think the prudent way to do it is to have a transition period that is fruitful, that allows us to ease into it in a way that doesn't neglect the possibility of people getting in there and actually come out on the other end with something that's feasible that we buy into. Because part of this, and I know a lot about Massachusetts, I think part of the deal is that, you've got to get people convinced that they want to do it. They got to buy into it. They have to embrace it. They have to want to do it. And if you don't do that, which means you don't have a very good website, you don't have a very good system, you're not answering the phone, you're not answering questions, all these things that go with normal insurance companies, and all of a sudden it's in the exchange. If you have any similar problems as you do with normal insurance companies, you're going to have, I think, a conundrum on your hand if you're forcing people to go in. That's why it's important to have this transition period.
Right, no, I understand. If I could, I just wanted to say two things, because I think what you just said is really thoughtful and raises some very good questions. And so the first thing is we're building an exchange anyway. We're building one, and we're going to build the best one we can. And the Exchange Authority is terrific and has great staff and is moving forward fast, and that's great. The second thing is what I would like to say as a small business person. Forget who we are and what we do, because we're trying to keep our health care costs down as well. I want to have an investment in how well the exchange is built. And I want every small business in D.C. to have an investment. When I walk down Church Street, I want to look at all the restaurants I go to, and I want to say all those people are rooting for the exchange, because in a couple of years, they're going to be in it. That, I think, is how we produce good government.
One last point, if I might. I think, you're touching on something, but it's just on the edges. But I think there is an individual mandate, too, that people forget to mention on a regular basis, and so that will drive people into the exchange as well and help, diversify the risk pool. Your comment on 18 states and us being the best, it's irrelevant whether or not we're a state in that regard. I'd like to be a state someday, but we can be the best as a city, and I think we have to strive to do that. And, that makes it harder, really hard. There's a lot of pressure out there in the community to say, hey, adopt the federal, exchange. Embrace it, adopt it. We did that with the high-risk pool. We did not to build our own high-risk pool for a lot of the same reasons why I think some people are scared that this isn't going to work. And so it's something to keep in mind. I guess we can always fall back to a partnership with the federal government if it doesn't work, and I think that's valuable to mention. But anyway, I'll shut up. I could ramble on all day about this, and that makes me completely unusual, I know. So, thank you.
I'm glad to have you as an active member on the Health Committee. Thank you all for your testimony.
Thank you.
Next, Ms. Shirley Smith, who has been waiting very patiently, and Frank J. Oldham, Jr., a member and founding committee of Positively Healthy, I should say.
Thank you.
Dave Biderman. Mr. Biderman is not here. Are there any other witnesses who are here who would like to present testimony at this time? If not, you are our final panel before our executive witness. Good afternoon.
Thank you.
Good afternoon. Good afternoon, Councilman Alexander. My name is Shirley Ribbon Smith. I'm a resident of Ward 5, ANC Commissioner for ANC 5B01. Yes? Oh, they said do not touch, so. Can you hear me now? Yes. Okay. My name is Shirley Ribbon Smith. I'm a resident of Ward 5, ANC Commissioner for ANC 5B01, and the current Chair and Treasurer of ANC 5B. I come before you this afternoon in support of B 2240. Today's health insurance marketplace is a difficult place to be if you are an older American trying to purchase health insurance on your own. That's why I'm here to support B 2240. This legislation puts in place the final pieces necessary to ensure that the D.C. Health Benefit Exchange is able to create a new marketplace that enables district residents of all ages to purchase quality, affordable health insurance. Many people don't want to work until age 65, or depending on their job, simply can't work right up until Medicare eligibility. Yet if you are between the ages of 50 to 64, you often fall through the cracks between private insurance and Medicare. In today's unfair health insurance marketplace, all Americans are left at the mercy of health insurers. They look into our individual medical backgrounds. If we survived cancer like I have, or successfully managing diabetes, or have suffered from depression in the past, they would exclude those services from our policies, even though that's what we need health insurance for the most. Until the Council took action to limit age rating in response to passage of the Affordable Care Act, we were even in a worse shape. Before April the 8th, 2011, insurers had unlimited freedom to charge older adults outrageously high premium based on our age. The Council acted quickly on that legislation to protect older district residents, and I urge you to do so again with the bill before you today. I'm thrilled that change is coming between excluding needed medical services and simply refusing to sell insurance to us at all. Thousands of older district residents are uninsured today. If the Council approves B 2240, people of all ages will be guaranteed the right to purchase health insurance without being underwritten based on our medical histories or our gender. Insurers will no longer be able to deny us coverage because they think we might actually use our health insurance benefits. As by creating one big marketplace, this legislation seeks to get the best value possible for consumers. It is especially important for those of us on the upper age spectrum. The law still permits limited age rating by insurers. Thus, we will still be paying more for our health insurance than our younger counterparts. I strongly endorse this legislation and urge the council to move quickly to enact. It is my understanding that health insurers are filling their rate proposals any day now. We don't have time to wait. To paraphrase Mayor Ray, one city marketplace. Thank you very much and have a blessed day.
Thank you, and congratulations on your story, your survival story. I did not know that, but I know what a wonderful silver fox you are.
Thank you.
Thank you. Good afternoon. You are our final public witness.
Thank you. Good afternoon, Chair Alexander, and also to the Councilman Grasso. My name is Frank J. Oldham Jr. I'm a member of the founding steering committee of Health HIV's National Coalition of People with HIV/AIDS. It's called Positively, with a Z, Positively Healthy. And I'm a person living with HIV for over 25 years. I won't go aside from the remarks, though, because there was a very interesting, and this will only take 2 sentences or less, value discussion I thought we had here. You know, as a person living with HIV, and someone who has been a part of the gay community for over, since I was 17, you have a circle of friends, and in New York City, where I had mine, there are only 3 of us left today who are alive. I also have a circle of friends in Denmark, which has universal health care. I lost 1 friend to AIDS there. 1. Where in New York, I lost almost everyone. And so I just want to say that the idea of the exchange, the idea of the Affordable Care Act is really about, it really is a matter of life and death, because when you have universal health care, it did save people's lives. I lost 1 person in Denmark, all 24 people in New York City. So that statement. Some may ask about why a no advocacy organization now, and why are we devoting ourselves to HIV?
I hate to cut you off. Can I ask you, but what year was that? Because now, with so many enhanced treatments and medications out there, that was some years ago, was it not?
It was, and I'm so glad you asked that, because I also had another note. The other thing is that here, where we have 19% of people who have HIV, 19% of those who have HIV are adherent to medication. Though again, we have universal health care, 85% of people adhere to their medications.
Okay, that's good news.
So even that has changed, and actually I was told it's very hard in that city, in Copenhagen, to get HIV because people are adhering to their medications. Treatment is prevention. Whereas here we don't have that. We have less than 19% of people adhering to their medications. So again, it's another case for the exchange of universal health care. So we have this organization called Positively Healthy, which is an initiative with HIV. Some will say, why we have a new advocacy organization. We're devoting ourselves to HIV/AIDS advocacy for those of us fighting HIV, first as a call to action for other advocacy organizations to come together and to unite. We need to work together. We need to consolidate our efforts. We need fewer and more focused advocacy organizations. We need fewer but stronger advocacy organizations. But this is not the sole reason why I've come here today. The reason I've come is because we need a new voice in advocacy that we need to ensure health care reform, the Affordable Care Act, for people living with HIV/AIDS. Health care reform works to combat the spread of the disease, and we need to do this with the exchanges. Health HIV is Positively Healthy strongly supports the Affordable Care Act and the award efforts of our President to expand insurance coverage for all Americans. As people living with HIV/AIDS, we are, of course, very grateful for the support that we have received from the Worldwide Care Act and the AIDS Drug Assistance Program. But I am here to remind you that we are not just bags of virus. We have arms that can break, we have hearts that break, and so will be comprehensive health care insurance that health care reform brings. For those of us who live in the district, 14,000 people live with HIV/AIDS. We are so grateful for the mayor and to the City Council, Chair Alexander, who have embraced the Affordable Care Act instead of fighting it. We want to expand Medicaid Early and the Alliance. That leadership has taken the city to 93% coverage for adults, the second highest innovation after Massachusetts, and 96% for kids, the highest in the nation. We are so proud to be a part of this in this remarkable city. Thousands of people living with HIV in D.C. have transitioned smoothly off AILAC to Medicaid, and now with the exchange, we can close that gap even further. We hope that transition of those who go onto the exchange is smooth, and we will work with you to help that transition. We will also work with you to encourage people to learn about the exchange and to enroll those who are still not fully insured. We are very encouraged by the exchange's focus efforts to reach out to the LGBT community, which has been the most greatly impacted by HIV/AIDS in the city. This focused outreach to our community will go a long way to bring the LGBT community out of the shadows and pull us away from our fears of exclusion by providing a special sustained outreach. We support and applaud the council and the city for creating this exchange, one of the first in the history of the nation. But now let's talk about the future. Change brings hope and also brings anxiety. Will Medicaid and the insurance provided by the exchange meet the needs of people living with HIV/AIDS? African American women, economically disadvantaged and poor African Americans, Latinos, and gay men. Our city is diverse, multicultural, and complex, like so many other large urban centers in America. Under Medicaid, only 1 in 5 persons living with AIDS collectively took care in the first year they were diagnosed. Only 1 in 5 in the first year. Early treatment is essential. More than ever, early treatment is essential. We want to help people preserve their immune system. We also want to help communities stop the spread of the virus. Having everyone on medication as soon as possible is critical because it slows the spread of the virus. Treatment is prevention, so we encourage the exchange to ensure that all providers are providing universal testing. We also encourage the exchange to work with providers to start fourth-generation testing, which closes the windows period and finds positives even earlier. We're therefore calling for a carve-out of HIV testing for managed care organizations there is no disincentive at any level for HIV testing. We want to continue to increase testing. This is not going to be expensive, but it is to promote testing within the healthcare system, and it sends exactly the right message. Regarding medication, we encourage the exchange to promote uniform standards and state-of-the-art formularies. Instead of reinventing the wheel, we recommend using the Right-of-Way Care Act process. We do not want people living to change medications when they change health plans or coverage or go on Medicaid or the AIDS Drug Assistance Program or any other insurance. We also want to encourage the exchange to promote excellent standards of the right-of-way care programs concerning support services and retention and care. Staying on medication for a lifetime is critical to our health. PWAs need support services like those in Ryan White. The private sector insurance needs to start providing those same kind of support services. Support services are essential to us. They save lives. We've learned that from Ryan White. It is successful. And my closing paragraph.
Your closing paragraph?
My closing segment.
Okay.
3 sentences.
One line. You took up for you and the person next to you.
Okay. I can move to this seat. Okay.
His time is up too.
It is, well, the number one thing is essential that health care reform works. And if we get it right for people living with HIV/AIDS, it's a very complicated disease. We can get it right for everybody else. On behalf of Health HIV, Positively Healthy, the new national coalition advocating for HIV-positive communities, and 1.2 million people living with HIV/AIDS, universal health care is a right, and we're very thankful.
Thank you for your testimony. And if you heard an earlier testimony, Don Blanchon, who is working definitely with the providers, that hopefully they will have him on board as a part of their network through the exchange. And I can assure you that the Department of Health, as well as my office, are working hard to get the awareness out there, to get tested, to know your status. And we're working with every demographic across the city with those efforts. So I do commend the Department of Health for their efforts with that, and we will continue to do that. But there are many important factors with the drug formularies. You said it's so important to get into treatment within that, that year of diagnosis. It's very important. So we're going to ensure that that happens. There have been a lot of working groups and a lot of HIV/AIDS advocates and experts that have been working on those groups. So I do thank you.
Madam, we thank you for your leadership, Chair Alexander.
Thank you, definitely. Thank you all for your testimony
Chairman
and your
Alexander,
patience.
one of the things for sure in our community, we have not, it's surprising that we're talking about September. And there's no literature. As ANC Commissioner, we have not received anything to take out to our community. There's been a couple articles way back in the Federal Diary back in January, February, saying that it was coming. But not enough information has been out there for the older.
And that's important, and I should have asked you in your capacity of advisory neighborhood commissioner, because the commissioners are across the city, and the exchange committed to working with the ANC to make sure the word is out there, that you get the word out. You have not received any literature or any training. There was supposed to be a fact sheet to be compiled to give out to every ANC commission, and I will keep you up to date. I will ask the board about that, because we need that. If we want to start enrolling, up and running by October 1.
And we're willing to work with you. We've talked about that at different times. People are willing to work in the community. I think this is the providers and those who are going to benefit or could benefit.
That's a must, because I know each of your single-member districts is 2,000 people.
Right.
We can cover the entire city just through the ANC commissioners. So I definitely will follow up. Thank you for bringing that up, because the education and outreach portion is a major component in the success of the exchange. So thank you.
Thank you.
Thank you all for your
Thank you very much.
And next we will hear from our Health Benefit Exchange board members who have waited so patiently throughout this entire hearing. Since 11 o'clock this morning, Dr. Mohammed Akhtar is the chairman of the District of Columbia Health Benefit Exchange Executive Board, and Ms. Mila Kaufman is the executive director of the Health Benefit Exchange. Good afternoon.
Good
and
afternoon.
Welcome. And I truly appreciate you remaining for the entire hearing. If you don't mind raising your right hand, do you affirm under penalty of law that the testimony you're about to give the Committee on Health is the truth, the whole truth, and nothing but?
I do.
Thank you. And I have both of your testimonies, so you may proceed.
Thank you very much, Madam Chair, members of the committee. We truly appreciate this hearing, and this has been very instructional to all of us. And the hours got long, and I want to be brief before I turn it over to my colleague, Ms. Kaufman, to present the testimony on our behalf. I want to make three different points. The first one is that I want to thank you, Madam Chair, and the members of the Council for your work over the years to make sure that the people have access to care. I want to review this a little bit so that people who are watching by the television see what you have done and where we are, why we're doing this. After the closure of DC General Hospital, the council, the mayors worked together to create the Alliance program. It's been an invaluable program. This was a new venture at that point. Not many cities. In fact, I know of only one other place where people try to do something like this. But you stepped forward in faith and said, we're going to have a Alliance program, and today it's an invaluable program, serving thousands of people living in our city. When the law was passed, and we were given the authority to expand Medicaid program up to 200% of the poverty level, we became one of the first states to really take advantage of that program. And the moved people from the Alliance over to the Medicaid program. We now have one of the best Medicaid programs in the country still. There are only two other places where people have tried to reach 200% of the poverty level, what we've been able to do in this. So we've always been very progressive in moving ourselves along with the new opportunities that are presented to us. What a good way of moving our residents for whose care we're paying 100% to moving it on a 30-70 rate where 70% of the funds came from the federal government. I congratulate you for being so upfront in taking care of our folks. After we did that, we recognized that even if everybody has health insurance, everybody's covered by Medicaid program, there were not going to be enough providers. So the City Council and the Mayor took the tobacco funds and invested into creating the primary care centers. And Madam Chair, some of those centers are located in your ward, and every ward of the city where there's underserved population, we have those centers. And now where we are is the last phase of covering our people. We have only 7% of our citizens who are uninsured. We are second only to Massachusetts in the nation. And Massachusetts started way ahead of us. And so I congratulate you, I congratulate the Mayor for their work, what they have done so far. It's only 6 months ago that I sent a declaration letter to the federal government saying we are ready to have our own exchange. We are fully committed to have it for our own people because we could do the best job for our own people rather than giving it to the federal government. In 6 months, we have come a long way in implementation of the health care reform. We are on time, we have met every single deadline, and somebody earlier mentioned that we also passed the federal inspection of our program. Where we are now, we wouldn't be if you had not moved, Madam Chair, personally, the emergency piece of legislation giving us the authority so we could hire much-needed IT people to really get the job done. So I salute you. Tradespeople, thank you for moving that agenda forward so we will have the exchange, and I could promise you exchange door will open on October 1, 2013, and we'll start enrolling the people. And the second point I want to make, Madam Chair, is that board has been working very hard. Board member work without compensation because they love the city and they want to do very best for the people of this great city. And they work together with the community. You saw many of the stakeholders come in today and testify. Those who agreed with us or those who didn't agree with us, but they all were part of the process. So the legislative package that we have submitted hasn't come from one department, one person, or one entity. It is the community's total effort. It is a compromise that all the stakeholders have made and presented it to you. And I want to make that very, very clear that it's not that something I developed. Somewhere 80 to 85% of the material in the package is consensus, where all parties, all stakeholders agreed on something. There are a few things where we have to make the decision. And now I want to make 3 points about what is going to be new in addition to all the federal protections that Affordable Care Law provides, all the arguments that you heard about the single unified marketplace. Wherever there was a possibility of a flexibility for the exchange to move away from the federal guidelines, which are pretty strict, we have taken that flexibility to help our people be served better. The first area where we took the flexibility was to create the parity with mental health, the behavioral health. Mental health is a chronic condition, just like no different than diabetes. We don't put limit on the people's visit for diabetes, but we do put limit for people with mental health, behavioral health services. So for the first time in Truly, we created a parity, and board voted for to create that parity. The second area where we recognize that people's condition change, circumstances change in their life events, their income goes down, they lose their job, they may move from one insurance plan to another insurance plan. So I work to create a seamless system of transition where people can transition from one plan to another. In fact, board voted that in case you are undergoing a treatment and your plan changes, you move on to a different plan, you can still continue to have your providers, existing providers, until your treatment is completed or 90 days. And that is something that's going to benefit our people enormously. And the third thing I want to say about our work is that smoking is a pre-existing condition. And the federal government puts a big surcharge on the smokers, had allowed for people to do that. And we agreed in our city that since smokers, some of them are very low income people, that there will be no surcharge on the smokers, because we think the best thing we can do for a smoker is to bring them into treatment. By counseling, by medical care, they can quit smoking. We can help them quit smoking. And that's the move that we have made. And this is, again, a very, very important thing that we have done. And finally, Madam Chair, as I said before, we board members work without compensation. We have no vested interest. We're just trying to do the very best under the constraints of the federal guidelines to provide services to people. One thing we want to make sure is that the people living in D.C. get their fair shake in the program. And that is one reason that we put together the legislative package that you have. It provided the best possible opportunity for our individuals who are uninsured and small businesses to be able to get the maximum benefits, protection as well as additional services that are provided, so that the people will benefit from it to the best of our ability and to have their health status improved, and we truly become one city where everybody has an equal chance to be healthy and happy. And that's the board's policy decisions, some of them that I presented to you, and I'm going to turn it over to my colleague, Ms. Kaufman, to give us the update since our last roundtable on the progress that we have made on some of the technical issues. So, Ms. Kaufman.
Thank you very much, Chairperson Alexander and members of the committee and Councilmember Grasso. My name is Mila Kaufman, and as the Executive Director of the DC Health Benefit Exchange Authority, it is an honor for me to be here again with you. Today, I would like to give you a quick update on the significant progress we've made to ensure that we are open for business on October 1 this year. I also would like to briefly discuss why we need you to pass our legislation called Better Prices, Better Quality, Better Choices for Health Coverage Act of 2013. The District of Columbia has within its power to establish a truly competitive, consumer-centered, private health insurance marketplace for residents and small businesses here in the district. Together, we can ensure that individuals and small business owners have access to high-quality, affordable coverage, a marketplace exchange where you can choose coverage that meets your budget and needs, a marketplace where you can choose to buy from all insurance companies a policy of your choice, a marketplace where you don't need a PhD in insurance to compare prices and options, because you will have basic information to make smart choices, where all prices and easy-to-understand options are there for you in one place. Look, choose, and enroll. As simple as that. And get tax credits that will make premiums more affordable. Tax credits that will be paid directly to an insurance company of your choice for an insurance policy of your choice. Madam Chair, I'm not going to read my testimony. If I can have your permission to have it entered as part of your record, I just want to highlight a few things that were discussed earlier today. First of all, we are building an exchange from the ground up with diverse stakeholders involved in our policy discussions and our policy decisions. We're building the district's exchange to serve the first family if the president decides to enroll his family. We're building our exchange to serve members of Congress and their staffs. And most important, we're building the district's exchange to serve the individuals, the families, and the small businesses who live and work here in the district. So that is our standard. If it's good enough for Congress, if it's good enough for the first family, we want to make sure it is good enough for everyone who lives and works here in this great city. So with that, I want to give you just a quick update on where we are. Recently, we received some terrific news, and this is a direct answer to all of those naysayers who didn't think we could do it. As you know, in January of this year, the city signed a contract with our IT vendor, and thanks to your leadership and the support of you, Madam Chair, and Councilmember Grasso, we were able to get our procurement authority clarified, and because of that effort and the commitment of the entire team at the Exchange, of Director Burns at DHS, of some of the terrific staff who've been working on IT issues like Marina Havan and Suzanne Peck, who work 24/7 to get it done, we were notified that we were the first state in the nation to pass Wave 2 testing for our IT. So thank you for all of your support and the mayor's support and the support of all of the board members and the staff to make that happen. The second piece of good news we've recently received. We were notified by all 4 insurance companies who are in the individual and the small group market here in the district that they plan to do business through the exchange. So that means that Aetna and CareFirst and Kaiser and United, which is 100% pretty much of our marketplace, all 4 companies will be doing business through the exchange. And in fact, one of those companies told us that it plans to sell as many as 150 different products. So that's terrific news. We know that all insurance companies will be participating. In fact, the same 4 will be participating in Maryland. And they'll be offering lots of options to people who purchase coverage through the exchange. I also want to tell you a little bit about some of the progress that we've made through our policy working groups. Initially, as you know, when the board and I set up a community-based process to help us with policy decisions, a concern was raised that we just don't have time for that kind of input. Well, I can tell you, through the hard work of all of the stakeholders, and when they've earlier told you today that they've spent a lot of time on our work groups, they did not underestimate. It became their full-time job, and I truly appreciate their volunteer work for the policy work groups. Their work helped us create great policies, make sure that the policies that the Exchange Board adopted truly reflect the priorities and the values of the community. So I want to make sure that their work is fully recognized. And to date, all 15 policy working groups have been done with their recommendations. And many of those recommendations are in fact reflected in our legislative package before you. We continue to have ongoing advisory committees. We have 3 standing topic-specific committees and 1 general advisory standing board. And those groups will continue their work and will provide valuable input into our process and into the policies and help us make decisions around important questions around policy. I want to share with you additional terrific news in that I want to reassure you that your decision to build a district-based exchange was the right one. In fact, we recently learned, and it's unfortunate, that the federal government cannot provide some options that the Affordable Care Act requires in 2014. But because of your decision to create a district-based exchange, I can tell you that we'll be able to provide options that just don't exist in the marketplace now, and options that will not exist in places where the federal government is facilitating a federal exchange, at least in year one. So I'll tell you about one of those options for small business owners. Right now, you know, as a small business owner, that you have very few options. If you want to offer your workers a choice of all health insurance policies or a choice of all health insurers in the market, you just can't do that. For the most part, to most small businesses, only one option is available: one insurance company, one insurance policy. Well, in October, when we're open for open enrollment with coverage becoming effective in January of 2014, small business owners will have choices. A small business owner could choose to enable his or her workers to sign up for any insurance company that does business through the exchange in a particular level of coverage. Or if the employer likes a particular insurance company but wants to offer workers a choice of an HMO or a PPO at different coverage levels, that employer can choose to do so. Or if the employer likes the current system, one insurance company, one product, the employer can choose to do that. So that's the kind of, those are the kinds of options that we can offer the small business community that are just not yet available in the federally facilitated exchange states. So I thank you again for your leadership around supporting us and supporting a district-based exchange. Now, I want to discuss our legislation, and specifically, I want to talk about premiums. We've all been reading the headlines, especially from our sister state, Maryland, that some insurance companies have filed rates, and some have filed very high rates for 2014. As you know, I've been very concerned about how insurance companies price their products. And we at the exchange made a decision that we're not going to be negotiating coverage or prices with insurance companies. We'll be relying on the insurance commissioner here to review rates to make sure that they're reasonable. With that said, I continue to be very concerned about what prices will look like in 2014. And I strongly believe that the best way to ensure that prices are reasonable is through price transparency. And let me explain what that means. If you force insurance companies to compete for your business by requiring them to put all of their products and all of their prices in one place through our web portal, then you know that insurance companies are going to want to price their premiums in a reasonable way, because the larger insurance companies are not going to want to lose your business by pricing their premiums too high. And insurance companies who want to gain your business, they're going to want to make sure that their prices are reasonable to entice you to sign up for that coverage. So price transparency is the best way to ensure that prices are reasonable in 2014. And this is not theory. We know just by looking at the headlines out of Oregon, another state that was certified as a state-based exchange, their insurance commissioner posted just a sample of rate filings, and within a day or two of the insurance companies refiled their rates asking for lower rates. So we know price transparency works, and we need to make sure that businesses here in the district and people who live and work here have access to good coverage, quality coverage, and affordable coverage. And so by forcing insurance companies to compete for your business, we can ensure that prices in 2014 are reasonable and that people and businesses can actually afford health insurance. I also want to mention that the decision to create one big marketplace, with your support, of course, will mean not only premium prices will be reasonable, but also it will mean that for the first time, small businesses and individuals will have options that just don't exist today. they'll be able to choose any insurance company, any health insurance policy of their choice. They're not going to be limited. So we're not closing the market. We're not limiting the market. We're trying to make one big market so everyone has the same access to coverage and all of the products. In fact, we want to make sure that there is no dual markets where the haves have better coverage and people who are getting tax credits may not have the same level of coverage. We want to make sure everything in the private health insurance market is available to everyone, no matter whether you're receiving tax credits or not receiving tax credits. We want to make sure you have options that don't exist today. And I strongly urge you to pass our legislation without changes to the benefits, to the consumer protections, or the big marketplace transition that we have. As Dr. Achter noted, our legislative package is a result of many compromises. It was essentially put together through all of the policy work groups we've had with diverse stakeholders. This is not a traditional agency bill where we're coming to you and it requires lots of changes. This bill really reflects the extensive work that hundreds of people who've participated in our policy groups have contributed. And I should note that these work groups have met more than 50 times. There have been hundreds of people participating. It really reflects the compromises that the stakeholders have made, and I strongly urge your support and the passage of the bill. Thank you, Madam Chair.
Thank you, and we'll have 10-minute rounds of questions. Councilmember Grasso, I want to take this opportunity to commend you both on all of your work. You mentioned that this has taken place in a short time frame. It has been in a 6-month time frame, even less than that for Ms. Kaufman. So she's really hit the ground running, and we know it's a lot of work. I want to commend you, the entire executive board, as well as the advisory boards and all the stakeholders and working groups that really made this happen. And, you know, we don't discount the long hours and the work that still has to be done. So thank you for that. Some things came up, and it's really good news that you have the 4 insurance providers that have agreed to join the exchange, and that is good news. Now, they've agreed to join the exchange with the legislation as is, or what have their caveats been? Have they mentioned anything with regards to their being outside of the exchange as well, or their letter of intent states that they're going to do that?
Yes, Madam Chair. We'll check to make sure that the letters of intent are not confidential. For some reason, I don't think they are, and we're happy to provide the notifications that we've received. The letters focus on their commitment to participate in the exchange, and also 3 out of the 4 insurers told us what their intent is in terms of selling a high number of policies and products in various levels in bronze, silver, gold, and platinum.
We heard a lot about the Insurance Commission and rate filings, and that was a lot of concern. I mean, when this is the Affordable Care Act, that's the most important thing. We want to make sure, well, of course, quality, but we want to make sure it's affordable. And we've heard a lot of criticism about the Insurance Commission, about the rates, about the process in which the rates are reviewed and filed. So I want to ask you, one, have any carriers filed their rates, or when do you anticipate them filing their rates?
We initially asked the carriers to file their forms and rates by mid-May, May 15th. We received a request from a major carrier indicating that they needed extra time. So to accommodate their need for additional time, we decided to extend the filing deadline until the end of May.
Is the Insurance Commission, one, aware of your timeline for that?
Yes, we work very closely with the Insurance Department, Commissioner White and his team, to make sure that the timetable that we need to follow in order to make the IT piece of this work also works with the resources and the priorities that the Insurance Department has. And so in extending the deadline, we worked very closely with Commissioner White, and the extended deadline will be in the carrier manual update. We have a carrier manual, kind of a guideline that we've issued, provided to all of the insurance companies to help them conform their products and rates and comply with the district's requirements as well as the Affordable Care Act's requirements. And to draft that carrier guidance, we work very closely with the Insurance Department.
So DISB is aware, and you're confident that they'll be able to review within your timelines?
Yes, so the necessity behind our legislation is in fact driven by those timelines. So by the end of this month, insurance companies are asked to file their products and their rates for approval. By the end of June, all of those products and rates must be opined on and approved or not by the Insurance Department. In July, insurance companies have to file their products and their rates into our IT portal. In August, we'll be testing to make sure that all of the information was filed, uploaded correctly, that it transferred correctly. We'll be working very closely with carriers to make sure all of the information is accurate.
And you, I don't know if you were here, I'm sure you were, Councilmember Catania's proposed amendment. Are you aware of any other states with a rates commission or a public comment period? And how would that work in the district? Would you recommend that? Do you have an opinion on that?
So if I can put my former superintendent of insurance hat on, I do believe that it's critically important for consumers to know that the premiums that they'll be paying are reasonable. And when you look, even if you look at a rate filing, and you've seen them, they're hundreds of pages long, you really do need to be an actuary to figure out whether something makes sense or not. And even if you hire an actuary, you know, you can get 10 of them in one room and they'll give you 10 different numbers and they're all reasonable. But in 2014, the world changes. We're all required to be personally responsible. We have to have health insurance under the Affordable Care Act. But we also deserve to know that the premiums we're charged are reasonable, that we're not being ripped off, that the premiums are justified. And so I firmly believe that rates need to be scrutinized carefully by regulators. And because at the exchange we're not going to be negotiating rates, we will be relying heavily on the insurance department and their reviews. Now, of course, we'll have our consulting actuaries providing feedback, but ultimately we'll be relying on the scrutiny and the comprehensive review that Commissioner White and his team will have to do on the health insurance products and rates.
So you feel that a public comment or that would be a better process for DISB to do?
Yes, I'm sorry, I forgot the first part of your question. Thank you for asking it again. So under the Affordable Care Act, all states that have been declared to have effective rate review, where the federal government isn't looking at the filings, essentially have to have a public comment period of at least 30 days. So that's one of the minimum federal standards. I think that extensive scrutiny over rate filings to make sure rates are reasonable is critical, and I also believe that public input is very helpful. When when individuals are required to buy coverage, they should be able to have a say on the price, and they should be able to provide input. It will be especially critical in 2015 and 2016. You know, in 2014, all products will be new unless you have a grandfathered plan. So relying on expert reviewers at the insurance department is critical. After that, as prices change annually, small businesses and individuals will want to provide input, and there has to be an effective way for them to do so.
So with the August 1st deadline to be met, could you just please explain what needs to be in place, one, and is there any decision that we've been postponing due to federal regulation or federal guidelines that need to still be discussed?
We're not waiting for the federal government, period. So if there's no information, no details, we're moving forward. We cannot wait for our federal partners. Now, they've been great, and the federal government has provided a lot of guidance and a lot of information, but I'll give you an example. On IT, they still have to issue some guidance. We're not waiting. We're making certain assumptions, and we're moving forward. We're documenting those assumptions, but we're not waiting on the federal government. We want to be the leader. And we want to make sure that on October 1, we're open for business, and that's our mantra.
And so for one more timeline, August 1st, what needs to be in place by August 1st?
Yes. So by the end of this month, rate and form filings must be done with the insurance department by insurance companies. By the end of June, those forms and rates must be reviewed. As you know, Madam Chair, forms are essentially products. So to make sure that health insurance products comply with the Affordable Care Act and the district's requirements. So by the end of June, those products and rates have to be reviewed and approved. In July, and carriers have the whole month of July to load that information into our web portal. And the federal government did ask us to have all of that loaded by mid-July. We pushed back. We wanted to give our insurance companies the maximum amount of time to load all of their products, especially if it turns out that one insurance company files 150 different products. They need time to load their rates, to load their products into our web portal. In August, we at the Exchange will be looking at that information to make sure that it was loaded properly. We'll be working very closely with each of the carriers, as we are now, to make sure all of the information is accurate and testing it out with the carriers.
Thank you. And you did mention the IT will be, a dry run will be tested August 1 too. Well, you said in August, not by August 1.
Yes, the carriers have to load their information, their products, and their rates by August 1, so we can start testing those products, those rates, to make sure everything is accurate in August, throughout August.
Thank you. Councilmember Grasso?
Good afternoon. Good afternoon. Congratulations on your Wave 2 accomplishment. That's a huge deal. And certainly puts you on the right path, I think, to winning. I have a couple of questions for you with your insurance commissioner hat still on, if you don't mind. Because I think there's been a lot of discussion today around putting rates out there in the public and the process and all this stuff. And it is complicated, as you mentioned, when they do form filings. It's the actuarials, like you say, you get 10 of them in a room, you might get 10 different opinions on what's right and what's wrong, and we deal with this on a regular basis. But what did you do when you were commissioner to protect the information? Like, what are your obligations as the government in this situation? This is a competitive marketplace. There's accusations all the time that there are anti-competitive activities happening on the private side. So what is the government's responsibility here, and how do we do that when you're doing this rate review? I mean, I think clearly you can publish the final price. That's obvious. But what about the process going forward? And especially in light of Councilmember Catania's wanting a hearing in this process, how does that work?
So under the Affordable Care Act, there are certain aspects of a rate filing that you have to make public so consumers could weigh in and provide you with feedback before a final decision is made. Some of those basic requirements are in the final regulation that CSIO had issued on effective rate review. So a lot of information is already public. Before the Affordable Care Act, some states essentially made pretty much almost all information public, even before final decisions on rates were made. So I can tell you, in Maine, there were certain exceptions to public information, HIPAA-protected information. When you have hemophiliac claim in a small market, if you publish the claims data, you can figure out who it may be. And so you want to protect certain information. The other information that was protected was the negotiations over reimbursement between the carriers and providers while they were still ongoing.
Right.
So that was always kept under seal until the final contracts were signed. But pretty much everything else was public. In fact, not only was it public, but it was posted on the website for the insurance department up in Maine. So anyone could download all of the data, look at all of the assumptions for medical trend. It's all about predicting.
Right.
Your premium is how well can you predict your claims in the future. So all of that data was public, supported through the website.
Did you see that in those states where there was that kind of public information, did you see any impact on the price? Did the price go down drastically or in any way at all because of the public sharing of this information?
So in the states where the insurance regulators had prior approval, that's correct. So sometimes, a 25% rate increase would be filed and a 10% would be approved. And that's the case in states with prior approval. Sometimes, you file the 10% and you get it approved. As long as the insurance company makes its case. The point I was making earlier about driving prices to make sure that they're reasonable through transparency is that for the first time, if you post everyone's product and prices on a website, that price transparency will force insurance companies to compete for your business. They're going to want to price their products appropriately. That's separate and apart from having a regulator review rates to make sure that they're justified, they're supported, they're reasonable, they're sufficient. But the private market competition and through price transparency is what I firmly believe will help keep premium rates reasonable in 2014 here in the district.
Do you have any other companies that are coming into the city that you know of that are looking at coming to the market? You mentioned the 4 that we have here, but one of the issues in D.C. has always been a lack of desire to come and play here for lots of different reasons. So do you have any other bites?
We are actively reaching out to other insurance companies. I think earlier today you heard that one company is in the market now and is not going to stay. That's not the case. I think the reference was to Cigna. Cigna is not in the individual market here. They're not in the small group market. They have a larger group market presence. So we have reached out to Cigna on their individual side. They're actually building an individual business. They're only participating in one state-based exchange in 2014. So we've reached out to them to see what we can do here to get them into our market. We've also looked at all of the carriers in the Maryland exchange and figured out that we have all 4 of them. So they're no different than what we have. Our goal is, and in fact, it will help us recruit insurance companies if they're all competing on the same level playing field. If there's one distribution channel, meaning through the web portal, it will be easier for companies to penetrate this market. As you know, when you're trying to enter a new marketplace, you need a lot of cash, a lot of investment. You have to create relationships with providers and brokers and other service providers that you may not have. So it's very hard for an insurer to enter a market. having one big marketplace will make it a lot easier for other insurers to come. In addition, there'll be a multi-state plan, which OPM has governance over, and we've been informed by OPM that we will have at least one multi-state plan. We do not yet know the name.
Thank you. I understand. I think there's only 2 of those anyway, right?
Correct, 2.
But do you have? Are you nervous at all that is the congressional staff going to be required to come in here? The high-level congressional staff. What's the barrier for them to have to come in here? They have to live here? Is it just because they work here they'll be required? Because I believe there was a law passed that they would, as part of the ACA, be required to use an exchange.
Yes, we're still waiting for final guidance from the federal government on which congressional staff would be required.
I think it was in the law. I think it's chiefs of staffs, and anybody over making a certain amount of money, something like that. Committee directors maybe, or not, I'm not sure, but it was in the law.
That's correct. So there's some ambiguity as
to... So how will you, like, once you get the direction, how will you govern that? You know, like, how will you make sure that is that your problem, or is that someone else's problem? Because it's the law. I mean, they're going to have to...
Correct. We're going to make sure that the district's marketplace exchange serves everyone equally. We welcome congressional staff. We welcome members of Congress. We welcome the first family to come in and get coverage through us.
I just think that's... I guess when I'm thinking about the exchange, I think about these small off things a lot. You know, one of the things I worry about also, I think it's interesting. One of the requirements in the ACA is that subsidized products are not allowed to have abortion coverage under them, and that becomes a very complicated thing to implement. What is the plan? Is there, in these 150 products, are these carriers going to actually offer? Are you going to make space for them to offer? Are you going to encourage them to offer alternative plans for people that aren't in a subsidized product to actually have that coverage?
So I'm not sure how many of those, and the 150 products was just one carrier. Others will have additional products. The product filings are due by the end of May, so I do not yet know what...
Did you talk to them about that and your guidance? Because I think that's a serious concern here in the District of Columbia, and maybe not in other states, but the federal government put this in there that said that you can't use this subsidized money to pay for this service, and it's something that concerns me a lot. So I would hope that you would be proactive on it and put in the guidance and say that they should cover. Most of them offer some product line now that has that coverage. The question is now, are they going to just say, hey, that's too much? It's already complicated enough, forget it, and then folks aren't going to be able to get that coverage here?
And as you know, the National Association of Insurance Commissioners developed some guidelines for the carriers and how to make sure that funding is segregated into appropriate accounts to ensure compliance with the Affordable Care Act. And Commissioner White's staff works very closely with the NEIC, and of course he's a member. And so we'll make sure that we do what we have to do to ensure full compliance with the Affordable Care Act.
I wouldn't ask you this as, kind of intensely if I wasn't, if you close the outside market, you then eliminate the option for women to have those reproductive health coverages that are important if you don't then make it an option in the exchange as part of the exchange product offerings. Right?
There are very specific federal ACA requirements around premiums.
I'm talking about abortion coverage, and they're actually not good for this coverage. They're not helping, right? It's on our backs to make sure that we offer these products and that insurance carriers. If you close the outside market, it becomes a bigger burden. And I'm just wondering, have you thought about that? Are you going to plan for this? What's your thoughts?
Yeah, and I apologize. I thought I was trying to answer the question earlier. So the Affordable Care Act requires carriers who provide benefits for abortions to segregate the premiums that pay for those benefits. The NEIC has developed some guidelines to help carriers comply with that. And through the insurance department here, we're going to make sure that the carriers here are in full compliance.
And offer it.
There's no prohibition, right, on offering.
Actually have, encourage them. I'm not saying mandate it, but you could make it easy on them to do this. This is, if you're closing the outside market, this is a big concern, right?
So what we can do is, it's not a policy issue that has come up in any of the policy groups that we've had. We still have a number of policy areas to get feedback from various stakeholders on, and I can add this particular issue to
Thank
the
you.
list.
I'd appreciate that, and I'm sorry to run over, but this is something that's extremely important to me, to ensure that we still have this option in the district, in light of the fact that we're likely going to close the outside market. I don't want to put women in a position to not be able to have this coverage. So I'd appreciate if you would put a spotlight on that in your policy discussions and make sure that we have it. Okay?
Absolutely, and I would just note, one of the members of our standing advisory board is actually from the Women's Law Center, and she testified earlier, and
She just mentioned maternity benefits.
I don't think she mentioned...
Not pregnancy termination.
Right.
Not infertility benefits either.
I would suspect if this was an issue, a significant issue, concern, it would have been raised, but because it was not raised, it is definitely something that we will ask policy
It's a
work group.
significant issue that needs to be raised, and it is a concern of mine, and it's important to me that we get this taken care of. I'm inclined to support I don't have any more questions, but if I can just say something real quick before I leave. I'm inclined to support the chairwoman in whatever she decides to do here. I think she's thought through it. I think she's got a good eye on this stuff. But, and I appreciate that, and I think there's a lot of hard work that's gone into this, and we need to move it quickly, and I'm respectful of that as well. This issue, though, it'll stop me from voting for this. So you might want to put a plan together, send it over to my office, maybe pass it by some folks that actually care about it. There are people in the city that work on this every day, and it'd be important, I think, if we could really address it. So I will put that on the table right now, that I'm going to vote for whatever she says to vote for, but I have to have an explanation on how we handle abortion coverage in the District of Columbia. Okay?
Great, thank you.
Okay?
And I did all that, Councilmember Grosso. I would like, but I'm sure insurance companies can offer a plan that has that coverage in it. But as it stands now, just to be clear, that's not a part of the 10 essential benefits under the ACA, correct?
Correct.
That's correct.
So it's not guaranteed, but I'm sure companies will offer plans that provide that service.
And they do right now, but if you close the outside market, and then it just becomes that much more complicated in the exchange because of this requirement put on by the government. And all I'm saying is, show me a plan before I have to vote, so that I can support you. Otherwise, I'm going to be really hesitant, because I don't want to limit, women's choice in the District of Columbia.
Right, so, it would follow, Councilmember Grosso, I guess, if none of the 4 plans offered it, then why would it, if 3 if they don't offer it, why would anyone want to offer it? I'm sure it's an additional cost to offer that. So if I'm with the company and I see that 3 other companies aren't offering it, then what would give me incentive to offer it to, as well?
We can also, I can also find out from the 4 carriers what their intent is with their product filings, even if they have not filed their products. And they're filing their products for all 2014. So we'll know from them what they intend to do.
I appreciate that. I really do. And, like I said, I'm supportive here. I want to move forward. I think I am still skeptical, but that's just my nature. I'm a conservative person. I don't like to be out there the number 1 out of 18 states that's doing something. I think that's kind of a shaky ground to be on. But nonetheless, I see that a lot of people are supporting this effort, and that we got to move forward. So my fingers are crossed.
Thank you.
Thank you.
Thank you, Councilmember Grasso. To continue with the funding portion, after January 1st, 2015, we'll have to be self-sustaining with the exchange. And what are we going to have opportunity for any additional federal funding, or are there any proposals or thoughts on how we're going to fund the exchange after all the federal subsidies have subsided?
Yes. So we have had a policy working group on sustainability coming up with funding options for us. They recently concluded their work. Their full report is going to the board at the next board meeting. There'll be a vote. My understanding is the Sustainability Policy Work Group reached consensus on their recommendations, and at a very high level, essentially, they want us to take a look at potential new revenue that will come in as a result of more people being coverage, revenue on the premium taxes side. And if that's not sufficient, or if that's not practical, then to do a market-wide assessment. And they calculate the market-wide assessment would be less than 1%, so 0.7% is the calculation that they came up with, which is much, much lower than the fees being charged in the federally facilitated exchanges.
If you could walk me through now the IT, the next steps for the IT infrastructure. You did state that you can't, can you really do anything with IT until all the filings take place? Or is that going to be the benchmark to test out the filing, the IT infrastructure?
Every day we're doing significant things, building the IT. On the city part, it has to, the connections have to work, the connection has to be secure.
So what are the next major steps for the IT infrastructure prior to August 1?
Yes. So the next major step is we asked the federal government to be the first state in the Wave 3 testing. The federal government is continuously updating its IT software, testing the connection between states and the federal hub. And my understanding is their final version, the 1.5 version, will be ready the third week in May, and we've asked to be the first state tested under their final software. We continuously to work on very detailed documents. Essentially, in addition to the actual testing of the connection, the federal government is looking at all of our documentation and our work plans to make sure every component of the IT system, that there's a plan, the plan is solid, that if there are any risks, we can identify them and mitigate them. So that's ongoing as well. The next big thing with us will be to test out how well the connections work with the carriers, as well as with insurance brokers. We'll be testing our portal. And one thing I forgot to mention earlier is that we believe that it is critical for people to have access to brokers, and that is why in our IT design we're developing the system to make sure that small businesses and individuals can continue working with their brokers. In fact, small businesses that have brokers now, they won't have to do anything. We'll have a special web portal just for brokers, so the broker will come and shop their business and help them enroll and choose. We also believe that small businesses and individual purchasers who are not working with brokers, if they want to, they should have easy access. So we're building that.
I was going to ask about consumer testing.
So we're building that search engine to help consumers find brokers, and also if consumers just want to enroll themselves, they can do that. We are doing.
Will there be testing for consumers before October 1?
Yes. So we'll have various opportunities for testing, both with brokers, with carriers, with assisters, and in-person assisters will be diverse members of the community, which will include faith-based groups, community health centers, and other folks that will help educate people and help them enroll. So there'll be extensive testing with the sisters as well.
Thank you. It was an earlier testimony about education for small employers and brokers. I believe Barbara Lang from the Chamber said that she still wants that component out there. Is there any plan for any outreach or educational plans with our small businesses?
Yes, absolutely. As you know, the federal regulations prohibit us providing assisted grants to associations that have either insurance companies or other entities on their boards. So we unfortunately cannot do in-person assisted grants with the D.C. Chamber of Commerce and some of the other business associations. Given that, we're fully committed to partnering with the D.C. Chamber and other business groups to help us educate and to help us enroll small businesses. And so I've had discussions with Barbara Lang to help figure out how we can work together.
There was also concern, an advisory neighborhood commissioner testified and stated, and I know there was a plan to engage the ANCs across the city. Each of them represents a constituency of about 2,000 residents, and that's across the city. In terms of, they want to help in terms of outreach and letting people know the exchange is there for them. If they're uninsured, if they're underinsured, if they're overinsured, what have you. What are we doing to engage the ANC, the churches, what have you? She mentioned that there has been no contact, and I know we mentioned a fact sheet or education or outreach interaction with the advisory neighborhood commissioners. So what's going on with the ANC?
So at the last meeting that the mayor had with the ANC chairs, he had asked me to present information about the exchange, which I did. And there were some very good questions. I encouraged the ANC chairs to reach out to us, to my staff and myself at the exchange, and to include us in any presentations or opportunities that they're establishing. I welcome the invitations to come speak to particular blocks even. And Dr. Akhtar has been, he does at least 2 or 3 events, probably more a week, and we have a full board of volunteers who want to be out in the community helping to educate. So I truly welcome the opportunity to get these invites. And if it cannot be me, it will be a board member who goes out.
Because what I would suggest, I believe there is an ANC website, and there's a contact number for each advisory neighborhood commission, and maybe if that could be coordinated through Gottlieb Simon, who is the director of the office of the ANC, that maybe he could even disseminate information. That would be a way to reach a lot of residents in the District of Columbia, for the exchange. So we really want to get that out there. Has there been a fact sheet that's been developed, and if I could just see a sample of what's being handed out in the community?
Yes, we have several.
We have several fact sheets, and we have also spoken to as a faith community. We were at Reverend Wilson's church. We were at Reverend Tucker's association with different ministers. I think you were at one of the meetings yourself at this church. You had just left before we showed up. And we continue to work with all segment of our community to make sure that they have the information. We want to be close enough to enrollment so people pay attention to that this is going to happen. And we also want to have accurate information available. So we will see what they should be looking for and what they should be doing. And so that's where we are. General information is being provided, but specific information will be coming within the month.
Someone mentioned before the vote took place regarding the transition, they weren't able to get through in a teleconference. Was there some technical difficulties with the teleconference?
Yes, we had the teleconference set up all, and the board members, of course, joined in from different locations. Staff was in different locations, and somewhat malfunction took place. This is the only time this has happened. Now we double-check everything before anything else happens. So this particular individual was not able to tap in by the time. It was a very short board meeting, 15 minutes, because everything that we do, I want to present this, everything that we do in the board meeting is presented in a public meeting first. So everybody got a chance to think about it, and then 3 or 4 days later there's a vote. So people could weigh in. So that's the way this was done. It was a public meeting, issues were presented, and then we said the vote will take place on this date. And on that date, this malfunction took place, and unfortunately people couldn't hear. But that's the only example where we had received a complaint.
On the day of the vote, the malfunctions.
And for that reason, Madam Chair, we took a subsequent vote on the entire legislative package, and we gave the public in person an opportunity to weigh in. Although we were assured that the initial call was valid in terms of public disclosure, we wanted to make sure that anyone who wanted to weigh in still and again, and there have been a number of opportunities that they had a chance to do so.
Thank you. Had there been a large number of persons that stressed they couldn't get through, or was that a single?
This is the only time that I'm aware of. I don't know, maybe the staff know anybody else. No.
The grandfather provision, and there seems to be some confusion or some things that aren't clear about companies who would be, small businesses who would be grandfathered in, that could hang on to their plan that they have. There's been some statements that say if you make a change, if there's a change with regards to your premium cost or benefits, you would still, if you meet that date of March 2010, you can still keep your same plan outside of the exchange. What are the provisions? Do you have the specifics on who is eligible to be grandfathered and who isn't, and how much of a change could a small group make to still qualify for the grandfather provision?
That's correct, Madam Chair. So if you've had health coverage as of March 2010 and you have not made substantial changes to it.
What are substantial changes?
Substantial changes are defined by the federal government. It is not up to the state or any jurisdiction to define those. They're strictly defined and governed by the regulations that the federal government has issued, and we can provide those to you. So some changes are allowed, but there's a threshold of the kind of changes that you can have. Obviously, if you're a small business owner or a large company and you want to make sure you have a grandfathered plan, you can still hire workers and add new people. That's not a substantial change. But all of those standards are, in fact, in federal guidelines.
Well, it does, and I'm sorry, I see the significant changes here, what you cannot do. And there are a lot. So do you, and from what I see, it says you cannot significantly cut or reduce benefits with regards to diabetes, HIV/AIDS. You can't raise co-insurance. You can't raise co-payments or significantly. The key word is significantly, and I don't know, well, they go into detail with it. You can't significantly lower employer contributions. You cannot add or tighten an annual limit on what the insurer pays. You cannot change insurance companies. So that's a lot of what you cannot do. Do you know how many companies currently, how many small groups would fit into that grandfather provision?
I can tell you through conversations with insurance companies, about a third of the marketplace they would consider grandfathered. It's really up to the insurance companies to continue offering those products and to continue to support those products. But according to industry estimates, it's about a third. We do not have direct information about that.
And someone mentioned that you even have to request, even if you're eligible to be grandfathered, someone mentioned you still had to request to be grandfathered.
Yeah, I'm not sure that that's an ACA requirement. I think that's a carrier requirement, but we'll double check that for you.
Okay. And, well, I think I asked that. The plan levels, could you go into detail on the different plan levels? There are going to be 4 plan levels, and if you could go into detail as to what those plans will provide.
So all health insurance has to have essential health benefits, which we talked about earlier, hospitalization, maternity coverage, and others. The plan levels, there are 4 what the Affordable Care Act calls plan levels. So there's bronze, silver, gold, and platinum. And those categories are really designed to help consumers, individuals, and small businesses better shop. So if someone wants very low deductibles and out-of-pocket costs, then they would be looking at a platinum level plan. If someone else doesn't mind higher deductibles, higher out-of-pocket costs, and the trade-off is lower premiums, then they would be looking at a silver or a bronze level. But that's essentially how it works. The different metal levels are really, that's really an aid to shoppers to help them be smarter shoppers.
And how do you plan to monitor between the different levels to ensure that they're still offering the benefits that they should be offering?
So all of the health plans have to be submitted to the insurance department for approval. And so only the ones that get approved as complying with the benefits and all of the other requirements will get approved. And we're relying on the insurance department to do market surveillance to ensure that essentially promises are kept, that benefits are paid when they're supposed to.
How many small groups do you expect to purchase renewal policies prior to the date of the transition? Do you have any estimates on that?
We do not have good data on that. As you know, our Standing Advisory Board recommended a transition plan to us, which we then adopted, which is reflected in the legislative package. And their recommendation to us is that in 2014, newly insured small businesses who didn't offer coverage before will be able to come to the Exchange web portal and select coverage and enroll, either working with a broker or directly themselves. And by the way, there's no extra cost for them to work with brokers. The premium is the same. And then in 2015, the proposal is to have small business coverage renew through the web portal. So essentially the same idea. Brokers will go to the broker web portal, get the best prices, best options for their clients, or if a small business is not working with a broker, they can go directly to the web portal and choose.
So how will the single marketplace safeguard premiums for small group and individual insurance plans?
So there are 2 major ways that we believe one big marketplace will keep premiums reasonable. One is the administrative cost savings. We commissioned Mercer actuaries to provide us with information about administrative cost savings that are possible when you only have one distribution channel, essentially. So if you think about it, there are different ways that insurance companies currently sell products, and it costs them money, different IT systems, different personnel. A lot goes into supporting different products. If the products are all sold through a web portal, it's much more efficient for the carriers to support that distribution channel. So the Mercer report, which is still draft, which I can provide to you, shows that there are broad categories of administrative cost savings to be had when there is one big marketplace. In addition, and more immediate, we believe that through full price transparency, insurance companies will want to compete for your business. They will want to make sure that their prices are reasonable so they can attract customers. So we believe it's critical to have one big marketplace to achieve reasonable premiums in 2014 and onward.
With regards to the habilitative services, it seems to be really broad. Is that, is that the same as the federal requirement, or are we broadening, making it broader than the federal requirement in this legislation?
So one of the first policy work group we had was looking at the essential health benefits package to see what areas we need to clarify and fill in if we were missing certain things. One of the options outlined, it was not a consensus option, but one of the options that policy work group provided to the board, which the board adopted, was to clarify the definition of habilitative services to include treatment for applied behavioral analysis for autistic children. And that's a clarification. It's not a new requirement. It's a clarification that, in fact, habilitative services benefits include that particular service.
So with regards to the plan levels again, how will insureds be able to monitor changes in provider networks or drug formularies or what have you in real time? How are the consumers going to be able to monitor that?
So we will have a lot of information on our website, including initially links to insurance company websites for provider networks. We will also have an approach I call secret shopper, just to make sure that if a provider's name is in a particular network, that in fact that provider is in the network and accepting new customers. And we plan to work very closely with insurance companies to make sure that their information for consumers is up to date. Also, I forgot to mention earlier that we really want to encourage as many innovative products as possible. So that's why we did not limit the number of products to be sold through the exchange. In fact, we said to the insurance companies, offer as many products as you want. We, of course, will have tools for consumers to help consumers shop for the best available option. If a consumer wants to see everything that's available, they'll be able to do that. If a consumer just wants to see the top 5 options that fit that consumer's specifications and needs, they can do that as well. But we want to encourage all products and product innovation, and in fact, on top of the essential health benefits, our approach is to allow and encourage additional benefits to be offered, like acupuncture, which is not currently in the essential health benefits, but many consumers want that benefit. And we want to encourage carriers to offer as many innovative products to consumers as possible. The other point I wanted to make, we've learned a lot from the Massachusetts experience, especially around the needs of the small businesses. Small businesses, more so than individual purchasers, like lots of options and lots of product variations to fit their budgets and their preferences for benefits. And so we're very aware of that, and that's why we wanted to encourage insurance companies to offer as many products as they want to offer, to make sure that there is a product out there for everyone.
If the district government were a part of the exchange, would that make it more attractive for small businesses to go through the exchange at that point, if the pool increased at that great number, about 35,000 employees. What would happen with that?
So, under the Affordable Care Act, that is having large employers, which the district government is not an option to states until 2017. At that time, it will be up to you and other council members to decide whether the exchange marketplace should be open to larger employers.
And what happened with the timeline, the 2-year transition? And how did it get from 2016 to 2015? How was that decision reached?
So we had asked our Standing Advisory Board to take a look at the transition and make recommendations. And so the Standing Advisory Board on the individual market side recommended that all renewals and all new purchases should be through the web portal in 2014. On the small group side, the Standing Advisory Board recommended to us that the transition be different than individual. So any business without insurance essentially would go to the web portal and have all of those options available in 2014. Any business that has insurance now and wants to stay with the same insurance company or wants to switch to a different one, they can do that outside of the web portal in 2014, but then in 2015, the renewal would be through the web portal.
Well, I don't have any further questions. I look forward to the vote on the legislation. As I stated, the emergency will be next week, May the 22nd, and I look forward to working with you between now and then to come up with what we need to have a very successful exchange. So I look forward to the vote on May the 22nd, and thank you all for staying for the entire testimony, and thank you for your personal testimony. This concludes today's Public Oversight Roundtable on the implementation of the district's Health Benefit Exchange. I would like to thank all who came to testify today, and as a reminder, the record will remain open for 2 weeks and will close on, well, actually for 1 week. No, that is 2 weeks still, May 27th. And we'll close, it will be exactly 2 weeks, Monday, May the 27th at 5:30 p.m. The time is 6:05 p.m. and we are adjourned. Thank you.